Well, good morning, everyone, and welcome to the second Food is Medicine in Oncology Care Symposium. Whether you're joining us live here in DC or via the virtual live stream, thank you for making the time to be part of this important conversation today. I'm Kristen Sullivan, Director of Cancer Wellness at the American Cancer Society, and ACS is very proud to be sponsoring this symposium for the second time. We've got a really full and exciting agenda ahead, featuring many of the leaders in food as medicine, and we're really excited for the day. To kick us off, I am really pleased that we've got two members of the ACS executive team to offer some welcome remarks. Our CEO, Shane Jacobson, and Chief Patient Officer, Dr. Arif Kamal. Dr. Kamal, I'll just turn it over to you. Thanks.
Well, good morning. It's such an honor and truly a pleasure to be with all of you, not only some of the top leaders in the country, 100 of you here in the room, but nearly 1,000 online as well. That really symbolizes to me kind of this collective passion around food as medicine specific to oncology. As an oncologist for the last 20 years, I reflect on sort of where our field has come. In particular, sometimes the only tools we had in our toolbox historically had been things that are really after the biology of the abnormal cell. And while that remains important in terms of R&D pipelines and other things that we do, we have so much more choice today than we did when I was training. This real appreciation for the whole person and every component that can both help them thrive or be a source of suffering, that can help them with the addressing the biology, can help them with their communities and how they live as a whole person, is such an amazing appreciation that we're all having, and you guys are the leaders to do that. So as the American Cancer Society, we're here as much as a convener as we are here to be a learner from all of you about what is our highest and best use, each of us collectively and individually, in this really important movement. I think as I've was recently in clinic talking to patients about this experience we call cancer, that for a long time the idea of prevention and early detection, and when things would happen that we didn't expect, that there was not a lot of agency that people could feel, right? Patients walk into my clinic and say, why did this happen? What could have I done differently or better? I wish I would have known that there were things I could have done over the course of my lifetime. And indeed, the concept of, genetics that one cannot change, or, bad luck that sometimes we run into, is not one that's very engaging or empowering. And yet what all of you symbolize today is that there is, in fact, great hope for the ability to engage and empower people to control their outcomes and control their future. And really, short of us curing cancer, the way we really need to focus on is by bending that incidence curve, right? For those of you who realize, and Robin Yabroff's here and some great scientists from ACS, what we continue to show, right, is remarkable progress, reduction in mortality of 34% over the last 40 years. What we have not yet done, right, is bend that incidence curve. Age-adjusted incidence, sure, for my epidemiology colleagues is going in the right direction, sure. But the absolute number of people being diagnosed with cancer in 2000, when I finished part of my training, at that time was 1.2 million new diagnoses per year in America. Today, we're now reporting nearly 2.2 million new diagnoses per year in America. So that's an additional 1 million of our family, friends, neighbors, and community members who are hearing those words, "You have cancer." And while mortality, fortunately, remains somewhat stable, that number growing by 1 million annually per year is completely unacceptable. We all agree. And so then the question is, what do we do about it? And I really appreciate all of you guys coming together here to start to talk about that conversation. And I want to commit to you this: the American Cancer Society is one in this space. We continue to want to be a good force in this space as well. But I need your help in trying to figure out how we can best show up in this space and be helpers to all of you in the great work that you're doing. And I look forward to your ideas. You've got great leaders here in the room from the American Cancer Society. I want you to share with them your ideas and thoughts. And as we go into our strategic planning, hopefully that will inform a little bit of how we think of the future of ACS. In addition, I want to thank those who helped plan this. I know this has been several months in the planning. So if you are part of the planning process, would you mind standing to be recognized? Fantastic. And then lastly, a little birdie told me that today is Kristen Sullivan's 19th anniversary to the date of starting at ACS. So thank you, Kristen, for your leadership. And with that, it's my privilege and honor to introduce you to Shane Jacobson, our, I would say, newish CEO at ACS, and really a wonderful champion for the work we do in patient support and the work we do here in the mission, and a great champion for cancer prevention as well. So please come up here, Shane.
Thank you. Good morning. I don't know if that applause was for my introduction or for Arif, but let's give it up for Dr. Kamal. Thank you for the kind words. I'm very, very excited about the future of our work in cancer. We hold very close to our hearts the why we do this, the why we do this work, the why we gave our most precious asset, our time, to be here today, whether it's in person or for those of you watching from home or at work. And I'm really quite excited about our future because I firmly believe it's not a matter of if we can ultimately beat cancer. It truly is a matter of when. And tackling an opponent that is as significant and as tough to beat as cancer means we have to out-collaborate the competition. We have to out-collaborate what we face. And just in the moments I've had with this group as we've gotten started today, I can see that collaboration is one of our superpowers. It's certainly one of our attributes. And as we do this work together and we move from this point of if to the point of when, and we hold those whys close to our heart, just know that every ounce of effort we put into this work together is moving us closer to when. It's shortening the distance between if and when. So as you lean in today, hold those whys close to your heart, close to your mind, close to your soul. Bring those whys into the room with you. If they're not already here today, please bring them in with you. I want to thank again Dr. Kamal for setting the stage. His points were spot on, grounding us in why this conversation today matters, why it's so deeply personal to the American Cancer Society and the ACS Cancer Action Network, and to patients and the families and the caregivers we serve. This is the second Food is Medicine in Oncology Care Symposium that the ACS has supported. And I can say that the momentum behind our movement is energizing. I feel that energy in the room today. I don't think at all we're tampered down by the weather outside of the room here today. It certainly isn't going to dampen our enthusiasm. And based on the weather prediction, I understand sleet, so it's not going to freeze our enthusiasm, I don't think, either. For those of you at home in, I don't know, Florida, Southern California, we may envy you here at this moment. And we know that this interest speaks volumes. As Arif mentioned, there's more than 1,000 of you, both here in the room and watching today, joining us together, because you share in the belief that nutrition itself plays a critical role in the cancer journey. Your presence is powerful. It sends a message that this work matters, and the field is certainly ready for progress. At the American Cancer Society, we're committed to leading. We're committed to helping. We're committed to sustaining and collaborating to build on this momentum. Food is Medicine is cancer care now. It is cancer care of the future. But we know this isn't something that any one organization alone, nor should it be, can tackle and solve. The work is bigger than any one of us alone. The American Cancer Society will soon celebrate its 113th anniversary. 113 years as one of the nation's leaders in the cancer fighting battle. We're the only nonprofit that tackles the full spectrum of prevention, early detection, treatment, survivorship, innovation, research, and advocacy. We deliver on our promise, not at the American Cancer Society, but at your American Cancer Society through our work in discovery, our research. We carry a substantial research portfolio, our patient support programs led by Dr. Kamal, and our advocacy work through the ACS Cancer Action Network led by our president, Lisa, who's here with us today. Lisa Lacasse, welcome. We give partners meaningful ways to engage across the spectrum. I mentioned research earlier. We're the nation's largest non-governmental funder of research, carrying a research portfolio exceeding $500 million today. We fund a lot of young investigators, early stage research, who have a brilliant idea that they need to advance, some high risk, high reward opportunities in that space. And in our history, because of funding young scientists with novel new ideas, we happen to have funded more than 50 individuals who went on to receive the Nobel Prize. Our work, alongside the work of many others, those of you in this room, we can celebrate progress. Since 1991, we have seen a 34 percentage point improvement in survivorship. More than 4 million people alive today because of the impact of innovation and access to care. Yet 1 in 2 men and 1 in 3 women we know will be diagnosed with cancer in their lifetime. And we know incident rates from the year 2015 until the year 2050 will increase by nearly 50%. That's not okay. Let's bring that why into the room today. We believe food is medicine. It's a key contributor to the fight against cancer. We're honored to welcome so many of you here today, so many of you who are already partners with the American Cancer Society and our Cancer Action Network. From health systems and cancer centers, federal partners at the NIH, CMS, and HHS, community-based organizations, several of whom are partners with us and recipients of our Addressing Barriers to Care program, to universities and research institutions and advocacy organizations. We see huge opportunity together. As Arif said, we want to learn from you. We want to collaborate with you. We see even more opportunities. For example, in the grocery and retail space, consumer activation campaigns, cause marketing grounded in a shared mission around prevention, early detection, and in-store engagement. Healthcare and health plans co-investing in medically tailored meal programs, food insecurity screenings, workforce capacity building, or navigation programs that could very well touch our Hope Lodge system around the country. 31, soon later this year to be 32, homes away from home for those who need it most and need good food as part of their journey. To financial services organizations who are interested in aligning the work we do with a focus on financial toxicity that comes from cancer and funding programs that help reduce access to nutrition. To our friends in manufacturing and the CPG world, with consumer-facing product campaigns tied to cause marketing, bringing branding opportunities, employee engagement, healthy eating, and storytelling. To our technology and analytics partners, data matters. We know this. Data partnerships to advance food insecurity screening, analytics, patient navigation tools, population health modeling, and yes, the topic du jour, artificial intelligence. I want to thank you for your expertise. I want to thank you for your leadership, and most importantly, as I mentioned earlier, thank each of you here and joining us virtually for your time. It is, in fact, the most precious asset you have. Giving us time here today are also patients. Patients who have faced a cancer journey, quite possibly patients currently facing a cancer journey, as well as volunteers who give us their time, lean in with effort. Your voices keep us grounded in humanity, which is exactly where our work belongs. Thank you all for your dedication, for your commitment. And as we stand here and I close in the month of March, I am thinking about March Madness. And I'm thinking about my Iowa State Cyclones, for any Iowans in the room. And I think about our work in this space together. Food is medicine in the fight against cancer. I think we've qualified. I think we have qualified. In fact, I know we have qualified for what would be March Madness. If this is a competition and our opponent is cancer, we're in the tournament. I think we've won a couple games. We certainly made it through the round of 64. I think we've made it through the round of 32. We're maybe in that Sweet 16 spot right now, right where I hope my Cyclones ultimately can make it partway through the tournament and beyond. But none of us got into this with the idea that we are satisfied with making the tournament. None of us are certainly satisfied with leaving before we meet and make it to the Elite Eight and the Final Four, which is where I hope my Iowa State Cyclones, both in the women and men, they're going to qualify in both this year, can make it. But in the same way you may cheer for your teams, cheer for this team, the cancer fighting team that we are all on. We all have roles to play as we take the court. Let's go win the championship. Let's accept the opportunity.
Okay, great.
Sorry, give our time, our talents, our commitments, our treasures to this work.
About advancing nutrition.
I think we all can agree food is medicine, food as medicine.
As we describe,
part of the team,
medicine,
and it can take us through.
There's a framework we like to use in the ecosystem. So, food as medicine is a very diverse ecosystem of different components and different things. And
thank you so much, Arif and Shane, for taking the time to share your remarks with us. And we love a good March Madness analogy, so that's perfect.
What have you done over the last several years?
Before we move on to our next speakers, I just want to take a minute to
Secretary for Health. They've been leading this collaborative action project.
I'll give another shout out to the planning committee who have been amazing, but I specifically want to call out Christina Gately and Gretchen Bruni, who have managed all of the hundreds and thousands of little details to get us all here today.
Kind of what Jim McGovern was talking about, this action goes all the way back to the White House conference.
And I just want to highlight the proceedings from the first Food as Medicine and Oncology Care Symposium were recently published in the Journal Cancer back in January. So if you're interested in that, please use this QR code to access that publication.
Appropriated some funds for this,
and now I'm going to ask you to turn your attention to the video monitors.
Again,
we have a little
to reduce nutrition-related chronic disease and improve
some
health in the
remarks from
United States.
Representative Jim McGovern.
Strategy,
Thank you to the incredible advocates, the patients and their loved ones, survivors, doctors, researchers, for gathering this week in Washington for the American Cancer Society's second annual Food is Medicine and Oncology Care Symposium. I'm Congressman Jim McGovern, representing the 2nd Congressional District in Massachusetts. I am the lead Democrat at the House Rules Committee, a senior member of the House Agriculture Committee, which has jurisdiction over nutrition programs, and co-chair of the bipartisan House Hunger Caucus. The cause of my career has been ending hunger and improving nutrition. And as someone who has faced a devastating personal loss due to this horrible disease, preventing, curing, and eliminating cancer couldn't be more personal to me. I am grateful to this symposium for exploring the connections between access to good nutrition and cancer prevention. We know that poor nutrition, obesity, and physical inactivity are the #1 cancer risk for people who don't use tobacco, accounting for 1 in 5 cancer cases. We also know that 48 million Americans are food insecure, meaning they lack consistent access to an affordable, nutritious diet. And sky-high food costs are putting nutritious diets out of reach for more and more and more Americans, including middle-class families and working families trying to make ends meet. What's clear to me, and I know that what's clear to those of you in this room, is we have to do better. We have to do much better. That's why in 2022, I organized the 2nd ever White House Conference on Hunger, Nutrition, and Health. And out of that conference came a whole of society national strategy that charged federal, state, and local governments, philanthropic partners, and industry to implement policies that will reduce diet-related disease and end hunger once and for all. I have to be honest with you, the federal government has not lived up to their commitments in the national strategy. In fact, across so many markers, we are actually worse off now than we were 4 years ago. Hunger in this country is increasing rapidly due to economic choices that are harming working people and massive cuts to nutrition programs that have put nutritious food further out of reach for families. We are seeing extraordinary threats to our communities with the largest cut to nutrition programs ever. H.R. 1 cut SNAP by nearly $200 billion, taking modest food benefits away from millions of Americans to give billionaires a tax cut. That same bill decimated Medicaid and the ACA, putting health care out of reach for millions of Americans. But this is no time to despair. While we continue the fight to restore these benefits, we must also look for opportunities to expand availability of food as medicine programs that improve access to nutrition in healthcare settings. I'm encouraged by some bipartisan conversations happening on Capitol Hill that would expand access to medically tailored meals, a key program that helps cancer patients and those with other chronic diseases eat nutritiously. I have a bill with Republican Representatives Vern Buchanan and Nicole Malliotakos to pilot coverage of these meals in Medicare. We also have a bipartisan coalition that supports better access to produce prescriptions, improved nutrition education for doctors, and coordination across the federal government on exploring the role of food in chronic disease. But here's where all of you come in. Before I turn over the program, I just have a few action items for every single person at the symposium. 1, call your member of Congress. Ask them to reverse cuts to SNAP. Oppose all cuts to nutrition assistance programs. Sign on to the medically tailored meals bill, H.R. 5439, and expand access to food as medicine interventions. 2, work with American Cancer Society's expansive network to demand that health insurers improve coverage to food as medicine interventions. That doesn't take Congress. Insurers can and have, and some have, helped patients have better access to food as medicine interventions. Private industry has a role to play here. So thank you again for inviting me to say a few words, and from the bottom of my heart, thank you for all that you do to combat cancer through better access to nutrition.
Good morning, everyone. Good morning, everyone. My name is Emily Levin, and I'm a public health analyst and registered dietitian in the National Institutes of Health at the Office of Nutrition Research. In this role, I collaborate with the NIH and interagency partners to help prioritize and coordinate federal nutrition research efforts, and I manage and support several nutrition-focused thematic working groups. Additionally, I co-lead our Teaching Kitchen initiative at the Children's and at NIH. Previously, I served as an ORISE Fellow in the Office of Disease Prevention and Health Promotion at the U.S. Department of Health and Human Services, where I focused on nutrition policy and the HHS Food as Medicine initiative. It is a pleasure to be with you and to moderate this keynote address on federal government activities in food as medicine. Our keynote speaker today is Dr. Nick Jury, also in the Office of Nutrition Research at the National Institutes of Health. Dr. Jury serves as a strategic scientific advisor, and in this role, he is responsible for planning, analyzing, reporting, and communicating scientific, clinical, and policy issues, and information in support of NIH nutrition research programs. He is also charged with coordinating the implementation efforts for the Office of Nutrition Research, strategic plan for the National Institutes of Health Nutrition Research. Furthermore, he is the co-chair of the NIH-wide thematic working group in food as medicine.
Well, thank you. Can people hear me? I guess I'm going to have to lean in on this. Thank you so much for having us today. I want to thank the ACS for having us and inviting us. What a great message we had today, just the enthusiasm that we're getting on this topic. But today I really want to just kind of set the stage today. We're going to be talking about some, I'm sorry, go back a slide. Oh. You're missing a slide. We're going to be talking about federal government activities in food as medicine today. I'm going to be talking about a HHS project to unify and advance collective action. And then we're going to get specifically into some NIH efforts to support research in this area. This is really... Can people still hear me if I talk like this? Okay, so we're going to talk about some HHS Food as Medicine initiatives, and then we're going to talk about, thank you. That's better. Can you hear me now? Okay, great. Sorry about those technical issues here. And then we're going to talk about advancing nutrition education. So as we describe food as medicine, there's a framework we like to use in an ecosystem. So food as medicine is a very diverse ecosystem of different components and different things. And I wanted to just to dive into the HHS collective action. So what have we done? Over the last several years, led by an effort in the Office of Disease Prevention and Health Promotion in the HHS Office of the Assistant Secretary for Health, they've been leading this collaborative action project to try to really get at the issues that are biggest to happen in food as medicine. And as a way of a background, kind of what Jim McGovern was talking about, you know, this action goes all the way back to the White House Conference on Hunger, Nutrition, and Health, and really kind of galvanized that strategic plan that we then implemented, and then going off that momentum, really established this FIM initiative. And Congress actually appropriated some funds for this, bipartisan funds, to support this effort to, again, to reduce nutrition-related chronic disease and improve health in the United States. And the strategy includes programmatic efforts, policy efforts, and we actually have a group that meets pretty often and across the government. So bottom line is that this is a whole of society, whole of government issue that we need to address. So what have we gotten done? So some of these are some of the accomplishments that have been done over the last few years. You can kind of see the website there. There's a toolkit that has been developed for researchers, for clinicians, and just a cornucopia of resources to advance food as medicine and looking at programmatic access to FIM interventions. The concept of FIM is a tactical tool to help people connect the role of nutrition and chronic disease, and represents a range of food-based nutrition and education-oriented interventions and programs. And this directly aligns with the MAHA agenda for the Secretary. So getting back to this ecosystem, as you can see, there is a very large and wide-ranging ecosystem here. And while we recognize food as medicine interventions require collaboration at the nexus of healthcare and community, food as medicine sits within this much larger system of care and society. And there are many different environments that support access to food as medicine, as included in this image. And many federal resources don't support food as medicine directly, but there are enabling policy environments and systems that kind of interact here. And so that's kind of where HHS has been kind of working in this space. Collectively with our federal partners, the Federal Collaborative identified these 4 key opportunities that the federal government could do immediately to take action to advance food as medicine and continue to be guiding principles. So again, we want to cultivate those partnerships across sector leaders and engage these partners so that we could better understand challenges and opportunities to advance FIM. We want to develop an interactive resource to help communities design and implement effective FIM interventions, create a shared understanding of food as medicine through clear language and principles, and importantly, getting back to the CEO's message, foster collaborative action that supports coordinated learning and action across federal resources to support the advancement of food as medicine. So, one of the other things that the group got together that we've been thinking about is how do we define food as medicine? And so we went through a very deliberative process with stakeholders and other government agencies to kind of define food as medicine. And as part of setting the foundation, one of the first things we did was we wanted to try to create that language. When we first started, the only federal agency that really had a definition for food as medicine was the Indian Health Service. So back after the HHS Food as Medicine Summit, which was hosted by HHS, which was the largest summit that had been convened, we had over 500 people. we got a group together to really think thoughtfully about how we would frame this language. And again, I'm not going to read this to you, but this language and some guiding principles were developed to then formulate how would inform our future work. How are we going to operate in this space now that we can define it? So, by definition, for the framing language, recent research has conceptualized FIM interventions into a pyramid in which the top tiers, medically tailored meals, medically tailored groceries, are typically reserved for patients with the greatest treatment needs, and the lower tiers, produce prescriptions, nutrition incentive programs, can be a much broader impact are in the lower levels, and also trying to mitigate severe diet-related chronic diseases. FIM program interventions maximize their benefit and sustainability when supported by resources by these enabling systems. And I'm showing the enabling systems on the outside of the pyramid. It's a little bit different than what others have reported, but we think that these enabling systems are important to consider for the FIM interventions. Across any intervention shown the following pyramid, HHS identified these 4 core components. Recognizing that interventions look very different depending on the level of resources, context, or settings, these core components can offer a unifying approach, but at the core of food as medicine intervention is the provision of food itself, right? In an ideal situation, the provision of food is accompanied by navigation and educational supports provided by a care team that can include a range of health professionals understanding the individual's needs. And this is very specific in oncology care, right? So, to evaluate the success of any intervention, our working group developed an analytical framework to provide a research-based, community-centered guidepost to support diverse leaders implementing and measuring the effects of FIM interventions. The opportunity to evaluate and report on collective FIM models using a consistent measurement framework led us to work closely with federal, external research, practice, policy partners who developed individual inputs to develop this framework that can be used as a resource by partners implementing FIM interventions to support measurement across priority domains. The framework identifies this analytic domains identified as having potential from resulting food as medicine interventions. And our work is also ongoing to identify the specific measures and measurements tools for each indicator found within those 4 domains. So this is a deeper dive into the 4 identified domains. Across all the domains, indicators should be relevant, actionable, measurable, sensitive to change, scientifically sound, and community valued. So I'm kind of showing you a little bit about what success would look like in each of these domains. So for person and households, improve access to healthy foods aligned with diet-related health states, or an increased health system performance or integration of FIM into the healthcare system, or increase access to healthy food within communities, or increased support of regional food producers. So that was kind of an encapsulation of what has been happening at the very high level with HHS. And I want to acknowledge Rachel Fisher, who is in the room here, who has led these efforts across the government and has really been a champion and a leader. So, and relevant to all these things that we've been doing in these meetings and all this information I showed you, kind of drilling down more into the NIH, which is where I'm from. I want to talk about some specific activities that the Office of Nutrition Research has been leading as a part of this greater collective collaborative action that I was telling you about. So, as Emily alluded to in the introductory remarks, we have a strategic plan for NIH nutrition research. And last year, ONR released its own Office of Nutrition Research strategic plan. These strategic plans are our guiding star, and they have goals and objectives that we want to achieve in nutrition science. And so I'm calling out these 4 objectives here from what we call the Strategic Plan on Nutrition Research, as we call the SPINNER. And so spurring discovery and innovation into foundational research, defining the role of nutrition across the lifespan, reducing the burden of disease in clinical settings, and investigating the role of dietary patterns and behavior for optimal health. All 4 of these goals follow under a unifying theme of precision nutrition, which is directly relevant to the food as medicine interventions that we're trying to support here. So recently we did an analysis. So you have a strategic plan. You're like, okay, we got all these great strategies. We got all these great goals. Have you actually achieved anything? What are you doing? We don't want to just do lip service to these things. So we published an analysis of the first 3 fiscal years of our plan. And that analysis found out we were doing a lot of different things. We had over 600 actions, either papers, grants, reports, policy actions, patents, things in the nutrition science space. That's really great. Okay, you're doing all these things. But we identified a gap in the food as medicine area, which was kind of interesting. And so showing that area is a particular area requiring additional work, additional research. And so I want to talk about NIH's investment in that. So the analysis showed that over the last few fiscal years, funding support for food as medicine research has almost doubled, and the number of FIM-supported projects has also doubled. We funded over 20 of them last fiscal year, and they are each on a range from across the pyramid, from population level all the way up to medically tailored meals with select grants throughout there. But dare I say that 20, while that's a great start, getting to the CEO's remarks about how many people were still, incidence of cancer, we still have a lot of work to do. So, digging deeper into this analysis, I want to call your attention. There were only 2 projects that were cancer related within the context of cancer in the food as medicine that we were able to identify from FY25. I think there were 3 in the previous fiscal year, but again, given the magnitude of cancer and the exposure of this area and the importance of this area, this is a key gap that we should be addressing. I also want to talk about something else that Emily alluded to, that she is helping lead this project. ONR has a teaching kitchen program at the NIH at the Children's Inn. So the Children's Inn is a place where children often who are getting cancer treatment or are involved in a clinical study at the clinical center at NIH, they stay there with their families. They're able to have food. And so the Teaching Kitchen program is a really cool way to engage the children and their families into making healthy meals, making educational things here. We have pictures of our director, Dr. Bremer, and then you can see Sam and Emily and some of our other staff in there. And so it's just a really important tool to, again, show the importance of nutrition in improving health and also during treatment, and then just really giving a social engagement for them. So this program is going to expand hopefully over time, but this is just the program that we've been doing over the last 2 years and just kind of a service to the community. ONR has also launched the ADMIT program, the Assessing Determinants of Malnutrition Implications for Treatment. And really, this program is to provide information and service to support the entire food, nutrition, research, and global health enterprise. And so, when a patient comes in, even from the beginning of diagnosis to treatment, malnutrition can be a huge component in that way of treatment. So screening for malnutrition, and the program really hopes to enable current tools and development of new tools to assess malnutrition in clinical settings. Okay, so I just gave you a lot of information in a very short period of time. And so I really want to call out the research opportunities looking forward. So HHS and NIH put out a interagency RFI a couple years ago, and then we produced a white paper with Office of Disease Prevention and Health Promotion at HHS that called out these 4 specific areas that need to be addressed to advance food as medicine programs and interventions. And so really, one of the biggest things I'll talk about, the return on investment, just how are food as medicine interventions improving health outcomes? How are they lowering healthcare utilization costs? How are they affecting communities? So that's really what it comes down to. And hopefully we're hoping to advance more research looking at this type of areas. Okay, so the last thing I want to talk about is nutrition education. And so, Last week, the Secretary announced the new national commitment to advancing nutrition education and showing that there is a huge lack of nutrition training at medical school curricula. The Secretary of HHS and Department of Education secured voluntary commitments from 53 medical schools across 31 states to require at least a minimum of 40 hours of nutrition education or implement a 40-hour competency equivalent starting in the fall of this year. It's a major achievement, and given the lack, and it's been an issue as well. And NIH is very proud to have released our own prize challenge as well. So, as part of the program, NIH is dedicating $2.1 million to support medical schools, nursing, residency, nutrition science, and dietitian programs to integrate nutrition education into their curricula through a multi-phased NIH education challenge. And so this prize challenge is going to have two tracks. We're going to support the development of new programs, new curricula, schools who want to integrate this, and then also support evaluation of existing programs. And so I'll put the QR code and leave that up there. So just part of NIH's support and effort to support the Secretary's agenda, part of the MAHA movement, again, putting in nutrition education into the medical community. And with that, Emily and I are going to have a little chat here. She's going to moderate some questions, and then after that, we'll take some questions from the audience.
Well, thank you so much, Nick. That was great. So right off the bat, you just mentioned the nutrition education newly released from the Secretary. Can you tell me a little bit more about how you see nutrition education in healthcare and how that could improve quality of cancer care?
That's a great question, Emily. And yeah, this presentation I gave is very high level, but to bring it to specifics to oncology care, and I'm sure a lot of people are going to talk about this later, but nutrition is so important, right? From the diagnosis standpoint to the treatment to the post-treatment. And those three periods can be very distinct, what you need, the requirements of a patient. So again, getting back to the ADMIT project, being able to evaluate for malnutrition, screen for food insecurity. And so I think, and this challenge will be really key to improving nutrition education. And again, let's be clear, it's not about taking away the role of the dietitian, right? It's about giving doctors, future medical providers, the tools to know to refer to dietitians, right? And I remember reading a study that it talked about a cardiologist who took some CME credits in nutrition, and then his referral rate to dietitians went up 30%, seeing the value of that. And so I don't have the citation, but again, the education will be really key to that, right?
Great, thank you. Now, how does NIH plan to continue to support Food is Medicine?
Another great question. So you mentioned our Food is Medicine thematic working group that Emily and I run, along with Dr. Carlos Garrido and Dr. Charlotte Pratt with National Institute of Minority Health Disparities and National Heart, Lung, and Blood Institute. We meet regularly, and we're trying to identify ways to get the institutes. NIH is a large structure. There's 27 institutes and centers, each one focusing on either a disease or body part. But really just we're a convener. Our office convenes. We want to get people energized. We want to find ways to fund the best research and, again, address some of those gaps that I talked about. That's through seminars, through funding announcements, through engagements with you all like here. That's one of the reasons we're here. We're here to hear from you. We're here to be of service to you. And you all are really moving the field so fast, so we want to make sure that we're relevant and that we're supporting the best science.
Great, thank you. I think you've answered all of my questions. Do we have time for questions from the audience or online?
If you just want to go to we can.
Thank you for the great presentation. Just a couple of questions. we know education is sometimes the first step of many. And so in thinking about how someone is to execute and implement that at home once they're in their own kitchen, can you speak to a couple of the grants that you mentioned were cancer focused that really are intended to help somebody once they're back home put into practice what they've been taught? And second question, if I may, can you speak a little bit about what will always be the same and what kinds of things change across administrations with different priorities?
Okay, so I'm going to answer the last question first, and then I'll get back to the specific grants. I do have to say, so as we talked about, a lot of this work started with the Conference on Hunger, Nutrition, and Health, but it hasn't started there, right? You all have been in the trenches working on food as medicine for years. It goes all the way back to Native communities, right? But I can certainly say this, that just from my viewpoint, going from previous administration to this administration, it is a priority. Nutrition is a priority. Dr. Jay Bhattacharya, the head of the National Institutes of Health, our director, it is clearly stated in the 5 priority goals, nutrition is one of his priorities. And at a congressional briefing on ultra-processed foods a few months back, he gave those remarks and really galvanized his support for nutrition research and food as medicine. So I think we can reassure you that, and as you can see from the data, we're showing, support for these types of applications are going up. Going back to your other question about those specific grants, I believe those specific grants, although my colleague, Dr. Tanya Agers-Collins, is going to be speaking later, she might be able to speak more to that, but I believe those 2 grants were actually medically tailored meal. I don't believe they were an educational component part of that. But getting back to the importance of that, my mother was diagnosed with cancer last year, and she had a neuroendocrine tumor. And, I was so impressed, and having us hosted this meeting back in 2024, I knew the importance of talking to the doctor. What kind of nutrition, what kind of support is she going to get? And they were very looped in. She got her medically tailored meals after her procedure a week later delivered to her, even though she didn't need that. But I appreciated that. So, but you're right. A lot of people don't have that knowledge, or and some doctors don't even know, oh, just eat whatever you want, right? It's a really important issue, and I hope I addressed your question. Anybody else? I think we have time. What time? Yeah.
Thank you. And kind of touching on what Shane said, holding on to your why, I appreciate your vulnerability, talking about your mother. That's a little bit about my why too. Her name was Christine, and I lost her when I was just 13, and I will be holding on to your story too, as well. I am from the great state of Maine, and I'm part of a community-based organization called the Christine B. Foundation. And for the past 6 or so years, we've been really trying to design and answer a lot of questions that the 20-some-odd projects that you've helped support and fund might be answering as well. And my question is around enrollment, and I know that's kind of a boots on the ground level discussion when it comes to research, but I'm curious if you've learned anything from the groups you've been working with and funding to have patients enroll in some of the studies. We're engaged in one right now called Nourishing Hope, and it's really to understand change of quality of life, health outcomes, and hospital utilization. But when we started the trial, our enrollment for some of these medically tailored groceries we provide and the dietitian counseling we provide has actually gone down a little bit. So we were curious if you have some best practices to still encourage participation to get the best science while not burdening patients too much on the playing field of access to food. Some folks might just go to a food pantry where there's not a lot of questions or tests and deeper perhaps barriers to get the food. I was curious if you could share any lessons you have.
That's a really great question, and that's very deep, but I since not being involved in the actual recruitment of these studies, I don't want to get too far into that, but I do know enrollment in general in clinical studies, we know it can always be a challenge, but I'm surprised that particular component, because I would think those, having the groceries delivered, the populations you're talking about, that would be something they'd want to sign up for. But I don't want to put the question to our investigators, but I'd happy to have a talk with you afterwards. We can put you in touch with some of those investigators that run those studies. Happy to do that.
Thank you.
Any questions online? Oh, here comes Colleen.
Hi, great talk. We have to speak up because I'm back online seeing that people can't hear very well, so we want to take care of that. And the slides will be, look, I'm just on the planning committee. The slides will be available online or back to you later, or the recording. Thank you. I will say probably 50% of what I'm seeing online in questions, and thank you for all that information, is the call. And I promise I am biased about this question, but the acknowledgement that right now there's one dietitian to every 2,300 cancer patients. And now that we're getting, which is fantastic, we're going to have some education for the physicians. What is HHS and NIH doing to try to facilitate reimbursement for dietitians?
Excellent question, Colleen. And that is a challenge, right? I was at another conference a couple months ago and had two physicians come up to me and say, hey, this is all this great stuff you're doing. You're going to increase referral, but the actual referral, that they're not being reimbursed. And that is a challenge. And I can say this, if we're giving that slide I put up about the return on investment and decrease in utilization costs, if we drive demand for dietitians, right, and you show the insurance companies outcomes are improving, right, they're often driven by dollars, savings, they'll be more apt to support it, right, and then down the line. But I think we need more data on the referrals and just kind of not putting it back on you all, but you all have very strong voices. If this is an issue, again, we support research. We're a research agency. We can bring it up to the top as well. But the secretary is very engaged with MAHA. If dietitians are required for MAHA to go forward, which they are, I'll just leave that for you.
I don't know if there's other questions for here, but I'll keep going. So we have another question that is saying many patients with cancer want to try various diets after diagnoses. Does NIH have an interest in funding comparative effectiveness studies between different types of diets for people either going through active treatment or during survivorship?
I would say yes and yes. And we have funded some other studies on comparative effectiveness. Again, I don't want to get in front of Dr. Augers-Collins, who will be speaking later for NCI. So, but yes, comparative effectiveness is a very important study to have. How are we on time? Are we good on time?
You're great. I'd like to ask a question back to the reimbursement and models, and this may be beyond your purview. Do you have any insight on bundled models that are happening maybe with the enhancing oncology innovation models that are being investigated right now with CMS? Is nutrition, our dietitians, part of those EOM models? Is that something prevalent? Will that be something that yields data about this care delivery opportunity?
That is a very specific question. Do you want to get this one, Emily?
I was going to say we could also, CMS will be talking later as well.
Sorry, yeah.
And they might be better for taking that question since they're working a little bit more in the reimbursement space. Oh, can we?
Perfect. I knew you would come in.
That was a great question, and we currently don't have specific reimbursement for nutritionists, but we are working with some of the folks in the room to see if we can maybe pull together a waiver that does provide funding. But as it stands right now, oncologists take on the cost of any nutrition, so that is up to our participants to decide if they want to reimburse for nutritionists at this point.
So now that I have Yara on the microphone, before we go too far, how can NIH assist in that? What type of data can we support research or data that already exists in the ecosystem that we can pull together in a publication or white paper that would support that practice?
I think showing the benefit of during treatment, how nutrition impacts outcomes, medication adherence, all of the things we know in this room and in our bones needs to be on paper. And I've been working with a lot of us in the room to get that together. But I think the business case for us to take on more risk at this point is a tough call. And I know that data exists, but I think in a compelling way to say, look, if you bring on a dietitian, I think another important aspect is who do they partner. So unless they're part of their practice, it's very difficult to find specifically an oncology-focused nutrition dietitian or nutritionist. That's a lot of the questions as well. Working across state lines is also like tedious, but very relevant for their work. So those are some of the ideas off the top of my head.
I love it. And actually, I think another panel is going to probably get at some of those other issues. So thank you so much for coming in on that answer.
I actually just have a comment. Importance of collecting information about cost of these interventions and evaluating the cost effectiveness, not only in terms of delivering nutritional meals, but also patient outcomes. So how the impact on longer term patient adherence to treatment, survival, and other health-related outcomes. So that is a really important component for people thinking about the importance of reimbursement.
And just to piggyback on our comment, other policymakers, other higher ups that we talked about also want this data in our Congress as well, talking about these data. So, and I think we actually, our slide kind of gets at that a little bit, but you really articulated it much better than I did in the slide. So thank you.
Thank you.
Anybody else? Do we have time? Did I talk that fast?
There's a lot online, but I'm just going to say if you're not answered, we will get them to the presenters and they can answer you online as well. Is that true, someone from ACS? I just said. Okay, we're going to have that done.
I know, the ads are up there, so it's been up there for a while, so they're probably been typing already, so we can type.
But the question was, how do we get, which is a great question, and we might cover it later, insurers to buy in to the food as medicine and to all these things and the payers?
I'll let my colleague Emily answer that question if she wants.
Well, I think I kind of touched on it a bit earlier, talking about really utilizing your voices and pushing for it, especially clinicians using your voices and the importance of food as medicine in the work that you're doing and the impact it could have on your patients.
Is it a wrap? Any other? Are the big ones kind of you think that one want to really get at? Or are they kind of, is the thread kind of similar theme? Okay, that looks like we have another one.
There's, a lot of themed ones, but this one is kind of the disconnect with cancer and some of the new dietary guidelines that might be promoting some information that might not align with the cancer recommendations. So they just wanted comment on that.
So you want to take that one, Emily? As a dietitian? Look at me punching the difficult question to you. But you have expertise in DGA, so.
I think too, it's really important, especially in oncology care, to, if you have the ability to reach out to a dietitian, really utilize the dietitians. Ask your provider if there's a dietitian that they recommend, if they work with your insurance company, seeing if you're able to get reimbursed. I know it takes advocating on your end, which can be difficult, but if that is something that you're interested in exploring more, that's probably the best avenue to do.
Yeah. Oh, Stephen, good to see you.
Thank you, Dr. Perry. That was great for both of you. I have a question about the Advancing Education Challenge Grant. I'm curious if it's only targeted at medical schools, or do you also have challenge grants that allow postgraduate kind of folks who are already practicing and doing medicine in the clinics, and if they have programs, and if that could be part of the challenge?
So that is a great idea and definitely something we can explore. We currently are working on multiple phases of this program, of the challenge grants or challenge awards. Right now we are talking about residency programs as well. So although not still sort of in that education part of medical students, but that is something that we can definitely explore and something we should explore. I love that.
And the QR code only goes to the announcement right now. The full details are not available. You can't. It's kind of like you can't go there and apply right now, but there'll be more details coming out. But that point is important. And like Emily said, it will be a phased approach. But yeah, that's very important.
And I'll just say, I think it's really powerful. You're starting at the early pipeline of education, and we have so many practicing clinicians who need to be upskilled. And there are training programs that are doing that. And so to kind of encourage the flourishing of folks who have been in the trenches doing this, trying to upskill, would be powerful. Thank you.
Thank you.
Thank you. Well, with that, I'd like to thank you all for your your attention, and thank you for having us. And this is just the beginning of a great day. So thank you for having us.
Thank you.
Is this on? Great. Good morning, everyone. I'm Marissa Shams-White, and Dr. Robin Yarbrough and I are both researchers in the Discovery Pillar at ACS, and it is our pleasure to co-moderate this next session, Building the Evidence, Food as Medicine in Cancer Care Research. So we'll have 4 presentations with 5 speakers, and we're going to ask for everyone to hold their questions for the Q&A panel we'll have at the end. We'll invite all speakers to come sit up here for your questions. And for those joining online, please do share your questions online as well, and we'll go back and forth between in-person and online. So with that, I'm going to start off with inviting our first speaker, Dr. Carrie Daniel McDougall, up to give her presentation. A professor in the Department of Epidemiology at MD Anderson Cancer Center in Houston, Dr. Daniel McDougall's research program includes observational and controlled intervention studies focused on diet and biological markers across the spectrum of cancer prevention, cancer patients, and cancer survivors. And she also directs MD Anderson's Bionutrition Research Core and Metabolic Kitchen facility. Would you like this microphone, or you want to try that one?
I will give this one a try. Thank you. Oh. Okay. All right. First, I just wanted to give a shout out to American Cancer Society. I did my graduate training with Margie McCullough, and my dissertation in the CPS2 cohort was a research scholar grant recipient, which helped me keep my job at MD Anderson for the past 13 years, and I'm just so grateful to be here. So I really do work in the cancer patient and cancer treatment setting, and this is just kind of the bird's eye view of what we see in terms of patient outcomes, and I think it's important to kind of lay it out here what we're dealing with. Obviously, every cancer patient wants to go through therapy, not experience toxicity, and have this beneficial outcome. But there are a lot of other things that can happen along the way. And so we're also really concerned about toxicity, and that can be a treatment limiting toxicity. And if someone doesn't get enough treatment, they're unlikely to have a good response. And then it's kind of the worst scenarios, treatment resistance with toxicity. And those are some very unfortunate scenarios where individuals have to go on multiple lines of treatment. I'll just, for folks that don't know MD Anderson, we're the largest cancer center in the world, and we see a lot of late-stage cancer patients, and we have a huge clinical trial program, particularly in phase 0, phase 1 clinical trials. So we kind of see a very different population that is out in the community and is represented in most of our survivor cohorts that we all study and learn about. These are very late-stage, very sick patients. That said, I didn't want to give up on the fact that diet could actually be a modifiable risk factor in patients like this. Obviously, we want to get them through their treatment. We want this treatment to be a durable response. We don't want individuals coming back. We want to watch them closely. But the other challenge, being an epidemiologist and being someone in the research side, is that these treatments are constantly evolving and changing. So we have to be very agile in our study designs. But this is wonderful for patients that this is happening, and we have to really be on top of it. We know that obesity and poor diet are cancer prevention risk factors, and we're starting to understand how these things are associated with progression and outcomes. But over here in the pyramid, we know that like iceberg, I'm thinking of diet. Age, sex, BMI, these are the kinds of things that impact a patient's response to therapy already. We're learning that the microbiome is predicting response to therapy. So if we look at all those things above, gosh, don't you think diet and lifestyle maybe has something to do with response to therapy? This is something that we're trying to increasingly bring to the table. And I'll talk a little bit about our work in the gut microbiome and therapeutic response. It's also incredibly important for therapy resistance. And this has really been shaping new research priorities for patients with cancer, and I think really allowing diet to come to the table. And so we have to think about how diet and lifestyle can synergize with treatment tolerance and efficacy, both at the start or priming prior to treatment, but also support through treatment in the survivorship phase. So how have we done this? Obviously not by myself. So really that collaborative effort, bringing together the research and the clinical teams, has been hugely impactful for us to develop strategies. Some of us are just completely interested in the gut microbiome. Some of us come from a nutrition background. Some of us are interested in immunotherapy treatment resistance. And we all come together to do this work. And we've built these therapy-driven prospective cohorts where we're measuring diets. I heard a lot about how are we going to get insurance to cover this and all of that. Well, we have to show that it has an impact on clinically relevant outcomes. And we have to do that, unfortunately, in very specific settings and very controlled ways. So first we develop the cohorts. Then we do these parallel preclinical studies using animal avatars, and then we've been developing clinical trials. Another area very dear to my heart that I won't present today is also following stage 4 survivors. So someone who has done the amazing thing and survived their metastatic cancer, but is now living with chronic toxicity. So immunotherapy toxicities can pop up anywhere from during the treatment to 2 years after treatment. Think about that survivor coming to their primary care physician with something that's popped up to do the therapy. Do you think that that primary care physician knows anything about that? Is that going to be treated properly? Are they going to be referred back to the cancer center? And we're really interested in how diet is a part of that process during therapy and long term. So that's the long-term goal after we figure all this out. So coming to the human gut microbiome, when I really started in my assistant professorship at MD Anderson, this was a really hot topic. And this was something that I really saw in my biomarker-driven research program was going to be hugely impactful. Never did I imagine what it would mean for response to therapy. We know that many other things besides diet obviously affect the gut microbiome. It's a very, very sensitive marker. It's very different between you and I. It's very different within each other over time. But there are some very key things that are definitely relevant in the cancer treatment space, and there are some things that we cannot change. But it is a marker that we can measure and use as a measure of potential efficacy in this space with diet. So just a quick vocabulary lesson. Probably everyone in this room knows these things, but sometimes people get confused when I talk about probiotics and prebiotics. Prebiotics are the things that the bugs like to eat. Probiotics are actually the bugs themselves. They don't just come in a pill. And then there's a lot of interest in the research space on creating symbiotics, and you'll see these on supplement shelves too, like a probiotic with a set of different prebiotic fibers. Ideally, those are designed to work together. Usually it's just a hodgepodge of junk. Postbiotics are really interesting for people in the gut microbiome research community. There's a lot of trials giving people the metabolites or the products of those interactions directly. So just skipping all the steps and giving the individual the product, like butyrate. I live upstream in the diet part with prebiotics. So we worked on this amazing study together, Giorgio Trinchieri at NCI, Jennifer Wargo, who's a surgical oncologist and melanoma at MD Anderson, and myself worked on this project looking at dietary fiber and probiotic use among our patients going into their treatment initiation, and what was that effect on the gut microbiome and melanoma immunotherapy response. We had previously showed in a smaller cohort that the gut microbiome was significantly associated with who was going to respond to treatment over time. And there were these fiber fermenting bugs, Faecalibacterium, and in the family Ruminococcoseae, that are really well known to people who do diet microbiome research as being stimulated by dietary fiber or like habitual high fiber diets. So we saw those to be associated with response to immunotherapy in our patients. In this next cohort, which was a whole new set of patients, new set of therapies, we had a lot more frontline immunotherapy when we did this cohort. We had some new agents that were being combined with PD-1. So this was a broader cohort, larger cohort, but those findings were sustained. Then we had also convinced, seen that there was an effect of the gut microbiome and maybe these fiber fermenting microbes. We had given patients a very brief dietary questionnaire. It was not the questionnaire I wanted. It was the questionnaire I was allowed to use because nobody thought this was important, and we were just gonna adjust for it in the model as a covariate and move on with life. Well, it turned out to be the most important thing in the entire cohort, to be honest with you. And this is, for epidemiologists, a population-specific cut point. Obviously, with dietary assessment, we don't get excited about absolute amounts, but it was about less than 20 grams of fiber, roughly, was insufficient dietary fiber in this cohort. And so the patients who had insufficient dietary fiber at baseline were less likely to respond and had shortened progression-free survival. And that effect was quite robust to adjustment for all these other clinical factors like LDH, like BMI, like the other things of concern. Interestingly, because there was already news out about the gut microbiome and immunotherapy response from honestly the prior study, patients were all taking probiotic supplements. About 40% of our patients were taking them. Some were in their medical chart, maybe let's say 10% they told their doctor about, and the rest were reported in our questionnaires and all pretty much over-the-counter hodgepodge, not one specific type. We're not going after anybody in particular, but it was not a good effect. What we found is that patients who were taking probiotics were less likely to respond. And then when we kind of layered this together, we saw that the patients who had sufficient dietary fiber and did not take probiotic supplements did the best. Well, that's all well and good in an observational cohort. What can you say about that? Well, we actually took samples from patient stool samples and put them into FMT models in the mice. We took a complete responder from the cohort. We gave the complete responder microbiome the over-the-counter probiotics and reversed that effect and made that patient a non-responder. So it may not necessarily be harmless to just take supplements, and maybe there's some thought to consider about diet. So I always bring this up because everyone wants a supplement. But I don't have to tell everyone in this room, we haven't really succeeded in diet and cancer with supplements. So coming to kind of my focus, which is really on whole diet. So we know that there are already excellent, well-established cancer prevention recommendations put forth by the ACS. This is the American Institute for Cancer Research. Eating a high-fiber diet is already consistent with those recommendations. What's the big deal? What's the problem? Well, I would say, though, it's still important to consider that these are not healthy individuals. They are facing a lot of different things going through their therapy. And then I think we have to think about what are also the oncology nutrition guidelines that we need to consider in this context. Obviously, there's a focus on eating enough calories, getting enough protein. But there are also a lot of nutrients that patients may need that are from animal food sources. So we're not going to go out with this high fiber and vegetarian veganism often get mixed together for some reason in terms of the message that people receive, but this is something that we need to consider. And then, of course, patients tend to do better with small, frequent meals. I'll talk a little bit about a feeding study that we did. It's very difficult, as treatment progresses for patients to eat up to their calorie needs or complete full meals. I just realized I didn't update the dietary guidelines, but honestly, I don't even know what to put on there. So these are the old ones, but the core of this is that there are already many beautiful cohort studies that have recruited people without cancer and then continued to follow them through a diagnosis of cancer. And they've shown that these different dietary patterns are definitely associated with cancer survival. So the root here is the Cancer Prevention Diet Guidelines, which overlap with some of these other very interesting and healthy dietary patterns like anti-inflammatory diet, Mediterranean diet. And then over there in the corner is my restrictive diets, because there's a lot of interest in ketogenic diet, or do I need to give up this? I mean, everyone's focused on what do I need to give up as opposed to what do I need to be eating. And those don't have to be healthy. I mean, you can knock out all animal foods and eat a really still unhealthy diet. So just kind of recognizing that those don't necessarily achieve all these things. So thinking back to the microbiome and how impactful it may be, gut health and the microbiome may be for a response to immunotherapy, and also sort of dealing with toxicity and resistance in this space, there are multiple ways that we can change the microbiome. Our focus on diet is really on the basis that anybody on these other modulation strategies is also going to be eating. And so not only is it potentially independently important in this space, it's in the background of everything that everybody else is trying to do. So it's extremely important, as hard as it's going to be, it's extremely important to build the evidence on what a diet is doing during therapy. So we kind of undertook this in the fiber space, conducting several different trials. The first really being establishing feasibility and safety. So we're not going to optimize an intervention in patients on treatment for cancer. So we did our phase 1 diet 1.0 study. I'll talk about the diet 2.0 study, and this endeavor study in survivor and healthy populations, really optimizing the intervention. I'm going to first tell you a little bit about my ACS-funded trial, the BGON trial. This was done actually in a colorectal cancer survivor population. This was a little bit larger trial than the early phase trials. And all we did in the study was feed individuals who had a history of colorectal cancer or recently had recurrent polyps and who were obese, up to a cup of beads per day. That's all we did in this study. And the goal was that this population was sort of already struggling with diet quality, certainly actually avoiding a lot of these foods for obvious reasons, and really seeing beans as the perfect prebiotic off-the-shelf food that everyone could have in their pantry. What we found in this randomized crossover study, again, we're targeting the microbiome through this dietary exposure. Over here on the, I guess that's your right, my right, we're looking at a marker called pipecolic acid, which is a really well-established blood-based metabolite of the interaction between gut microbes and the certain compound in beans called lysine, amino acid. And so that is produced by that interaction. And as you can see, as patients were on the part of the trial where they ate the beans, that goes up. And then as they came off the beans, that went down. So we know that the effects that we observed were related to this interaction. I'll just say that we also saw these changes in these intestinal, systemic, immune, and inflammatory response. That was very interesting to us. And then, of course, these bugs that we had seen in the immunotherapy setting as well. So I'm running out of time already. Let me get going. So the Diet 2.0 study was conducted in metastatic melanoma patients receiving immunotherapy. It is a fully controlled feeding study where individuals got a control diet that meets the cancer prevention guidelines but does not exceed 20 grams of fiber per day. The other arm was ramped up to patients' tolerance up to 50 grams of fiber. I can't share all the results because we are in a resubmission, but we did see a differential in terms of response in these two arms. But most importantly, I wanted to mention how much incredible feedback we had from patients, and also that this was a stepping stone and a learning experience, and that we learned that even with the support of the dietitian, all the meals of full feed patients were not able to eat all the food. So the next step was to build this hybrid, which we call pre-fed. And in that, we're providing more small meals or daily snacks where they still have freedom to eat with their families and eat other food. The dietitian is counseling them in terms of stocking their pantry. I will also for this group mention that during our pilot and feasibility, we tested try a new fresh ingredient with recipes and all of that. Dandelion greens are your weekly ingredient. We provide it, we give it to them. We had to take that out in the pilot. Nobody liked that. Everyone preferred to just receive the food made. And honestly, that makes sense. You've got a lot going on. Just, for all the grocery stuff, I think that's great. I think that's going to be rough in this setting. We are definitely doing a component of that, but that is not the primary focus of our intervention. And we're doing this in the neoadjuvant and the metastatic space. So just kind of coming to the end here, these may be really important for providing everything the microbiome needs in a single bite. The fact that we're all different and our gut microbiomes evolved on our diets may allow it to stimulate all that variation between us, whereas you drop a supplement in there, if that's not what you need, it's probably not going to work, right? Or you don't have the bugs to work with that supplement, it's not going to work. And then I really think that, the multiple components can possibly mitigate kind of the stress that the gut is going through and the host in terms of going through cancer. And I just, again, not for this group, but every other group I speak to, it's always there. People have to eat no matter what you prescribe, no matter what you do, someone has to go home and figure out what to eat every night. And so it's just this variable we really need to be thinking about. So kind of going forward, we're also really thinking about how diet integrates with actually human FMT trials. We're thinking about how diet may integrate with different fancier probiotic consortia strategies. And I think this is really where nutrition is actually going to take the microbiome field to the next level. That's my hope. And I just want to thank our funders, and I look forward to your questions later. Thank you.
Thank you so much, Dr. Dougal. Okay, so our next two speakers are Dr. Colleen Spies and Dr. Fangfang Zhang. So Dr. Colleen Spies is a professor in the Division of Medical Dietetics at the Ohio State University College of Medicine, and her research focuses on developing and testing food as medicine interventions with a strong emphasis on cardio-oncology clinical trials that integrate medically tailored nutrition to improve treatment tolerance, cardiometabolic health, and long-term outcomes. A fellow of the American Heart Association and the Academy of Nutrition and Dietetics, she has contributed to national clinical guidelines spanning diet and physical activity in oncology, malnutrition, and food and nutrition insecurity. Dr. Fangfang Zhang is the Neely Family Professor and Chair of the Division of Nutrition Epidemiology and Data Science at the Friedman School of Nutrition Science and Policy at Tufts University. She is a nutritional epidemiologist with extensive expertise in assessing dietary intake patterns, trends, and disparities in the population, and conducting observational studies and clinical trials to investigate the role of nutrition in cancer prevention and control. So with that, I'll pass the baton over here to Dr. Zhang. Sorry. Oh, sorry. We're going to start off with the video. Apologies.
Nutrition is a critical component of the treatment plan for patients with lung cancer. It is one of the modifiable risk factors for treatment outcomes and healthy living that patients actually have control over. And the majority of patients with lung cancer are actually malnourished either at the start or during their lung cancer treatment.
My name is Ruth Comer. I'm 82 years old. I'm from Columbus, Ohio. Well, since the study, I am more concerned about the foods that I eat. Before the study, my eating habit was really bad. Most of the time I would eat maybe one meal a day. And since I have been into the study that I'm in now, I've learned how important it is to have a healthy diet. And the meals that you get from Manna, it's all set up for you. You don't have to be doing a lot of cooking. And the Manna meals are good, too. They're really convenient for you. And I have really learned a lot of things. And I know that once this is all over with, I will be doing a lot better with my eating because I know it's going to help me with my illness. I've also learned from my counselor. Your counselor does a lot to help you out also.
When a person starts cancer treatment, they often experience nutrition impact symptoms, and as a result, eating can feel like a chore. And with the NutriCare intervention, we have seen people regain their love for food. They see it as a key source of nutrition as well as a provision of the energy they need to do the things they enjoy with the people they love. And so with Medically tailored home delivered meals, we are providing people what they need in an easy and convenient way, a way that will be feasible for them, even when it's a struggle just to get through the day. Evidence demonstrates that oncology patients want access to registered dietitians. This same sentiment has been echoed by NutriCare participants, stating every cancer patient should have the opportunity to meet with a registered dietitian. However, access is limited. It is estimated that for every one registered dietitian, there are 2,300 oncology patients, thus identifying a large gap. Not to mention that most patients are not referred to nutrition support until they've begun to demonstrate some of the early signs of malnutrition.
So great. So this is a video clip from the one of our patient participants, our study oncologist and the study dietitian for NutriCare study. So the NutriCare study is a study. I don't know how to advance the slide. Is this? Okay. Excellent. Is a study to evaluate a food as medicine intervention among vulnerable patients with lung cancer. So why patients with lung cancer? We know that patients with lung cancer are among the most malnourished cancer patients. And in fact, malnutrition occurs up to 85% of all cancer patients, especially those who are undergoing treatment or diagnosed at late stage. And malnutrition leads to increased inflammation, muscle wasting, weight loss, and weakened immune function, which reduce patients' ability to tolerate treatment. As a consequence, malnourished patients with cancer, they're significantly more likely to develop treatment toxicities, have treatment interruptions, and increase hospitalizations, which can impair the quality of life and eventually reduce survival. So thanks for the Bristol Myers Squibb Foundation, we were able to partner with 4 cancer centers across the nation, the Tufts Medical Center, Fox Chase Cancer Center, and the Ohio State University James Cancer Hospital, and also MD Anderson Cancer Center, to enroll patients with lung cancer who had low income, who are racial ethnic minorities, had no insurance or Medicaid, who are from rural areas, age 65 older, to the NutriCare study. And most of the patients were undergoing treatment when they were enrolled, and they were randomized to either the intervention or the control group. So those who randomized to the control group, they received a printed copy of the nutrition toolkit we actually developed at Tufts University as part of PCORI funding project that outlined topics like dietary intake recommendations during cancer treatment and some strategies that cancer patients can take at home to address nutrition impact symptoms, including evidence-based nutrition guidelines, including American Cancer Society's nutrition physiology guidelines for cancer survivors. And they also receive monthly nutrition newsletters sent through email. For those who randomized to the intervention group, in addition to receive the toolkit, the newsletter, they also received medically tailored meals delivered to the home. So the medically tailored meals are designed by dietitians, and they were prepared and shipped by Manna, which is a community-based food as medicine provider in Philadelphia. So these meals were shipped in a box with a week of the meals, and with ice and dry ice to keep the temperature low to ensure safety. And we provide the meals in a step-down fashion, meaning the dose was initially higher, but gradually reduced over the course of 6 months. And the meal provision was provided in combination with nutrition counseling and provided by Dr. Holding-Spee's team. Those dietitians are trained to conduct motivational interviewing, and the initial dose was weekly, but adjusted by the dietitian according to the patient's condition and their schedule. And the dietitian also worked with Manna to adjust the meal provision as needed. So we assessed a bunch of health outcomes, and so this is a busy slide. The primary outcomes we assessed are diet quality and unintentional weight loss. And we enrolled randomized 249 patients with lung cancer, and roughly half were randomized to the intervention, the other half randomized to the control group. And majority of the patients with lung cancer had non-small cell lung cancer, and majority of them diagnosed at a late stage. And at baseline, the diet quality measured by the Healthy Eating Index, which measures a person's adherence to the dietary guidelines of Americans, the mean was 61.8 out of 100. And about 60% of these cancer patients were either overweight or obese at the time of enrollment. Despite the same time, nearly 2/3 screened positive to have risk of malnutrition. So what did we found? We found that the patients received intervention had a significant improvement in their diet quality measured by the Healthy Eating Index 2020, as you can see from the green line here, at both 3 months and 6 months. And those who on the control group, which on the blue line here, also had some increment, right, in diet quality, but you can see the increase was smaller and was not statistically significant. So overall, those who received intervention or the intervention resulted greater improvement in diet quality in the intervention and in the control group. And the difference in the Healthy Eating Index 2020 was statistically significant at 6 months. And for weight, both the intervention and control group reduced their weight over the course of the 6 months. However, the patients received intervention had a significant lower percentage weight loss compared to the control group at both 3 and 6 months. And also I want to point out is when we stratify the analysis by malnutrition risk at baseline, we found that the lower percentage weight loss in the intervention than control group really driven by those who were screened positive for malnutrition at baseline. And you can see from the left that the intervention control group really didn't differ if they were not screened positive for malnutrition risk at baseline. So these results suggest that the food as medicine intervention could be more effective when targeted to those who are high risk of malnutrition at baseline. So this is my last slide. We also evaluate treatment interruptions as part of secondary outcomes, and we evaluate treatment interruptions using the relative dose intensity, RDI, which is the ratio of the received dose intensity to the prescribed dose intensity. And we found that those who were on the intervention group, which are the green bar here, had consistently lower percentage of having the RDI reduction for more than 15% and having any dose reductions, any dose delays compared to those in the control group. Regardless whether we look at all treatment interruptions or those toxicity-related treatment interruptions. I want to say that this analysis was done among subset of 161 cancer patients who received curative intent or first-line palliative treatment. So it's not all the population here, and none of these differences reached statistical significance. However, the results are trending clearly toward supporting the benefit of food as medicine intervention, potentially reducing treatment interruptions in patients with lung cancer. I'm going to stop here and give speaker to Colleen.
Okay, so on this side of the room now this time, but what I want to do is talk about lessons learned from our trial, because not all of you might be in a position or researchers to go out and do trials like this, but what we want to do is share some of the key learnings so that it can be applicable to wherever you work and whatever you do. And there was a lot of lessons learned. So this first slide, I just want to show, and I'll talk through some of these lessons learned, but to show that we actually asked the participants. We had done semi-structured interview. This is based on a post-evaluation survey. And you can see on the left-hand side that we asked about nutrition counseling, and that was very well received, as you see, in terms of the counseling being a component to their care and the satisfaction with that. There was some mixed with the meals, but I want to chat about that because these are lessons learned that we all need to hear in this room as we're working with providers and vendors and suppliers and all of this. Okay. So a lot of words on these next few slides, but again, I'm going to break it into the components that we had and what we are doing and actively doing. We actually have a grant pending now that we have adopted many of our lessons learned. And that's why it's important that we share these things while we continue our analysis. And hopefully our main paper will be out here this summer. This is about the medically tailored meals, and how we broke it up is to the elements, and that we would recommend potential implementation strategies, and then why we see this as intended benefits. So we have spent a lot of time conversing about these things. In terms of the meals, I will say it was wonderful working with Manna. They are an amazing provider and supplier, and we're truly a collaborative team with us. Most of the dissatisfaction we found with the meals were related to delivery issues, which I'll talk about. But in terms of those who said, they didn't prefer maybe the taste or the flavor of the meal, some of them just wanted like their wife's cooking or their husband's cooking, and they're like, I want my wife to cook for me, or I love those meals, right? So we had some of that, and this was an older population, and that's fine. What we saw with a lot of the people at first who stated some dissatisfaction with the taste were actually from our MD Anderson group, because they wanted spicy foods, right? And they were like, so once our dietitians were able to teach them how to jazz it up a bit with, healthy herbs and spices, then we didn't hear as much of that. But these are some of the things that we would recommend, and also to mix and match a little bit, to add people, to allow them to offer at different times in their treatment course. We did have, in terms of the meals, some people who didn't want to waste, and they said, you're sending these meals and we thank you and they're great and the caregivers loved them, right? However, we feel like there's waste on weeks we're not eating all that food. So I think a flexible kind of approach would be much better, and to allow for that in these trials. The next one I want to talk about is the counseling. And although we had great satisfaction with our counselors, and that was one of our counselors you saw in the video, fantastic, we did have some folks going, it's just all too much, right? We're talking to this dietitian every week. We've got these meals coming. We've got all our appointments. So again, that human-centered design, but also to keep them engaged by allowing them some flexibility in the counseling. And we did that in the spirit of motivational interviewing as well. So when our dietitians sensed a more ambivalence, or somebody going, oh, it's a bad week, they would engage a little more, but also to back off when they could and just let the person be a person, right, that week. And I think that was important too. So once we were decreasing the meals and tapering those down, we actually increased our dietitian counseling so that they could connect them with services locally that they could continue to eat a healthy dietary pattern. And I will say, you saw on our once we had tapered those meals 3 months, we still saw the diet quality going up after the meals had been tapered down, which really tells us that they did adopt some of those dietary patterns. And, that's so thrilling. Okay, and then I want to give a shout out to the CSO and oncology dietitians out there, because they are essential interventionists, right? And it's important. This is medically tailored meals for people going through intensive toxic treatment with nutrition impact symptoms that often cause them to have the delays in treatment and such. So for this type of food as medicine program, it's absolutely critical, I feel, I'll own that statement, to have dietitians involved in how to manage that. And perhaps not so much for other levels of food as medicine spaces, but we also need people in their trials and even in their programs to really define what you're doing. Tell us the dose you're using. Tell us the frequency. Don't just write, and reviewers hold them to it. Don't just write, we did nutrition counseling. They could have it once a week. We need to know for our trials exactly what they're getting done, so that in the methodology section, so that we can replicate and we can start to be more transparent in what works and what doesn't, perhaps. And then support resources I want to give a shout out to, because we need to do better about this. Many in this room are experts in this area. But if we can start to pull in AI a little bit more to help us to do more of the precision medicine and the tailoring of these things and get AI trained and involved in virtual nudges. Right now, you all know, those that are fun in this room, we're running everything on shoestring budgets and not enough resources. So we really need to be using some of the other technologies that we can to try to and keep our patients engaged in these trials, and also to learn from them. And I think that can help us all. And then, of course, just doing things like involving the caregiver is so important, so important. So stepping back, and again, we'll get you all these slides so that you, when you're planning a program or planning your next Food is Medicine, or however you're trying to get your patients involved, you can do. But from a system approach, I really think where we need to go with this is to always screen patients early and often for malnutrition, and using a validated tool, and also screen them for food and nutrition insecurity, and then refer them directly to whatever you've defined as nutrition services, preferably food is medicine services, because that would encompass getting them the food, not just talking the talk, but walking the walk. So we're giving them the healthy food provisions that we're asking them to adopt and eat. Plus, we're also that would include a dietitian and nutrition support services as well. So those in tandem, I think, are the perfect prescription, right, for all of our patients that they tell us they want access to this. And then to work on that infrastructure and building it and getting implementation scientists involved in teaching us how to do this and to look at the determinants and the barriers and that kind of thing, so that we can then fully integrate food as medicine services and nutrition services into oncology care. Thank you.
Thanks for an excellent presentation. So my name is Robin Yabroff, and it is my pleasure to introduce the next couple speakers. So I want to introduce Dr. Francesca Gainey. She is a physician researcher focused on immigrant health and cancer disparities, who founded several programs at NYU School of Medicine and now serves as the founding chief of Immigrant Health and Cancer Disparities Center at Memorial Sloan Kettering. She leads several major NIH and NCI-funded studies addressing cancer prevention, healthcare access, social determinants of health, and culturally and linguistically responsive care for immigrant and underserved populations. Welcome, Dr. Gainey.
Thanks. Hi, everybody. It's such a pleasure to be here with everyone, like-minded folks, and hopefully new collaborations will grow, and always such a pleasure to hear about the NutriCare study. So I'm going to talk about sort of the trajectory that we have had in terms of building an evidence base. And I'm going to start with the patient who really just got all of this started. So we met this patient who was a mom of 4, including a 8-month-old baby, soon after she was diagnosed with breast cancer. And she told us that to pay for her transportation to her appointments and to be able to feed her family, she had broken her older daughter's piggy bank, but then after that had no money for that. When we met her, she was deciding between medication and food, and like the light bulb went off for us that we really needed to jump in and do something about this. So we mobilized, working with Food Bank for New York City, weekly bags of nutritious groceries and fresh produce, among other household needs. And then later with liquid meal supplements that the patient wanted, and we were able to deliver this to this patient. But this was one person. We realized what is going on with all of our other patients. So while that cancer patients often have increased nutritional needs, but the treatment-related costs, the financial toxicity associated with cancer treatment, and the income loss associated with cancer treatment goes hand in hand with food insecurity. And the food insecurity is a window into other essential needs like housing, transportation, legal services, etc. And all of the ramifications that poor food insecurity have in terms of patient outcomes, emotional outcomes, social well-being, higher depression risk, care delays, costs related to treatment non-adherence, and we're seeing persistent and growing food insecurity among patients after they start treatment, but also when they present for treatment. So, as Colleen mentioned, it's so important for us to all be screening for food insecurity early but often, because as treatment goes on, food insecurity rates go up. So we started by looking at our patient population and really assessing the food insecurity and what resources were available to them, and that grew into several other studies that I'll talk about.
So as formative research that we did in New York City, we found our Safe Direct Cancer clinics, 56% of patients were food insecure, and 38% had low food security, and 18% very low food security. And many of these were patients who were new to treatment. We looked at the comprehensive cancer centers who thought it was a problem for them, but between 18 or 30% of their patients had food insecurity, and that was very low there for the cancer centers. We also had over 70% of patients report that they had lost money since starting cancer treatment to spend on food. And we looked at SNP recipients to see if their food insecurity rates during cancer treatment were different than those who were not receiving SNP. No different. We looked at food insecurity and health-related quality of life, and I found that, not surprisingly, food insecurity was associated with poor health-related quality of life, more depression symptoms, etc. And then I looked at psychosocial sequelae and appointment keeping with two large cohorts of patients, and I found that depression was much higher among those who were food insecure, and in those with more than 4, equal to 4 unmet social needs, the biggest one being food insecurity, were more than likely to end up meeting their cancer treatment appointments. So there are what emergency food resources were out there in our community that were already easy that we could potentially tap for our patients. And I looked at the top zip codes of the patients who were attending the cancer clinics in New York City, and I found out the pantries, which were the biggest emergency food resource, were often restricted in their availability. They had limited open hours. If there were documented error, it was totally daunting because of the amount of documentation that was requested. Even if you weren't, that the largest didn't really meet the needs of our patients. The operating hours did not work with the hours that people had to spend going to their cancer treatment appointments. And so what availed for this look in concert with our patients and our food partners in New York was a food pantry intervention as a start. And this was a medically tailored pantry that was open to patient choice, that the food choices were developed with our patients and with our nutritionists and our dietitians, plus nutrition and cancer baseline education and availability throughout the treatment course, translated into multiple languages, coupled with food navigators who would navigate people through resources in the community, applying for government benefits to which they were eligible and their family members, etc. And we worked with a lot of public and nonprofit partners to be able to deliver the food. And these food pantries ultimately grew to be 15 on-site, medically tailored food pantries in clinics throughout New York City. So we knew we were doing this, but we didn't know what the outcomes were. And we also thought that food pantries, while one important intervention, there were other ways that potentially the food should be delivered in a much more acceptable way to patients, potentially that would give them more agency, and that might better suit them. So we decided to test the impact of the pantry and additional strategies that we developed through an NCI-funded randomized controlled trial of pantry plus nutrition, counseling, education, voucher plus pantry, and then home grocery delivery plus pantry.
And this was conducted with 117 patients. It was a small study at 4 New York City safety net clinics, all cancer types and stages, to reflect the patients that were coming in. The demographic characteristics and the cancer characteristics were the same across all arms. And we found that in this study, treatment completion, which was our primary outcome, was best in the voucher plus pantry arm. And we saw 94% treatment completion versus 83% in the delivery arm and 78% in the pantry arm. In all of the arms, patients became food secure, and quality of life and depressive symptoms improved in all the arms, but were most significant, statistically significant, in the pantry plus delivery arm. Small study, but really got us started into thinking about what else we should be looking at and diving in much more depth into the various interventions. We also looked at the weekly costs of these interventions, which were so low in each of the arms, compared, of course, to the tremendous cost of providing cancer care, which was not getting good outcomes in our patients who were food insecure. And so in our new study, which I'll talk about in a minute, we have added a cost arm, and we do that now with all of our studies. We looked at what people were choosing in the voucher arms, and we found that patients spent the most actually on animal protein, fruits, and vegetables. And when we had our dietitian colleagues really examine the diets, they noted that 77% of the funds were spent on healthy foods. So then we launched a randomized controlled trial of breast and GYN patients who had stage 1 to 3 cancer. 460 people were randomized into the study. This just looked at voucher versus pantry versus home grocery delivery, plus the nutrition intervention and the food navigation. It was a pretty diverse sample, but the arms were all equal. And this is hot off the press, so not for reproduction or sharing, but because we're still analyzing this. And I'm just presenting the primary outcome and then a couple of the secondary outcomes. We have a long list of secondary outcomes, as in your study, Colleen and Fang Fang. So we looked at 6 months into the study. So it was a 6-month intervention. And we found that in every arm of the study, the household food security scores went up, and everybody was food insecure when they started the study. We found that the PHQ-9, we found differences in depression symptoms, and the biggest differences were in the reduction in scores were in the pantry and delivery arms. We found, though, that the FACT-G, we had a different result in terms of the scores, and the best scores we saw for the FACT-G was in the pantry arm, and we have a lot of theories about that. The pantry actually, even though it ran the risk of bringing stigma in because patients were collecting food, even though it was done in a very discreet way, community actually formed in those pantries. Patients were supporting each other. They were sharing recipes. They were sharing strategies. And we've had, through these 6 months of the pantry, a really interesting, wonderful community of patients sort of coalesce. In terms of the treatment completion and the very preliminary results, we found again that the voucher arm had the best treatment completion results, and we're looking into why. And then we're going to do a deeper dive into many other secondary outcomes. But this has led us, because you will notice that there wasn't a food is medicine intervention, to a new study that's a hybrid type 2 optimization study and a multi-level stakeholder process evaluation and a resource utilization assessment. And this is really our attempt to look at all of the options that are out there now for patients with cancer and to look at the best combination, really optimizing the combination of interventions according to patient preference, according to the systems that these interventions are operating in, and really trying to personalize the interventions to our patients. So they're all food insecurity interventions, and we're assessing them singly and in combination, aspirationally. And that's pantry, home grocery delivery, and food vouchers, which we have found to have differential impact across the different spheres that we were looking at, and different costs, and medically tailored meals, which we'll be providing in partnership with God So We Deliver, which is New York based and a very big provider in the food is medicine space, and they've been really wonderful partners. And then doing a really deep dive with our implementation science partners to really look at larger issues such as scalability, policy, and long-term, reproducability. So reflections on what we've learned so far and what we're thinking about going forward. I should say this is not yet funded. It's in limbo. So fingers crossed. We're very hopeful, and we have some strategies if our, to put together a funding package. But in terms of reflections, and one of them is that, we know that cancer outcomes really depend on nutrition, food, addressing food insecurity, addressing other social risks that so many patients of ours have, either in concert with food insecurity or not. We know that food insecurity we don't know yet how often we should be assessing this, so we are doing research into how often food insecurity assessment is needed and other social needs assessment. We also, so we're looking at, we've systematized at MSK adoption of a food security screener, but it's not yet often enough. We know that one size does not fit all with patient-centered interventions, which is why we're looking to conduct the optimization study, and that we know that we need, of course, to tailor everything to patients' language, their preferences for food, their medical needs, their family context, and that we need to do this for all. Food insecurity prevalence has to be monitored at the local, state, and national levels, of course, but also at the individual patient level. We need to be, building the provider and systems capacity. Tip of the iceberg now, we've just scratched the surface. Great to hear about med school education and provider education around these issues. Medicare, Medicaid funding, et cetera, to support these initiatives and other funding. So great to hear the congressman talking about his commitment to this. And then on a bigger scale, what makes people food insecure? I mean, that is obviously a much bigger policy issue, but we need to treat financial toxicity and cancer more generally. And then, should there be universal minimum income? Should there be one for patients who are undergoing cancer treatment? Super important question. Thank you.
Thank you, Dr. Gainey. Another excellent presentation. Oh, I think this is a picture.
Thank you to everyone. A lot of people to do this, as we all know.
Yes, it takes a village. Okay. More funding and acknowledgements. So I'm really excited to introduce our next speaker, Dr. Mateo Benegas. He's an associate professor and co-director of the Center for Health Equity Education and Research in the Department of Radiation Medicine and Applied Sciences in UC San Diego. He leads a robust program of research addressing health-related social needs, including food insecurity, housing instability, transportation barriers to care, and financial hardship. So welcome, Dr. Benegas.
Okay, I'm gonna try to use this. Can you all still hear me in the back if I just use the podium mic? Okay. So I wanna ask you all to walk with me as we consider food insecurity alongside other social needs, as Dr. Yabroff and Dr. Gainey just mentioned: food, housing, transportation. Over the last decade, we've seen there's a lot of research, right, that has made the connections between food and other social needs and health outcomes among patients with cancer, right? Really saying, okay, these issues are important because they affect the health and the health outcomes. And it's really about health equity, right? None of us should be in a disadvantage because we're in a scenario where we can't or we're struggling to put food on our table. We should still have that opportunity to achieve that full health outcome. Well, so what do we do about it, right? What's going on? So what I want to do today is give you a brief snapshot of what's going on within oncology settings nationwide around screening and assisting individuals who have these social needs. Now, the National Academies put out this framework about 7 years ago. It's a lovely framework, simple and practical, right? The 5 A's about how do we really make headway toward addressing these issues. So on the left, thinking about awareness, right? Identifying the patients who have these issues. Adjustment. How do we adjust our care, our treatment plans for the patients who have some of these issues related to the assistance piece, making these referrals to others? How do we help? Moving alongside advocacy, right? Examples like this venue today. How do we really make and build the capacity of our nation to increase resources and then start to make headway on addressing it? Ending in alignment. As Dr. Jury mentioned earlier, creating these multi-sector partnerships so that not any one of us is having to do everything, right? It's the policymakers, the researchers, healthcare system, all of us. So what I'm gonna do is I'm gonna share results from 2 national surveys that really addressed how we are screening and assisting patients with these issues. This first one was conducted within NCORE. Now, for those of you who know what NCORE is, think of it as the umbrella network across our country of community oncology practices that make up the backbone of our oncology clinical trial system, right? So they're the ones who are spreading and opening these trials to millions of us across the country. So the importance of this is the reach, right? We're across the country asking, what's the infrastructure for screening and assisting these individuals? So of the 260 almost practices that responded, great news, right? Almost 80% report we're screening for these needs. And when we ask them, okay, well, how are you screening? Almost 80% again said, well, through the social work assessment, right? Others said, well, we have some kind of a survey, most of whom said, we use the NCCN distress thermometer. It's practical and it's available, right? We're using it in oncology settings. Others use some other kind of tool. Then we asked, what or which of these social need domains are we screening for? As you can see here, transportation, almost 100%. Other issues like family support, food, they're at 80%. Now, how about assistance? Well, shout out to social workers again. They're doing a brunt of this, right? Almost 90% of practices said, yes, the referrals are to our social work. Although there were other options like providing materials, educational, maybe a resource sheet, or referral to a community resource organization or patient navigator. So this is just one snapshot from the first survey. Second was a survey that was conducted by NCI that focused specifically on 3 issues: food insecurity, housing, and transportation. Now, the importance of this one is that it was administered through NCI designated cancer centers. So, right, over 70 centers across the country. And the importance here is that it gave us a slightly different perspective. And the results I'm going to share are really kind of supplement the ones that I just showed you from that other survey. So the first one was, we asked them, what percentage of patients do you all estimate are being affected by these 3 different types of social needs? So you can see that on top, food insecurity. We see about a quarter of these cancer centers said that between 11 to about 25% of our patients have food insecurity, 15%, about a quarter to half. And you can see as we move down, both housing and transportation, we see that about 30 to 40% of the patients are estimated to have one of these needs. Another interesting point was, when asked, of these 3 social needs, which do you all think is impacting your patients the most? Now, between these 3, the cancer centers thought that transportation was the one that really stood out as impacting the care they provide. So then what about the screening, right? How often are we doing it, and to whom are we doing it? So this first image on top shows that, okay, about 40% of the cancer centers are screening at new patient visits. Wonderful, right? Screening early on in this cancer journey, hopefully to address these issues early. You can see that about a third said, we're screening occasionally, maybe once a year. And as you move to the right, you can see here that about half, though, said, well, yeah, we're screening, maybe at the first patient visit, but not at any specific interval, right? So there's not a systematic screening frequency. Then as we move down, okay, we say, so who are you screening then? So what we showed, thankfully, is that, about 60% said we're screening all patients. Wonderful, right? This is a great way for us to universally get a sense of how are these issues affecting our patients. About 20 to 25% are doing it specifically for people on certain cancer treatments or certain cancers. Also maybe considering people who either have Medicaid or uninsured. Then we asked them, now the step for the assistance piece, right? Addressing these issues. What are some of the barriers you all are facing? Now, on this slide and the next, I'll show you, this first one's focused more on like system barriers, organizational barriers. And on the column there on the left, you'll see the different barriers that were offered. And then for each of these needs, cancer centers were asked, did this barrier affect being able to address this particular need? Now, you'll have the slides so you can walk through them more closely. Here I just point out a few that I think are common and that affected all of these needs. So, insufficient finances, right? You heard a comment about that earlier. It's expensive, and we're really not funding our systems in a way to really systematically address these issues. Lack of staff. I don't know any healthcare system that would say we have enough staff for this, So it makes sense. Related to that, limited infrastructure, right? We're a healthcare system, right? We're not really built yet to systematically address these needs, right? Again, so these barriers, they make sense, right? There are some unique barriers for some of these issues, and again, you can review them when you have the slides. But I'm really trying to just highlight the ones that are common. Next, clinician level. What are the ones that we think the clinicians, and not only physicians, nurses, social workers, this is more broadly, right? Healthcare staff, let's say. So, insufficient time. Makes sense. The physicians, the clinicians, the providers barely have enough time, often not always, just to get through the routine encounter, right? So adding this additional step of asking and potentially assisting these individuals is tough. These next two are connected. It's a mix of lack of training, but also just information about one, how do we have these conversations, right? We have to do it in a way, an approach that's sensitive, that understands the lived experiences of these individuals who may be experiencing these issues. So it's not just a cookie cutter question. We have to approach it strategically. And then thinking about this external resources, again, a lot of our staff aren't really trained. They don't have that information about how do we connect individuals to resources. If we don't have them in the system, if they're available, what's that connection? What's that pathway, that warm handoff, right? So thinking then collectively about these two surveys and the results. One, it looks like we're screening a lot, right? Almost 80% of us of our centers are screening, mostly through social work evaluations. Some of us do have a screener. It's the NCCN distress thermometer, a tool now validated to ask us information, but it's, again, practical, it's available. We use it often. And we see that we're screening for a lot of these different areas. Yes, I sure can. Second, social workers, again, shout out to them. They're doing a lot of the heavy lifting in this space, the screening and the assisting. And when we think then about how often, okay, it looks like at least at the new patient visits, but not in any systematic frequency, right? And then when we look at the barriers, we're seeing, right, it's just an overall lack of infrastructure. Okay, we understand, but we could build, right? We can make headway in this space, not only by training, but better funding this area. So just some ideas moving forward. What do we do, right? Well, the vision would be, can we elevate food insecurity, housing, these issues alongside some of these other health outcomes that we consider, right, as important within the healthcare context. Some of the priorities would be building that infrastructure, not only documentation, identification, but the workflows, the platforms to collect and then refer these individuals. Why? It's important, right? We see a lot of these accreditation bodies, federal and state agencies are now asking us, can you collect this information that's important, right? Because of a lot of work that many in this room have done. And then lastly, building that capacity. Again, as Dr. Jury and others mentioned this morning, we don't have to do it alone, right? These multi-sector partnerships are key to us making headway. We're the healthcare system. Can we do certain activities? One piece of it. Let's connect with the social service organization in the community that have been doing this for decades, right? They're the experts in this space. How do we connect so that we can create an effective integrated system? And then last, right, this advocacy piece again, you all in the room, this effort really to elevate this information to say it's important for us because it impacts the lives of our patients. So thank you to a lot of these folks. Thank you for your time. I appreciate it.
There we go. Thank you, Dr. Benegas, for an excellent talk. I'm going to invite all of the speakers to come sit so we can have some Q&A for the next 15 minutes or so. And that slide tells you exactly where we are. We're at Q&A. So if others in the room want to go ahead and line up at their microphones with your questions, people online who are not in the room, please go ahead and send your questions in and we will have them. I'm going to start with this is a little unstable up here. I'm going to start with a question to all of the presenters. And I appreciate the fact that you talked about lessons learned. The question is, what can we apply now to inform care and patient outcomes? And I'm going to add, especially in the context to recent cuts to social services like SNAP and Medicaid. So I think there's one microphone. Who wants to get us started?
Start. I think that partnerships have always been super important, but never more important than now. I think together we bring our resources together, and that helps us to help more patients. And I think the advocacy is also really key. And we might have more success locally and advocating locally with local departments of health, local government, et cetera. Many local officials want to step up to the plate and have been stepping up to the plate. So I think partnerships, looking for local solutions to fill some of the needs that have grown because of changes and cuts that might have happened federally, and and continued advocacy, et cetera, as a start, is one of the.
Yeah, I'll just make a pitch for research. So I think that we need to be a louder voice than the voice that doesn't have perhaps the evidence behind it. So I think we need to continue in the research space, showing people what can really be done. I know one thing I do appreciate about MD Anderson is we have a lot of effort that goes into bringing together industry and research partnerships and doing that in a way where we're still in control. And then I think that's an area that some of us I'm increasingly teaching myself to be more open to. It's something we don't really get raised up on, if you will, in research. But I think that just continuing to get the research funded, the research published, and the attention on real results, I think is important, but it's going to be stuck if we don't address the first point, which is to do the research in the first place.
Okay, I guess I'm going. So, I think I would just say, I'm been around a long time, and I think we all need to always keep thinking out of the box. I think we need to, in the midst, this is not the first change I've seen over the years, so I would say in the midst of a lot of change, there's often opportunities for golden nuggets of thinking differently and coming out, looking for different things like perhaps local partnerships or different research funding. ACS has still a ton of funding. American Heart Association, people are stepping up and doing those things. So, but I think that's really important to do. So in the midst of some of the change, we find those things and we keep working because we do it for our patients, right? And it's quality of life. So you keep trudging along. And I'm incredibly hopeful because this is the first time in 30 years that I've heard so much conversation in and around nutrition and about its impact and direct link to health and health outcomes. So, we have to navigate some changing field, However, I think it's possible, and I think we're going to continue to see that. So I think it's a great opportunity for everyone in this room and these kind of things. We never had these summits like this 5 years ago. We didn't talk about this. So I'm incredibly hopeful for those reasons.
Yeah, I would say, I would like to advocate definitely more funding from NIH, from American Cancer Society, other funders to support additional research. I think we've done RCTs, but it's also important to evaluate the effectiveness in the real world setting. For example, the cancer patient receive food as medicine program under the Medicaid 1115 waivers, right? I think we need the policy to advance, not just a waiver, you get 5-year renewal, but really make this as a permanent routine component of cancer care. And also heard so much about implementation. We shout for implementation scientists in this room. I learned so much like working with them to develop proposals. And I think that we really need to advance and to understand and to address this multi-level barriers we've heard that can prevent the translation of science into practices. So the one thing that I like my colleague Erin Hennessy, that when we prepare the grant, that she said it, we not only need to understand whether it works, but how do it work in the real world and how do we make it work everywhere?
Thank you so much. I'm going to give the next question to Dr. Joanna Lena.
No question. Just want to follow up for the pitch for research that the American Cancer Society has our next grant submission date, June 1st, 2026. And we really put an emphasis on early stage investigators. So I want to draw attention to the Research Scholar Grant for people with a faculty appointment. when you submit your application, you have to be within 8 years of your initial faculty appointment. And I'm happy to talk to anyone. Find me. I'm in the bright green.
Excellent. Thank you, Dr. Elena. The next speaker, would you mind stating your name and affiliation?
Hi, everybody. My name is Adam Shayevich. I'm the Chief Program Officer at About Fresh. We run the Fresh Connect produce prescription programs around the country. Last month, Doctors Kurt Hager and Seth Berkowitz released an op-ed in JAMA calling out the phrase social determinants of health as a problem because food is medicine, at least in their language, is a biological determinant of health shaped by social forces. And they said one of the consequences of this terminology is that food is medicine, at least, is getting relegated into a parallel but separate structure of care that is disassociated or increasingly disassociated from the point of care or ongoing care delivery. I'm curious if you've seen that in your own work, and more importantly, if you've seen any negative outcomes associated with the relegation, for lack of a better word, of food as medicine interventions into these parallel structures. So folks get referred out to a separate system. That separate system then takes care of screens them again, refers them to a food as medicine solution, manages that enrollment over time, but without much feedback in return to the healthcare setting where these patients are receiving ongoing care. So again, I'm curious if you've seen this in the research at all, if you've seen any negative consequences, I'm curious to hear your thoughts. Thank you.
Yeah, so I think that was an interesting paper for sure, and I agree. I personally think that everyone coming in for cancer care should be screened for malnutrition every time because, for instance, our study, more than half of them came in at diagnosis overweight or obese, but over 60% were malnourished when you screen for that. So I want to put the plug in for that using a validated tool. I also think, and I said that we should screen for those that we deem food and nutrition insecurity. I know the social determinants of health are screened inpatient, and at most outpatients now they're doing this as well. But personally, I think every single person, just like the malnutrition screening, no matter, I think everyone should have access to nutritional care during treatment because we know the direct connect between nutritional care and optimized nutritional care and cancer outcomes in so many ways. And we're starting to prove that. So I think that's important. So I agree that we don't want to tear it out or segment people. I think everyone should have the opportunity. And we also know because cancer is a very expensive disease and causes a lot of financial toxicity for even those that would screen negative for food and nutrition insecurity. They also could benefit from the nutritional care, or it's also very cyclical that we might miss it because of that. And overall, and Dr. Gainey can certainly attest to this, food is cheaper than the cancer inpatient or a hospital visit or an inpatient length of stay or an ED visit, right? Giving people the food, we're talking it's very reasonable, or vouchers or whatever. And dietitians are pretty cheap, So I hate to say that, but it's the fact of life when they can get to it. So we find that the costs offsets for sure the negative consequences of not providing these services. We are now baking them into our studies as well, as so is Dr. Gainey. But you're right, we need more research to show us those differences.
Just to speak to the fragmentation that you're talking about, somebody gets referred out and then you never hear anything. They're increasingly, since so many institutions are using the same electronic health record, and now a lot of these partners are also potentially connected to the electronic health record, there's a really good opportunity to close the loop and to make sure that that information gets returned to the provider and that there is ongoing dialogue. And that's something that isn't automatic, but is very doable now with the electronic, Epic, essentially, with the Epic electronic health record.
So I think one of the other issues is like PHI flying back and forth. MD Anderson would have a cow over that, right? So I think, again, the plug for dietitians, having the dietitian rooted in the clinical center as part of the care team, and somehow having a partnership where that person is still keeping the information internal. I mean, that's what we're looking at on the research side, and that's what you guys have achieved. So I think there are real barriers to doing things that way at some of these larger cancer centers. Now, I don't know if maybe that's really happening more in the community, perhaps, where there are not the resources at the local care centers. So I think there's definitely probably a divide there as well.
Thank you.
Next question.
Hi everyone, good morning. Great presentations, I've learned a lot. My name is Prama Kauta, I'm at NIH. We heard earlier through the presentations, enhancing gut microbiome can help to improve the immunotherapy outcomes. I am just wondering if you kind of improve that gut microbiome before, is there enough research, maybe earlier, would that be additional benefit, or if so, the bigger question is, what are some opportunities to perhaps add this to wellness checks, or, I don't know, making people, I mean, I know it's thinking way ahead, but I was just wondering.
No, so I mean, my talk really focused on the cancer patient arriving with the diagnosis, embarking on treatment, but obviously the gut microbiome and diet in combination are very strongly linked to a host of different preventive conditions. Everything from obesity to high cholesterol. It's important for cardiovascular disease risk. There's a huge amount of research in the diet and gut microbiome space there as well. So certainly things that you would want to change in your lifestyle to improve your gut health or your gut microbiome are going to pay off in spades in other ways. But I think that was sort of actually already accepted. Everybody is already told to eat that gut microbiome healthy diet, honestly, as a part of numerous guidelines prior. So what we're really focused on is sort of understanding how this can be used as a tool, like an ally or a tool in parallel with therapy, and understanding how we target what's happening in the gut microbiome with how that interacts with the immune system and the therapy targets. Again, going towards this, what evidence do we need to get this into the clinical care program? Is this as effective as some of the other drug and other therapies that are way more expensive that are out there? That's the goal. I'm not involved all the way in all the pieces, but definitely thinking about that in the beginning.
Thank you. So it's really from a prevention perspective, we have some work to do.
It's a good idea in all cases.
So now we have time for our last question, which is going to come online.
Yes, I want to, there's been some great feedback online, and this is to those who worked in NutriCare, but I think can be expanded to the other panelists as well. Can you share a bit more about how you got everyone on board and meeting resistance and trying to move this kind of work forward in the space?
Yeah, I think that, to get everybody together, right, on this, I think it's to recognizing that malnutrition is a very important problem for our cancer patients. And I think many of the speakers mentioned that malnutrition screening is happening, but it's happening only at half of the cancer centers in the nation. And when malnutrition screening occurs, that a lot of them are occurring at a late stage when nutrition deficiency is already advanced. I think we really need to get the cancer centers together to recognizing its importance to do regular malnutrition screening and to identify the needs of the cancer patients and during treatment, and also importantly that a large proportion of those who complete treatment, cancer patients complete treatment, that they have higher cardiometabolic disease burden. We look at this in our data, and I saw some cardiologists also in the audience, that I think it's also a need that needs to be recognized together as a community, that we also wanted to address the needs of food is medicine program, how to integrate food and nutrition services for cancer patients complete the treatment when they're transitioning, for example, to the primary care physicians along the cancer continuum. And I think we have to support our amazing food is medicine providers, a lot of them are community-based nonprofit organizations, and to help, to partner. And I think that the question asked by Adam is the gap, right? Right now, there's a gap that we need to close, we need to connect better between the clinic and our community-based organizations to make them to be smooth. And of course, the policymakers, we want them to hear the payers in the room and to generate more data with regard to how food is medicine programs can impact the healthcare utilization, the cost effectiveness, and to reimburse our dietitians to food nutrition services as part of the standard oncology care.
Thank you. I would say for me, the focus on this issue really arose from our focus on financial hardship, right? Financial toxicity, looking at the cost of these issues to our patients and realizing that they of course, they struggle for paying for the medical care, but it's also these non-medical issues that they face, right? And when food is just one of them in a mountain of other issues that we see as they begin this cancer journey, right? The systems start to realize, hey, we have to focus on these issues if we want our patients to be able to, again, right, even achieve these health outcomes that we expect, right, that we're treating them to hopefully achieve. So I think the more research we're doing, advocating for in this space, of course, will hopefully lead to some of these changes.
Okay, so looks like we are at noon, which at a meeting on food is medicine, I do not want to keep you from lunch. So please join me in thanking all of our excellent speakers. Also, for those in the room, please feel free to go up during lunch if you have additional questions that were not addressed. The online questions, we'll do our best to address them as well. So thank you so much, and we'll see you after lunch.
All right, thank you. We have a little bit of a change in the agenda. We are going to go directly to the current initiatives, innovations in food as medicine delivery, and then we'll do our patient panel after that. So I'll invite Emily Callahan, the moderator, to come up.
Good afternoon, everybody. I'm Emily Callahan. I'm the Director of Policy Strategy for the Food is Medicine Institute at Tufts University. I'm also a registered dietitian by training, and it is just thrilling as a dietitian to see the attention on the role of food in prevention, management, treatment, and recovery of disease. And this panel, it's scheduled as session 3 on the agenda, but we're being flexible today. So we're now session 2. It's called Current Initiatives, Innovations in Food as Medicine Delivery. And so we heard earlier about the evidence for these interventions. And now we're going to be talking about where the rubber meets the road, or to continue the March Madness analogy, where the basketball hits the court. And so how are we doing these things in practice? And we have some excellent presenters who are going to share their experiences doing that today. Our first speaker is Alyssa Wasung. Alyssa is the Executive Director of the Food is Medicine Coalition, a national coalition of nonprofit organizations that provide medically tailored meals and groceries, medical nutrition therapy, and nutrition counseling and education to people in communities across the country living with severe and chronic illnesses. Alyssa has been engaged in food as medicine work for 15 years and is focused on creating a more accessible, regenerative, and efficient healthcare and nutrition ecosystem. Alyssa, over to you.
Hi, everybody. I'm going to make sure that my slides are up. Oh, should I keep going? Okay, that was me. So first of all, I just want to say thank you. Thank you for spending time on this worthy subject, for all the research, policy, advocacy, implementation that all of you are doing on the ground. Thank you to the American Cancer Society for all that they do to bring us together here today, out in the field as well, for the partnerships that we've had together through the ABC grants and partnerships around Hope Lodges. You're going to hear and have heard already about some of the incredible work going on with the Food is Medicine Coalition. Dr. Gainey partnering with God's Love We Deliver, which is a medically tailored meal provider in our coalition. Later you'll hear from Food and Friends, and then Manna with Dr. Fang Kangsheng and the NutriCare study. So I'm not here to talk about practitioners necessarily. What I'm going to do today is actually talk about how we create a system of care, a little bit of that rubber hits the road piece that supports those who need it where they need it. And so just a little bit more about our coalition before we jump into those structural pieces. Food is Medicine Coalition, as Emily said, supports nonprofit medically tailored meal and grocery providers across the country. Our agencies have been in existence for over 40 years and actually created the medically tailored meal intervention at the height of the HIV epidemic as a response to community care. Since then, we've expanded our missions. We're now serving people living with severe, complex, and chronic illnesses, and we're going to talk a little bit about the focus on cancer in a bit. But today, what we are gathered together to do is to advance policy change that creates access, research and evaluation that continues to build the evidence base, and importantly, best practices that mean that actual humans get really good food, right? Because that's why we're here. And so with that, I also want to say a little bit more later about our programs where we're scaling community-based provision through a training program called the Accelerator, where we teach programs to deliver, new programs to deliver medically tailored meals and sort of scale that way, creating communities of practice where people are sharing and not reinventing the wheel. Anyone, right? And then finally, we have created the first ever accreditation standard for this service. So without further ado, just to give you a sense of sort of scale and scope, last year across the country, our agencies collectively delivered 21.4 million meals and meal equivalents through the 3 different Food is Medicine services, medically tailored meals, groceries, and produce prescriptions. These were all delivered free to the client, to the tune of 62,000 clients receiving these services. And we also support upper right-hand corner for those here and online. We support families, right? 18,000 dependents and caregivers also got services through our agencies. Really important, I think, is that these services are delivered to people of all ages. So we're not necessarily focusing on older Americans or children. If you are sick and hungry, we can serve you as long as you can eat a meal, right? All right, so the next thing that I just want to talk about is you're going to hear a lot today from me about healthcare. You've already heard from wonderful researchers that are way smarter than I am about how food as medicine should be included in cancer care. But despite all this research and the healthcare pilots that we have, right now it is not part of the standard of care. So our vision is a future state where it is, where anyone who needs this intervention has access to it, and that it is of the highest quality and not based on where you live or your ability to pay for it. Really importantly, I described our start at the height of the HIV epidemic. The first population our agencies expanded their missions to were people living with cancers, all different kinds of cancers, right? And that was because everyone saw what was happening with the great outcomes people living with HIV were having, and they picked up the phone and said, hey, can you serve my friend, cousin, former coworker, etc.? And so from that knowledge, we then were also able to expand to different illnesses. And it becomes sort of a symbiotic circle as well, where you're starting to see, at least in our client populations, people living with 4 illnesses at once, right? They might have HIV and cancer and diabetes all at the same time. And so these nutrition practices reinforced one another. On the right-hand side of this slide, you can see our most recent survey numbers. And so while diabetes and heart disease have outpaced other illnesses in terms of the prominence in our client population, cancer is still third, right? Still primarily what people are coming to us in need with. All right. All of this complexity has really led to what we call a culture of care. So yes, it is about delicious food, and it's about making sure that people are getting the right food for their illness, but it's also about following people through the trajectory of their illness, like from chemo to radiation to surgery, right? We are there when you don't feel well and you don't want to eat that soup. We have something else for you, right? It's about feeding families, because that's a huge stressor. It's about RDNs and education and survivorship and cooking for your life after, right? Birthday cakes and walks and runs and providing food to the advocates and folks who are doing that. And then I think especially beyond the cultural appropriateness of the food that we supply, making delicious food, right? Appetite is the first thing to go when you are sick. And it is critically important that we are feeding people food they want to eat, because it doesn't do its job, just like medication doesn't do its job when you don't eat it. And so we need to just be focused on delicious food. Food is medicine, but it doesn't have to taste like it. I like that over there. Thank you. So I am not going to belabor evidence. We already heard, again, from wonderful researchers. But why everyone is so excited about these food as medicine interventions is that they produce wonderful outcomes, right? Not only health improvement, but that middle column. Healthcare is very excited about that middle column. So are we. We want to see a more efficient healthcare system where we're rightly using our resources. But those outcomes kind of don't happen unless we're delivering a really robust service, right? You can't expect the same thing if you're not delivering the full intervention. So before we keep going, I want to take a minute just to talk about what is medically tailored meals. So this is a wonderful example of the medically tailored meal intervention, the way our agencies deliver it. It starts with a client referral from healthcare. I loved Adam Shayevich's question about creating parallel systems of care. We try not to do that. We try to engage with the client care continuum. We require engagement with healthcare, whether through the plan or through a doctor confirming diagnosis. The person can still come through the community, but we're still going to follow up with the doctor, right? And then they move through an intake and a nutrition risk assessment with a registered dietitian. And that's where all of that amazing stuff that Colleen and other people were talking about, that engagement with the RDN. And it's stressful when you are sick to know what you should be eating. Anyone feel that? I feel that. I felt it from many of my family members. And so having that personalized moment where there's a meal plan created for you that's dealing with all those complex things embeds client choice. It's then cooked. Those meals are cooked in our kitchens and often blast chilled and flash frozen, and then sent out to people's homes to really answer the needs of people living with activities of daily living limitations. And then it repeats, right? And people are reassessed at regular intervals. They can always call an RDN and actually have an interaction and say, my medication's changed, what do I do? So it is this intervention made from food that is not full of added preservative starters or fillers, but real food that is actually producing the outcomes. And we felt it was really necessary for our clients and for the future of the field to actually take this and synthesize our 40 years of experience into a standard. So we went through a really in-depth process with a standards making body, SCS standards, and the input of our experts and our coalition, and created this medically tailored, a bit of a mouthful, medically tailored meal intervention accreditation criteria and requirements. It has 8 different pillars, and they're quite complex. They're dealing with everything from food safety to delivery to cultural sensitivity when caring for clients. And it has been rolled out publicly, which is very rare in standards making. We wanted it to enter the public knowledge, to be talked about, to be a living, breathing document, and also to be a guidebook. Like if anyone wants to deliver medically tailored meals, this is how you do it, right? Finally, we also wanted it to enter policy conversations. And I am pleased to report that it actually has. 3 states have adopted our nutrition standards as part of their guidance for their state-based interventions, as well as DC. So what does this look like in practice? For us, this is our answer to scaling. We, like I said, run 3 programs. We run the accelerator, where we teach new programs how to deliver medically tailored meals according to that standard. We have a membership program that increases capacity through technical assistance to achieve accreditation. And our goal is really to build community power as we are scaling food as medicine. To date, we have actually accredited 14 agencies. Last week, a 14th agency was announced, Meals on Wheels People. They're actually an accelerator graduate, so the pipeline works. Woo! And then down at the bottom, we've graduated 22 agencies so far over the last 5 years of our accelerator program, which we partner with a variety of different entities on God's Love We Deliver, Community Servings, Center for Health Law and Policy Innovation, and the Nonprofit Finance Fund. We have our first international agency, Fair Share in Australia, and this year we have 6 more agencies enrolled. So for us, it's just really, really emblematic of the fact that so many are doing this good work in community, and we really want to be empowering them to continue that work. This year, we are also embarking on medically tailored grocery standards, all the acronyms, right? Medically tailored grocery standards, and we're excited to be looking toward a release in 2027. I wish I could stop for questions, but I think those are coming later, so I'm gonna go right into policy. And in terms of taking all of this innovative work that we're doing in defining the intervention and trying to ensure quality, like all boats rise, where our agencies are not, at least people can refer to this standard and deliver services accordingly. I want to talk a little bit about systems, and when I think systems, I always think policy. That's where I come from. So I'm going to talk a bit about how access looks in the public insurance infrastructure. I want to be clear that there is so much going on in this field right now, very much speaking from the Food as Medicine Coalition perspective and where we have worked this year. And I want to start with sort of an assessment of the gaps. Then I'm going to talk through how we're speaking into those gaps and trying to offer useful and practical resources for folks doing this work on the ground. So first, at the top of our system is all the boring stuff. I like to call it the boring stuff. I don't think it's boring. Other people do. But things like definitions and coding, and how do we actually integrate nutrition services into the structures of healthcare, which are very rigid. Anyone, right? Very rigid. There is a lot we can say about how they actually fit into the structures, but we need to say it. So up at the top, we're going to talk a little bit about those structural pieces, and then thinking through where folks are able to access, largely in our public insurance infrastructure or in infrastructure for special populations. Those are the folks that we tend to serve, so that's where we focus a lot of our energy. In Medicare, for older Americans and people with disabilities, there is currently no access on the original Medicare side. So Medicare is largely about 50-50 divided into receiving fee-for-service services or receiving your services through a plan. On the side that's fee-for-service, there's no access to food as medicine right now. So that's a problem, right? Both on the hospital and outpatient side, it's largely provided through community. And when I say access, I don't mean that people are not referring. I mean that healthcare is not paying. And then in Part C, we have really varied access through the plan side of Medicare. And there's been a lot said there. I'll talk a little bit about how we can actually create some guideposts and plus up that awesome window for our clients who might be receiving services that way. Medicaid has really been the engine of food as medicine innovation. So many states and so many localities and managed care entities have seen that research that I briefly flashed across the screen and said, we want to do that. We want to see that happen in our state. And I think some other presenters later, I think Dr. Chen is going to talk about what it looks across the country and states. But this is all sorts of states. This is red states, blue states, purple states, other colors of states. People are saying this is what we want to do. And so it's also very complex, though. There are many different ways that you can leverage food as medicine in the state. And so we want to create some guidance there and helpful resources. And then finally, as we think about moving food as medicine into benefit structures, or like I said, those rigid structures of healthcare, we need to be able to articulate how they fit. Finally, and again for FIMIC, we have also paid a lot of attention to the services that we're naturally giving to veterans and how we make it better, and there's currently no access within the VA's authority to food or food as medicine. I'll say again, there's a ton of other work going on. There's some amazing work going on in Indian health services, in produce prescriptions, like with our agencies, with tribal governments, but I'm going to focus on these 3 areas today. So structural factors, like I said, we've created a standard that we hope is additive to this moment. We're also partnering on a cross-sector group that's creating new codes for food as medicine. To get paid for discrete services, you have to have a code in healthcare, and the code should accurately describe the service. And what we're getting right now is sort of a use of a mishmash of codes that makes it really difficult to study the effects of what we're providing. Over in Medicare, again, Part A and B are no access, right? Part A hospitals, B outpatient. And so there have been some really exciting opportunities just in the last year to comment on whether that should change, right? In Part A, I'll speak about a bill that is in Congress. It's honestly been in Congress for quite some time, but it has a lot of support. It is bipartisan, bicameral. It's called the Medically Tailored Home Delivered Meal Program Pilot Act. We call it the MTM bill. I suggest you do too. It's a bit of a mouthful, but actually Representative McGovern, who you heard from earlier, is one of the original co-sponsors of this bill. It was recently introduced by Mr. McGovern, Representative Malliotakis, he actually mentioned it, and a suite of other folks on the House side, and then Senators Booker, Cassidy, Marshall, and Smith on the Senate side. This would create a big research pilot coming out of the hospitals in Medicare and really test, does medically tailored meals work in frontier communities and rural communities and urban communities, and sort of lay to rest that question for all of us, does it work? In Medicare Part B, we saw a really extraordinary opportunity to comment on whether the federal government should create a medically tailored meal benefit through the Incident to pathway. It's a bit of a complicated pathway, but the fact that this was part of a public comment is just groundbreaking, earth-shattering for those of us advocates that have been doing this for a while. So we were grateful to team up and provide a very technical comment about actually how this could happen, like how they could actually create a benefit and how it could mirror that robust intervention that I noted. Finally, there is kind of a litany of public comment over many years about adding some guideposts to the allowable food that could be delivered through a plan, making it more high quality, also making it primarily health related, classifying it as that. You're going to hear a lot of like, put this in healthcare, put this in healthcare, put this in healthcare. The theme continues. And here, this is just the most recent one, but you can definitely go to our website and read our recommendations there. And we believe that it will certainly result in better outcomes. So in Medicaid, on the right-hand side of this slide is just some of the authorities that states can use to cover food as medicine, groceries, meals, and produce prescriptions. It's a lot. It's a lot for community-based advocates, right? It can be a lot for Medicaid state agencies. And so we partnered with the wonderful folks at the Center for Health Law and Policy Innovation and kind of took everything that had been said and allowed about piloting using flexibilities in states and summarized it for folks as a reference guide. And then at the end, we put in some cross-cutting recommendations for working with CBOs, and for thinking about data as you decide to draw down on these great opportunities. And then finally in Medicaid, and then I have one more slide. I know I'm almost at time. Remember that benefit piece under Medicaid. A lot of what we have seen in food as medicine has been developed in really flexible, allowable structures like waivers. You can do a lot in waiver that doesn't actually fit into healthcare. And so what this blueprint does is actually say, what are the legal and regulatory requirements for medically tailored meals to fit into benefit status? So it goes through things like medical necessity. What is the AMA? What would that AMA lens say about who should get this today? Benefit category, how to pay for it, monitoring and evaluation. And it sort of synthesizes all of that into a blueprint so that we can start doing it now, like not building in the flexible structures where maybe one day we'll have a benefit and we have to sort of turn the ship toward that way of doing things. And it will, I think, help us to build more efficient structures as we move medically tailored meals into healthcare. And my biggest takeaway here, having worked so deeply on this project, is how much we can say today about how it fits into healthcare, the rigorous requirements of healthcare. And then finally, we are so pleased to partner with the Food Security Office at the VA. There's not a payment mechanism, but there are active referrals and FIMIC VA site pairs that are actively working together to serve veterans better. So this is a MOU centered around education, around cross-pollination, hopefully eventually looking at data sharing to make veterans' lives better and to make sure we're serving them in a culturally competent way. So for each one of these gaps, we're really trying to speak into practical, useful tools. For Part A, it's the bill. For Part B, it's that RFI and the structure of a potential benefit. For Part C, it is some guidance on how to do it even better. In Medicaid for states, we have our toolkit, and then for benefit structure, our blueprint, and then our MOU with the VA. And so we hope that all of this creates a real systemic approach to wherever someone is, we're able to answer them with a meal that's right for them. I hope you'll stay in touch.
In case you couldn't tell, there is a lot going on. I know Alyssa could have given an entire presentation on any of those things in the last slide she just shared. There's a lot of exciting activity, a lot of bipartisan interest in this topic. Our next speaker is Dr. Stephen Chen. He's Chief Medical Officer of Alameda County Recipe for Health, a regenerative food as medicine model that intentionally sources from local, regenerative, and organic farmers with inclusion of BIPOC-owned farms. By bringing together local community health centers with local farms and agriculture, Recipe for Health improves food and nutrition insecurity, chronic conditions, and health and racial equity. While leading the scale and spread of Recipe for Health, Dr. Chen and his team successfully implemented one of California's first medically supportive food and nutrition services as a covered Medi-Cal service in California. Welcome, Stephen.
Good afternoon, everyone. Thank you all so much for this opportunity to be before you in front of the American Cancer Society. What a great gathering of folks here. I want to do a quick pulse check with who's in the room. If you are a healthcare provider, please put your hand up. You could be a nutritionist. You can okay, we got some here. Wow, there's more here. Okay, how about chefs? 1, 2, maybe. Okay, farmers. Any farmers in the house? Okay, that's going to be part of my conversation that I'm sharing with you all. We are in system silos between food, agriculture, and health. And I like the quote from this person named Wendell Berry, writer, environmentalist, farmer. People are fed by the food industry, which pays no attention to health, and are treated by the health industry, which pays no attention to food. I think that's changing with the work that you all are doing and that we're all trying to do, but I think that's held true, certainly 25 years ago when I was in medical school, and with the new residents today, there hasn't always been that connection. I like to just add my own little corollary. Both the food and health industries pay no attention to the land and soil. And soil is really the microbiology and the microbiome of our land. And land, we have personal connection, family connections, trauma, and a whole kind of cultural piece to the land. And I would just argue that a regenerative food as medicine pathway has the power to bring the silos together. So what are we actually facing? From a health challenge perspective, our food environment is not very healthy, right? We have over 50% of our caloric needs from ultra-processed foods. And we know these ultra-processed foods are associated with 32 different adverse health outcomes, leading to more and more chronic conditions. We also know that food insecurity is a driver for chronic conditions. And I know that many folks spoke earlier, Mateo was speaking about, and other folks were speaking about the social determinants of health. If you are food insecure, you have a twofold increase of developing diabetes compared to if you're food secure. So all those little kids that show up in our clinic who don't necessarily have a condition yet but are food insecure will be developing that diabetes and coming to our clinic downstream. And we know that 6 in 10 of you in this room have a chronic condition. So this is kind of the landscape in which we're facing from a healthcare perspective. But let's also talk about the ecological challenge. The way we farm, the way we grow and produce our food is depleting the ecological foundations of our planet. Soil, 95% of our food is grown in topsoil, and yet the way we farm, the way we ranch is actually destroying that topsoil. Waterways pollution, see that dead fish in the water with all that algae? Agricultural runoff is basically contributing 78% of this algae bloom stuff. It's called eutrophication, is from agricultural runoff, all the fertilizers that we use. And we know in rural areas that groundwater is contaminated from that agricultural runoff, the nitrates. And I'm going to bring that in because we're in front of a Cancer Society team, so I'm going to make the link in my next slide. And then certainly, how much do you think greenhouse gases are attributed to from the food and agricultural system? Can I get a percentage? Greenhouse gases that contribute to our global warming. And just give me a number. Anyway, 75. Wow, around 30%, 31%. But 31% is still high, and that's just from the way we grow our foods. 75% would be incredible. I think but that it's significant, and so we have an opportunity to bring this all together when we think about certain questions about where our food comes from. Because we're in front of the American Cancer Society, I thought I would just share some of the ways in which agriculture impacts human health. This is an obvious one: occupational pesticide exposure. Our farm workers, the people who are growing the food before us that we ate, they are exposed often to organophosphates and other pesticides. We have a clear relationship, a clear association with all these different types of cancers right there: breast cancer, bladder cancer, prostate cancer, etc., multiple myeloma, lymphoma, leukemia. Every day we eat food, so there's also dietary exposure to the foods that we eat. Now this area needs a lot of research, so ACS, with your big money, big funding, we have some opportunities to check this out. 90% of you, when we looked at your urine today, there's going to be pesticides that we can pick up in 90% of our urine, the people here. And yet, we know that, and this was a study at UC Berkeley, 6 days of 100% organic diet, that reduces those metabolites down by 61%. So what does that do in our body, right? That's a question that needs to be explored. And then I would just say nitrates. So I was talking about the groundwater pollution, waterways. This is coming from our nitrogen-based fertilizers, in which how we grow our food. And we know that there's an association with colorectal cancer, thyroid disease, and neural tube defects. So there's a connection point here. And I want to suggest then that a regenerative food as medicine approach can impact these challenges. And that is really the work of which guides the work that we're doing in Alameda County. So I'm the chief medical officer for our county's food as medicine program. Alameda County, do you all know where that is? Some people do. It contains the cities of Oakland and Berkeley. It is right across the bay from San Francisco. we have a food as medicine program called Recipe for Health. And when I describe this to patients and to providers alike, I say, well, what is this? I say, it is food and health coaching. We're prescribing food and health coaching to treat, prevent, and reverse chronic conditions. So the biological work that we do in downstream care, and to address food and nutrition insecurity, some of the social drivers of health that our patients deal with. So we're doing the both and here. Now the food is not just any food. Our food is specifically produce boxes, local, organic, regenerative from as many BIPOC farms as possible. We're using Medicaid to fund it, so we get weekly boxes delivered to the doorstep, up to 12, and we can renew. We pair that when the patients want it with health coaching. That was a health center that I helped start with a little teaching kitchen in the back, nutritionists, small groups learning, community-based health coaches doing these 4 things: movement, nourishing, connecting, and being. Now, that's kind of like what it is, right? It's food and health coaching. It seems kind of basic. I'm prescribing this for my patients. I want to say that Recipe for Health and the way of how we've structured our food as medicine program acts as a health multiplier. So I want to socialize that concept, a health multiplier. And that happens, and you'll see more, because of the way we ask this question and how we design our program. Where does the food come from? I think many of us in healthcare, because we're siloed, we don't really care about where the food comes from. We just say, hopefully a vegetable is better than a Twinkie, right? And we're good with that. Just get any fresh vegetable in the body, and that's great. But I think if we ask this question, where does the food come from, we can get multiple benefits, and that's that health multiplier effect. We answer that question in the design of our program by intentionally sourcing locally within 250 miles. All of our food is organic, and some of it regenerative as well. And then from as many BIPOC-owned farms as possible. When we do that, we get a health multiplier effect. I'm going to use a little nerdy word or a little nerdy acronym. It's called H-cubed-E. H-cubed-E. 3 H's and an E, and these are the co-benefits. So certainly human health, right? We're prescribing food as medicine. It's great for our patients. But you ripple that a little further out, it's great for our farm workers and the people who grow the food. You ripple that out further, it's great for the community that's getting less pesticide drift. We get economic health, creating opportunities, new markets for our farmers, an aging population that is producing all of our food. Economic health to our health systems, economic health to the patients. And then ecological health, with that impact on the soil as well as the climate. And then we like to thread everything with equity, just to make sure, and for us, equity is really making sure no one gets left behind, because we know many communities have been left behind. And so when you do this, you prevent an economic race to the bottom. And I would just say, who's involved in school meals? Is anyone in this group? So you can look at school meals and you can see when school meals are reimbursed $1.98 per school meal, this is what you get. This is what my kids get. I have twins, they're in elementary school. This is a free breakfast. Frosted cornflakes, Trix, muffins. This is a metabolic bomb that's going to end up in our clinics if this is all my kids eat every day. I want to encourage us as we think about food and where the sourcing of food. How do we think about the food so that we can we can not only change healthcare, but we can also change the agricultural and food systems? So I'm going to now share. This is this whole panel about implementation. How do you do this on the ground? So I'm going to give you 5 ingredients to scale impact. Like any recipe, it has ingredients. So for us, we start with the safety net health centers. We do this work in our community health centers. We then structure and support, and this is an ecological model, right? It's an ecosystem. A food pharmacy, notice the word pharmacy, how we spell it. There's also a behavioral pharmacy, that's our health coaching. But the idea is simple, right? When I prescribe, Annalyn, when I prescribe you a blood pressure medicine, where do you take it? I prescribe you a prescription, I give you a prescription. Where do you take that prescription to fulfill my request for treating your blood pressure? You go to a pharmacy, right? It's local, it's easy, it's accessible. Yet we don't do that when we talk about food and health coaching or the behavioral support. So we wanted to create a pharmacy concept. And then you got to fund all of this. So we have a whole braided funding model, I'll go into it. And then you need someone to bring this all together. So that's my team at the county. We are the training and administrative hub. We do all of the work to make this all happen. Now I'm just going to go really quickly into just how it looks, or how can it look. This is our safety net health centers. We're in Alameda County. We're about the size of Rhode Island, 800 square miles, 1.565 million residents, 57 different languages. We're across 21 different clinics, across 5 different health centers. You and your locale, and these are a bunch of our health centers. You and your clinics, the idea is linking local health centers with local farms. There's 1,400 of these health centers, 19,000 sites. We're just right here. Where are you? Find yourself on the map and connect your clinics to the farms. Our food pharmacy, we partner with Farm Fresh to You. We've, in our contracting, identified 45 local farms that provide our BIPOC farmers as pharmacists, this local regenerative and organic food, nutrient-dense produce. I mean, look at that food. It's like whole food without that paycheck cost, right? It's free through our prescriptions, through Medicaid. And discrete weekly delivery. We're delivering it to our patients' homes. We have a whole system in place for that. This is just one example. This is Tony Serrano. He's a Mexican-American gentleman who owns his farm, Jazz Family Farms, regenerative organic since 2014, fair trade, etc. Third ingredient, I'm short on time, is the behavioral pharmacy with the group health coaching. So we partner with, again, this is partnership. We're not creating our own. We are actually linking our partners into the health centers. We partner with an amazing group called Open Source Wellness. Community-based health coaches, they provide us certified health coaches in the clinics. We do group medical visits and see a lot more patients in groups and have more fun moving together, talking about the kale that we just got last week in recipes, sharing different approaches, being in small groups, connecting, getting coaching calls and texts the week after, and then a mindfulness section. The braided funding, we at the county, we put in county funding, philanthropy, USDA, all of that waiver and Medicaid stuff that Alyssa was talking about. We use that as a mechanism to help pay for this. And again, this is our county and our state and our partners, Alameda Alliance, the local managed care plan. Now this is happening. I'm trying to show how it can happen nationally. This is from our Center for Health, Law, and Policy and Innovation team, Katie Garfield and Erica Hansen and her team, and she's here. You should go meet her. 41 out of 50 states are engaged in some type of policy change in food for food as medicine, waivers, legislation, whatnot. And then the training administrative hub. This is probably the most boring part, but it's that ingredient that gives a spice to the whole set. This is my team. We are expanding mindset. So we're training all the clinicians on how do you use food as medicine in a 15-minute visit. We are training the medical assistants to screen for food insecurity universally. We are blending in SNAP into our workflows. And we're doing all that non-sexy work, right? All that electronic health record stuff, all that clinic workflow work and Medicaid back end. We're making it easy for everyone to do their part, and we're behind the scenes. We've had over 1,000 attendees with a net promoter score of 95% of these are busy clinicians, right? Taking their lunches out to do a training, and they say, yes, they would recommend this training, and often we do this virtually. I'm gonna close in with just the impacts. Human health, economic health, that whole nerdy HQD, that's how I want you to remember it. I'm actually gonna skip through Tammy. Just know that Tammy is an incredible patient that got lots of change. You can quickly read it there. She talked about all of the things that have been benefiting her. I want to just get to some of the program numbers. We've served over 10,000 enrollees, almost 130,000 produce boxes, regenerative and organic, 2.4 million servings of this food to our community. And then I'm just going to quickly you can see this in the slides later, but human health benefits on physical, mental health, and social health. Economic health, we're generating $1.90 for the state for every dollar invested. And our BIPOC farmers are getting an increased demand in their product, 60% increased demand. And then this is a slide really just about the ecological benefits. Less greenhouse gases, an improvement in soil health for an improved food quality perspective. And then just to close with the impact, right? So our boxes every week, 63% of it comes from BIPOC-owned farms. And we are ensuring that no one in our communities are left behind. So I just want to encourage and ask the question, how are you going to bring more of a regenerative approach to your food as medicine work and join this movement? Thank you so much.
Thank you, Stephen. Our next presenter is Millette Seiler. She is a culinary dietitian with more than a decade of experience promoting the food as medicine movement in clinical, academic, and community settings. In 2022, Millette co-founded the UT Southwestern Culinary Medicine Clinical Service Line, a first-of-its-kind initiative enabling patients to use insurance benefits for culinary medicine using shared medical appointments in local community kitchen spaces. Millette believes lasting change requires not just access to nourishing food, but the education and support to make it delicious.
Thank you. That sounds so impressive when you say it, Emily. Such gravitas. Okay, I'm setting a timer for myself because I'm committed to not be breaking the chain of responsible use of your time and resources. Yes, I'm Millette, and I want to tell you a lot of things today. Of course, we want to talk about shared medical appointments, but I definitely want to, I'm calling it a tale of two kitchens. So I do want to spend a bit of time talking about the shared medical appointment program that we developed out of UT Southwestern. But I also want to first tell you about where I began as a culinary dietitian working at a cancer center. Oh, I see my slides. There we go. Perfect. Beautiful. But before I do any of that, I'm so thrilled that we're going to be hearing direct from patients who are experiencing some of our programs here today. So I don't want to take away any of their thunder. But I do want to tell you a story about Lisa. Let's see, whoops. Let me advance my slide here. This is a story that happened pretty early on in my career. I've been doing this for a little over 10 years. And as part of my work at the cancer center that I was at, I had a very small outpatient clinical practice, very traditional clinical care as a registered dietitian. But then I also had this fun little teaching kitchen program that I was doing. I didn't even know to call it a teaching kitchen. It was Cooking Fun Time with Millette, I believe was what my institution called it at that time. And you know what? I embraced that. It should be fun. It should be fun. So I met Lisa, who has given me permission, her and her family, to tell this story. She came to my clinic and she was very outspoken, and I really appreciated that, especially as early on in my career. She said, "I'm going to tell you, you keep using that term survivor. I don't like that." I said, "Okay, tell me more." She said, "Well, not everybody here has beat cancer or is in cancer treatment. I'm going to be living with cancer as long as I can. And hopefully that's long." First they told me 6 months, then they told me 9 months, and now they don't know. So I made up my own goal. Lisa and I both at that time bonded over our 15-year-old sons. And she said, "My goal is I want to live long enough to get him graduated high school." That was her goal. That was meaningful to her. I said, "Okay, great. How can I help?" So as part of being a registered dietitian, I was sharing ideas about how we can eat better. So I was sharing materials like this. And we saw this from the American Institute of Cancer Research. By the way, I helpfully starred everything that falls directly within the purview of the RDN. You can see when we're talking about reducing our risk of developing cancer, but also outcomes, so much of it is linked to diet. These are things that are within our control. So shout out again. I'm so thrilled we have so many shout outs to RDN, but we have a lot of power to influence quality of life for patients. So she said, "Yeah, I want to do all that. I want to do all that, but I need your help because my house is the fun house. My house is where the kids all want to come and hang out, and we sit in the kitchen and I cook for them and I get to hear about their lives and I get to connect with my son, and I don't want to lose that. So how do I eat healthy and do all the healthy things so I can be here as long as I can, but without losing that?" So I said, "Tell me more. Tell me, what do you like to make?" She's like, "Tex-Mex. We're in Texas. I love Tex-Mex." So all of that. I said, "Okay, let's start with a quesadilla. What does he like?" "Chicken and cheese." I said, "Okay, let's work with that." So we stepped into the teaching kitchen, and over time we developed what I call Lisa's quesadillas. And she said what worked for her finally was, yes, chicken, maybe a little less cheese, black beans, handful of spinach thrown in, and a whole wheat tortilla. It was still a quesadilla. It didn't impact the story. And Lisa is no longer with us, but she made me promise. She said, "I know you're going to share my story, Millette, and that's great if it helps other people." She says, "But I want you to be really clear." She met her goal. She saw her son through graduation, and she got him almost all the way through grad school. So she said, I want you to tell people, cancer didn't win, I did. I did. So moving on, just as Lisa came into my clinic, and I hope I helped her delivering medical nutrition therapy. And by the way, incidentally, what I'm talking about today, it does not replace good clinical care. This is an adjunct to, this is an additional tool in the toolkit for dietitians and physicians and our communities, right? Patients want more. I'm quoting, you see Katie Garfield? I think, is she over there? She's a real one. This is a great, read this. Patients want more, especially if they're food insecure. They're not offended if you ask them. If we are screening in a way that preserves dignity, patients appreciate that. They want more, especially when they're very ill, including cancer. So this is a small study that we did out of UT Southwestern that looked at, for some of our patients, I really appreciate the clinical context today. For some patients, giving them food is perfectly appropriate, but looking at dose, oftentimes patients say that they need more. They need education. They need assistance with dietitians to help them understand how to behavior change. They need clinical context to make it work for them. And if we really want to drive outcomes, especially long-term, we need to incorporate more support. So what we came up with is using something we call culinary medicine as a way to bring this all together. Not only are we offering education and support in a way for our patients to connect in a teaching kitchen setting with their clinician, we're also educating that clinician on how do you have these conversations with dignity? How do you have a food-focused discussion that actually makes progress here? And also puts the autonomy back in the hands of the patient or the community member. I was really enjoying my conversation I had earlier with one of our guests today. She said, so much in cancer is beyond my control. I give up my body to my oncologist. Food is one thing I can control. So we're giving them the opportunity in a teaching kitchen to make decisions that make sense for themselves. Putting this all together, and then I will transition into my next phase. What does it look like in real practice? So I'm going to show you pictures of two different cooking spaces, but I do want to emphasize, do we see a fancy teaching kitchen, shiny facility up here? This is a conference room in our cancer center, multi-purpose conference room. So you can do a lot of good things with a stainless steel table. So over here on the left, this was for patients who are experiencing cancer-related fatigue. We paired this with our oncology exercise specialist, and these were just low-effort ways to incorporate protein into simple breakfast. So this was overnight oats, and patients got to put their hands on and decide, do I want to add Greek yogurt? Do I want to add nuts? Do I want to add a protein supplement? So they got to make that choice. In the center, I do like to point out that this is really important for our students in the future. This is a group of our dietetic students having the time of their lives, and the patients love interacting with them as well. And then this is another next level delivery where we break patients into groups of 2 or 3 working with facilitator to help walk them through making the recipe work for them. How am I doing on time? Okay. So what populations benefit? I really appreciate the context today, hopefully when you're trying to figure out what the dose is, because that's really important. So in my teaching kitchen setting, we were working with anyone with a cancer diagnosis is eligible to come to these classes that we saw previously. So this was foundation funded for anyone plus a caregiver to come to the class if they so desired. So these are the domains, things that we work with. We talked about acute symptom management, of course, post-treatment, looking at general holistic wellness. And it's my friend Lisa, patients who were never going to be cured from cancer. Another population that we've targeted, I don't like that word. We need to come up with a better one. Reached out to are our AYA patients who are struggling with, childhood cancer. What does that look like as you're going through adolescence and young adulthood with a cancer diagnosis? So those are patients that are always helped. And we can do things like address food and nutrition myths, simple culinary education, right? But I do want to point out this little graphic here from the American Cancer Society, something that I'm so glad we've been talking about, non-clinical drivers of health, social isolation. If nothing else, the height of the pandemic, we learned that social isolation is painful for all of us, but it kills. in cancer and chronic disease. So talking about bringing patients together for even a virtual cooking class really gives them an opportunity to feel less alone. So I'm transitioning now. So before, again, that was foundation-funded, free classes. It was external to the EMR, really targeting our underserved populations. How do we make this into a billable service line? So this is in conjunction with my physician partner, Dr. Jacqueline Albin. She's a rock star. If you don't know her, I kind of look like her. So just imagine me 6 inches taller, and you know her. So this was a 3-part system. These are all billable. And I'm going to talk a little bit about that and give you more information on how that all works. But we started with an e-consult. E-consults are not new. This is something that the VA has been doing since, I believe, the 80s. And it is an asynchronous physician-to-physician referral. It's a very small amount of reimbursement. I call it a brand builder. Then I'll talk about our one-on-one clinical visit. And then finally, our shared medical appointment in my 4.5 minutes that got left. Okay. So the good news is we published all this. So please, I do encourage you to go take a look at that. But there's just the timeline. We started in August of 2021 with the e-consult, which was a great way to introduce this to my healthcare system, which, frankly, I don't think they thought this was going to work. But we got the opportunity, mostly because the community said we want culinary medicine, because we knew what Millette was doing for free over at another part of the system. So kudos to community involvement. So thank you for all of the confidence from everyone today about why that works. The one-on-one consult came later, the shared medical appointment, and now we're kind of knee-deep working with some really smart people about how do we measure this effectively. So the clinical one-on-one visit, they get to see the physician who is doing the billing, by the way. This is primary care. And as a dietitian, they are not using my billing. There's some benefits to that, right? So since they're primary care, our patients aren't being presented with 2 copays. So she bills enough to cover my time as well. So she meets with them first. She's doing an evaluation of their history. Then we're doing a quick handoff. Then I step in and I do what dietitians do. I offer medical nutrition therapy. I offer information about how to create a SMART goal. And then I am recording that in the EMR, but it is very food-focused, very much. Most of our interaction is recipes. And then we have follow-ups as well. Whoops. And we do self-referrals or working with our clinicians. All right. So this is some of the nuts and bolts here. I will be really honest. Please don't ask me a lot of super detailed billing questions. As I mentioned, I am the chef dietitian aspect of this, but you can see all of this. If billing codes is of interest to you, you could take this. Again, we're using primary care individual rates. I know you can see hypertension and diabetes. Some people might say, I thought this was about cancer. Cancer rarely rides solo. So even our patients that are referred to us from our radiation oncology care team, we are billing on these codes most frequently. And I will say access to culinary RD, we're going to talk briefly. There's a couple of slides. I'll show you our paper that we published in the New England Journal of Medicine Catalyst. The #1 piece of feedback from the referring clinician that said they loved this was it was interprofessional. We love that, but they got access to a dietitian where they would not normally have access. So moving over to our shared medical appointments in the teaching kitchen, I love this picture. We have a grant supported by the NIH. Give it up for the NIH. So we had a small, yes, thank you. You could clap for them. They're awesome. We're so glad to be in the room with them today. A very small amount of money that we used. 95% of that went to purchasing equipment, durable kitchen equipment, fixing. You can see our brand new shiny refrigerator. We went to these community kitchens, which were faith-based organizations. Again, we don't have a kitchen. Our institution was not in the process of building us one. So we went to kitchens and we said, you're already feeding people here. How can we support you? And we turned this into sites of service via CMS. So there's different local rules. In our Gestic, you just had to pay a leasing fee that was on par and then have signage from your institution. Boom, you're a site of service. Oh, and I'm going to say that, but there was a lot of meetings to determine that was how simple as it was. Sounds simple, but it's hard. So again, physician RD team right in that kitchen. We're right there with the community. It's all billable. And we did a 6-part series, 75% engagement. Patients showed up. They loved it. I keep referring to this. Look it up. There's lots of details there. Thank you. Got 1 minute. The payers, they be paying. All right? They did what they do. This is just a few pictures of the kitchen. We used look at our cute clinical staff, so they checked in just like they would for a moment, and then they stepped. I do an offer that culinary education piece, and then you can see what we used over there for the kitchen space. That's me, and that's Dr. Albin, and we appreciate that. It's an interprofessional team. Come find us. We'd love to chat with you. I really advocate for if you're a dietitian wanting to work in this space, physician champions are everything, and Dr. Albin is all she is. So I appreciate my time, and I've got 2 seconds.
Millette, thank you for being such a trailblazer in this space. I'd be remiss as a dietitian myself to not mention that yesterday, March 11th, was National Registered Dietitian Nutritionist Day, and so it's not too late to thank a dietitian and tell them you appreciate what they do. Okay, our final presenter before we'll do some questions is Athena Ray Raisler. Athena is a director on the public health team at Milken Institute Health, where she leads a portfolio of work focused on prevention and chronic disease. Some of her current projects include accelerating access to pharmacy-based clinical services, scaling food as medicine interventions, and advocating for public health policy. Athena.
I'm also going to set a timer for myself. So good afternoon, everyone, and extending gratitude to ACS for bringing us all here together for this symposium. And I wanted to start by clarifying that although we're at the beautiful Milken Institute School of Public Health, I am from a completely different Milken Institute. We're a nonprofit, nonpartisan think tank focused on the intersection of health, finance, and philanthropy. And I also want to give a little history that not everyone knows, that our work in food as medicine really started at the intersection of cancer care. Our chairman, Michael Milken, had a diagnosis of prostate cancer, and he really credits his diet change as being integral to his treatment actually working and allowing him to found the institute that we are here for today. So with that, I want to talk a little bit about the power and the opportunity of integrating pharmacy in FemCare. I had this whole bit of nobody said pharmacy through the first half of our day, and then Dr. Chen kind of ruined that bit. But it actually emphasized it, that it was used as an example, not as an integration point, and kind of a rebrand of the work that he's doing. So thank you, that only reinforced it. So in 2024, we did some multi-methods research, really looking at this opportunity of pharmacists as a care access point in food as medicine. And this is our brief methodology. Many of the people in this room were some of those 33 stakeholder interviews, but it was a really multi-sector collaboration between health plans, between food as medicine leaders, between retailers and those pharmacists. And that all culminated into this action plan that you can scan that QR code and read the full 12 recommendations and 34 actions. I promise I won't be going into all of those in 15 minutes. So I want to start with, why are we even talking about pharmacists? And why didn't they get brought up yet? I think pharmacists, we know, are one of the most frequently visited healthcare providers in the US. They're located within 5 miles of 90% of Americans, and they are sometimes the only close point of care access point in rural communities and other underserved communities. They're more frequently visited than other providers. There's a study that's often cited of 11 million Medicare beneficiaries who had more than one chronic condition, and they went to their pharmacy twice as often as any other healthcare provider. So this opportunity is massive. They're often the first clinical touch point of people just coming in and saying, hey, I got this funky thing going on. What do you think? And then they're also often the final touch point before patients start a treatment or a medication, before they go home and actually take that. So really an opportunity across the spectrum. They're also highly trained in clinical care. Most current pharmacists have doctorates, and they're really experienced in supporting prevention, screening, management, treatment throughout that ecosystem. And they're really experts in that medication counseling, that adherence support, understanding side effects, and really connecting to the larger ecosystem and coordinating across care teams. So with that, I want to emphasize that most of what I'm talking about here today is FIM care, not the actual food in food as medicine interventions, which is often what we talk about, but really that holistic care that accompanies the provision of food. So what does it look like to embed within other disease management and prevention programs, both cancer care and then broader? So thinking about all those other chronic conditions. Mylette mentioned cancer doesn't ride alone, so that's really where a lot of this research focused on. So showing you here our food as medicine ecosystem map. So these are all the stakeholder functions involved in food as medicine. And really, I know the type is really small. You can see it in the paper later, but it's just supposed to show you the functions that different folks play, and that within this ecosystem, people aren't having one role. And we know that. Organizations are doing everything from being evaluators, providing food, and maybe facilitating these programs. I do want to do a shout out to my colleague, Annalyn Schweitzer, who's currently in the process of updating this map. So you'll see a refreshed one in June. Be on the lookout to see kind of how these relationships are evolving since we did this research. But those orange rings are all the places we think pharmacists can play. So they're healthcare providers. They can facilitate to community-based programs and resources. They can provide the food if it's in a pharmacy that's based in a grocery store, which is quite common. And then they can also be evaluators, really connecting that data back into the system. So sketching out a little bit more what this can look like in cancer care specifically. So 4 main buckets of where pharmacy provided support can be, starting with that screening and monitoring. We heard a lot today about the importance of frequent food insecurity screening and how that's not always happening at different points of the care ecosystem. So this is a place where people are coming really frequently and just has that opportunity that can either be driven from a reminder in the system of, hey, we actually need a screener for this patient, or just kind of informally asking, how are you doing? Also that nutrition risk identification. We heard someone highlight that it's not just food insecurity screening we need, it's also the malnutrition screening and using those validated tools and making sure that we're not catching people only when they're at the end of malnutrition. Also thinking about screening here as identification and monitoring of other diet-related comorbidities. So knowing that diet-related chronic diseases can complicate treatment, but then also post-treatment, folks are like 2 times more likely to have 2 or more chronic conditions after cancer treatment. So thinking to the next step, that treatment support, I mentioned that pharmacists are extremely qualified in that medication side effect and the medication counseling, and they can really pay attention to things that impact appetite and absorption and really be asking patients those questions along the way. Pharmacists do medication therapy management, what we like to say, the other MTM, when we're in food as medicine spaces. And so knowing that those MTM services are already built into the pharmacy pathways, that's a place where FIM can really be integrated. Similarly, that tech-enabled monitoring with continuous glucose monitors and other pieces they're already doing. So next, thinking about care coordination. We've heard a lot about the need for this ecosystem approach. So where can pharmacists really play within this? And also thinking about the role of community health workers and pharm techs, not just the pharmacist. And lastly, thinking about evaluation and follow-up, the need for ongoing patient engagement, monitoring symptoms, and also just tracking those adherence numbers and really bringing it back into the system. So with that, bringing it all together in the patient journey. So going through the identification, assessing needs, planning for an intervention, and connecting, and then follow-up and evaluation. So thinking through pharmacy can play in all these places and uniquely be in one specific care point. So not having to go throughout, but also connecting within the community. So now I want to talk about the systems that need to be in place in order to scale FIM care in pharmacies. So our research identified 3 major areas that need to be in place for this to actually happen. The first is effective payment pathways, which we're going to go into next. The next is the supportive technology infrastructure. And third is a seamless workflow integration. We've all touched on all these points, but we know that payment is the first one on everyone's mind. So we'll start there. So the first kind of elephant in the room is that pharmacists are not eligible providers under Medicare Part B, which really leads to a lot of barriers in making sure that they're actually paid for these services. So want to call that out next. I feel like I'm going for a count on how many times will Katie Garfield be mentioned, but I'm not going to spend too much time on the second point because I know that we're going to be talking a lot more about the opportunities here. But when we did this research, 1115 waivers looked a lot different. So just putting that out there. But I mentioned the opportunity in medication therapy management. That's a great payment pathway. And then also that integration of community health workers. So we heard about examples of pharm techs being cross-trained or cross-licensed as community health workers, and that being an opportunity both for better integration, but also payment. So we saw that in grants with public health departments, and also there's a lot of new work to expand payment for CHWs, including the physician fee schedule and even some changes in rural health transformation program coming up. Lastly, I want to pause because I also haven't heard anyone mention ESI. So employer-sponsored plans represent a really big opportunity in this space. And I think we think so much about the public plans, which is incredibly important, but we also know that most working age adults who are diagnosed with cancer are covered by ESI. So I really want to put a finer point here that there's so much opportunity. So also emphasizing that ESI, oncology is one of the highest cost drivers. And so employers are really interested in finding out other ways here to both reduce costs by improving treatment adherence and treatment outcomes, but also just help their employees so that they stay healthy, are productive, and can just really be a part of the community. So after payment, thinking about integration of workflow. So we've talked a lot about that identification process of FIM eligible patients, but I think pharmacies have this unique opportunity because they have that frequent touch point. So I mentioned that systems can kind of prompt pharmacists to ask questions and really be matched with providers. Also emphasizing that front of store capacity and really thinking about grocery stores as a one-stop shop for FIM interventions, connecting from that clinical care to then going to the front of store and reimbursing a smart benefit card to actually get some medically tailored groceries. We've talked a lot about the connection between dietitians and the overall care journey, but also that collaboration between pharmacists and dietitians. Many dietitians are co-located in stores in the pharmacy or have relationships, so that becomes a much more seamless experience. And then also a call out to social needs aggregator platforms that I think some folks talked about before, but we heard a lot about that being the potential for even more integration so that pharmacists feel empowered to actually send people to a service that they know and trust. Lastly, ending with the technology infrastructure and some key opportunities there. So we heard a lot about all of this can be happening. How do we make sure that this is a seamless process? And the first is really the focus on data interoperability. I feel like, will data interoperability ever be solved? We'd like to hope, and clearly you can see how many stakeholders are involved in this recommendation and moving this forward. But the part here that was really important for pharmacists was making sure that what they were seeing was actually getting back to care teams and knowing that those electronic medical records also included their thoughts, not just that they did a service or they completed something, but what they were observing. Next is making sure that this technology on the patient side isn't too complicated and it's streamlined, especially with that screening. We talked a lot about how people feel overtapped and wanting to make sure that that is part of something they're already doing in the pharmacy. So I know when I pick up a prescription, you have to hit things on the little terminal. So is there a way to include some of those pieces in that process? And then lastly, that piece of evaluation and data continuing to be a part of that research cycle and making sure that's all wrapped together. So I hope everyone's leaving here now saying, how can I bring pharmacy in my research plans or my programs? But excited for our conversation on the rest. Thank you.
I'll invite our 4 speakers up to these chairs here. How much time do we have for, just signal me when, 10 minutes, okay. Well, I have a few questions to get us started, and then if folks in the room have questions, you're welcome to line up at the microphone. So, Alyssa and Stephen, both of you touched on policies that can unlock healthcare funding for food as medicine. Can you talk a little bit about what implementers can do to help advance these kind of policies? And what are some of the lessons you've learned when it comes to communicating the value of your work to promote policy change? And Milad and Athena, if you want to chime in here too, feel free.
Can everyone hear me? Okay. I think that maybe a good way to think about this is implementers is a really broad category. I would consider all of you implementers in your own right. And so maybe a way to think about it is, I specifically talked about some federal policy changes and then some state policy changes. But then you heard Stephen talk about county government, right? And your local city. So maybe we sort of start from that levels of government perspective. I would say at the federal level, there is a lot of interest in this bipartisan topic of food as medicine. It is one of the main places that we're seeing agreement, right? And forward momentum. And I think that all of us are both private citizens and have the implementer status in food as medicine. So encouraging your member of Congress to pay attention to this, to sign on to letters, to support bills that are moving through Congress, most of which are bipartisan, honestly, to support the work that is being done across agencies and highlight it, right? And make sure it's funded. These are all really important advocacy pieces that we can participate in. I think it's really important to note that those conversations are driven by data. They're driven by the results, the outcomes, the stories. I think a good story is often worth a good spreadsheet, right? A story is how we all interact with this work because it's how we as humans learn. So I would just encourage you to take that active status. And then at the state level, so much of this movement, the engine is the state, right? The states are saying, we see this problem, we're responding to communities, we're going to leverage these flexibilities to provide. So you can also engage there. There is a whole menu, like choose your own adventure. No state is doing it the same way. And there is a right way to do it for the state. And that's why we've provided those supportive kind of frameworks, because we don't think everyone should do it the same. There are different communities, there are different priorities. And then get engaged locally. I mean, a lot of the service that's at least provided through my coalition is still primarily funded by philanthropy. So find your local agency, go volunteer, please support us, deliver a meal. These are the connections that are really truly making community, and that's what drives success in food as medicine.
Is this working? Yes. Okay. When I think about implementers and the effect on policy, I think about big policy and little policy. Big policy being kind of federal and state, little policy being kind of what we deal with at the health plan level or in your county government or whatnot. And I think I want to do an inversion, because I think sometimes it's kind of like with patients and clinicians. We want to listen to the patients as clinicians. And I think sometimes we want to do that with policy. How do the policy people hear from the ground, the implementers, and design the policies that actually will give the freedom and the space for the implementers to actually do the work on the ground. And I think what happens sometimes is the policy work gets constrained because of the realpolitik of what seems to be what is. And then some of the decisions are made that when they actually get effectuated on the ground, make it really difficult for folks on the ground to actually do the work. So I would just say, how do we have the implementers continue to be the kind of ground truthing for whatever policy is being designed? I would say from a policy front, two big ones certainly that impact us that we're always advocating for is moving this to a covered benefit. How do we make this a permanent benefit within healthcare? And Fong spoke to that earlier. And certainly from my talk, I'm always encouraging the question, how do we embed localness, organic, regenerative sourcing into the kind of food that we're going to be creating this new market for? So those would be my thoughts on implementers and policy.
Thank you very much. I know you've had some interesting things in Alameda County where you had a former Secretary of Health and Human Services come and do a roundtable, and not every county will get to have that, but I think that was an awesome opportunity for people doing the work on the ground to talk to people at the highest levels. But even if you're not having someone in that position visit you, I appreciate what you said about writing your members, calling your members. Every call they get, they have to log. And so if there are a lot of people calling in support of a particular issue, that is noted. And each call and each email, they are truly counted. So, Millette, can you talk a little bit more about how you got where you are today with the culinary service line? We were talking on the prep call about, you alluded to this in your presentation, that, it was kind of a cooking fun time. And, it was maybe seen as, just this nice little program teaching people how to cook. Tell us about how you got that buy-in to just the respect, if you will, that the program has today for the role that it does play.
Thank you. I mean, how many people are doing teaching kitchen work actively? I know there's a few. Yes. I know some of you. Great people. I kind of embrace the cooking fun time. I don't want to disparage that at all, because if it's not fun, it's not delicious, it's not nutrition until someone eats it, right? So I lean into that a little bit because I think people are hungry for that. People, burnout's a real thing. So that's helped, being accessible and open. But I also alluded to the fact that the community made it happen for us. Part of our work, I'm really, really honored. I'm not an incredible NIH level researcher. I get to work with some really great ones though. And so we've been partnering with our local charitable food system they said, hey, 10 years ago, before we really understood like food and nutrition security wasn't as included in these conversations. They said, we don't want to just give people food. We want to make it food that makes sense for them with their diabetes. We get a lot of folks who come to us from the Cancer Center. We want this to be nourishing food that heals, not just calories and bellies. So we've been partnering with them for a long time, and I do culinary medicine with our medical students and residents there, wear a lot of hats, and our medical students were out volunteering at the food bank, and they came back and said, hey, people aren't taking food that's offered. Do you think this is something culinary medicine could help with? And that was about 8-9 years ago. And so we went out there and we showed up and we said, tell us what you're needing. Where are your gaps? Where are your barriers? What do you think's doing great? Where can we celebrate you? And so, we've been around. So when our healthcare system built a new clinic in an area that's historically underserved in southern Dallas, lots of the similar problems that we have DC area, they wanted to do it better because frankly, we hadn't done a great job about serving that community. There's a lot of trust that needed to be rebuilt. First thing they said, you know what, we want culinary medicine. They said that. That's why we're there. That's where we got the big buy-in shift. But then, they gave us, I don't want to speak out of turn, but sometimes you get the opportunity to fail. They weren't quite sure it was going to work, but they're like, okay, let's make it a reimbursable model. So that's really where the tides began to change, was building the evidence that you can do this and it can be reimbursed by all payers. It works.
And I bet that really helped with the trust. People felt like it was a safe place to come.
We came there first, and it's in the churches. which are that's the faith-based community organization that has the trust of that community. That was very important to them that we built that up. So yes, thank you for highlighting that.
Athena, during the time since the Milken report was published in June 2024, do you have any examples to highlight of traction or progress that you've seen toward achievement of some of those recommendations and actions that were outlined in the report?
Yeah, it's crazy that like 2 years has passed, but we have seen a lot of what we recommended actually happening in practice, which feels really good. I know an example, there's a Medicaid director that's just super believes in the power of pharmacy and is currently doing a pilot, so it's smaller scale, but to prove out that ROI of working with a regional grocer that has pharmacy, so doing a lot of those cardiometabolic specific FIM care services, and then partnered with a smart card provider to bring those funds to get medically tailored groceries in the store all in the same visit. So that's within a Medicaid ecosystem. And also a call out that the Rural Health Transformation Program, with all the nuance in funding cuts, it is a way for us to see what states are prioritizing. And I think it's 14 states have a provision in their plan to expand payment for pharmacist-based services. So clearly pharmacy is becoming hot in states, and I think 17 of them are expanding scope. So scope versus payment different, but cool to see that movement since then.
And it's great to have pharmacists as another messenger. I think the stakeholder map you showed really illustrated the multi-sector interest in inputs for food as medicine, and that has been something in the policy space that we've seen really help move the needle when policymakers see that it's not just the dietitians or it's not just the vendors that want this, it is people and actors across society. So thank you for just contributing to that piece of the puzzle. We have one question at the microphone. Go ahead.
There we go. Now it's, nope. Okay. Thank you for highlighting that manuscript. I literally just hit my Google Scholar feed this week and I shared it internally at ACS, because we can be a convener of health systems and community partners in that nonprofit space. My question, however, is for Alyssa. When you shared your strategy for Medicare, are you folks at all thinking about a national coverage determination as a potential pathway? We've had some success in the rehab and exercise community moving in that direction, getting that MedCAC panel together and having that technical review. Even if you don't get the NCD, if you get the legislation passed, it moves to the regulatory front and you're already underway. Is that part of the plan?
Thank you so much for that question. That has definitely been something that sort of the broader food as medicine advocacy space has considered. It has not floated to the ultimate top, I would say, at this moment. But it's part of what I sort of consider the toolkit of advocacy. Like, which one are you going to pick? I think some of the work that we've been doing, though, where we're sort of formalizing the structures of the intervention would contribute to something like that, right? Agreement on definition, on the key pieces of the intervention, so that if or when we go through a national coverage determination, we're going through it with some real clarity about what the service is. Some of you said, I forget what you use. I use the boring stuff that I nerd out about, right? About coding, what is the work of the RDN, all of those really important pieces need to sort of be clear before we go that route. But totally appreciate that. I love the way that you're thinking. Yeah.
Please join me in thanking this awesome panel. Thank you all. And now we'll hear some patient and provider perspectives.
Thanks, Emily.
Okay. We're really excited about this panel. We've been hearing today about research, about implementation and policy, and now we really want to hear from the people who are benefiting from these programs and the people who are on the ground delivering them as well. So I will introduce our panel. First, we have Becca Kahn. Becca is a registered dietitian and director of nutrition services at Food and Friends, which is a medically tailored meal provider right here in Washington, D.C. We have Kadisha Ash and Phyllis Paul. They are cancer survivors and clients of Food and Friends and Movable Feast who receive medically tailored meal service during their cancer treatment. And Debbie Michelle is a retired registered nurse who specialized in HIV and infectious disease at Johns Hopkins Hospital and has become a volunteer meal delivery driver for Movable Feast during COVID in 2020. So thanks for being here. I think we're going to quickly transition and show a really short video that gives a little bit of a snapshot on how these organizations work in the community.
My name is Alex Brown. I am a delivery driver here at Food and Friends. We feel like we're the eyes and the ears of Food and Friends. And what I mean by that is we speak to our clients, we address them, we ask them how they're doing, how they're feeling today. We get feedback from them because a lot of our clients, we're the only people that they ever even talk to in a day's time. The overall mission is to serve the community. We have a lot of people that are in need of help with special diets and getting the right diets for their illness. And Food and Friends specializes in that. So I haven't seen Monique in a year. It's gonna be really interesting to see her.
So I was diagnosed with congestive heart failure in college. I was just really fatigued, just didn't feel like myself. And long story short, I had a heart transplant. And because of the immunosuppressants, I can't fight just regular bacteria or viruses that live in our body. One of those viruses I have for about a year, and it actually manifests as a type of lymphoma cancer. I also had problems with my appetite because I developed gastroparesis, and that's where I couldn't digest food. The impact that Food and Friends has had on my life is it really helped me in a time where I couldn't wrap my arms around feeding myself in terms of getting the nutrition that I need with the energy I had to fuel my body. My quality of life was changed by food. I was on disability, so money was pretty tight. It was a help financially. Once my food was stabilized, then, I came more and more of myself, and I'm back to serving my community.
Thank you so much. That's such a lovely portrayal of the work that your organizations do. So thank you for that. Okay, so let's jump into the conversation. I want to start with Kadisha. Kadisha, can you tell us a little bit about your diagnosis and some of the effects you are having with eating and nutrition that brought you to Food and Friends?
There you go. Thank you for that question. Thank you for having me here. I was diagnosed with triple negative breast cancer. It's my second journey. And at one point, if you know anything about cancer, it can bother your taste buds. What you used to like, you don't, and what you never liked, you love. And I wasn't able to eat much of anything. So I did a lot of medical stuff, but there was still nothing that could give me the strength to cook, even if I thought I wanted something. And then I lost a lot of weight, like 26 pounds. And the dietitian recommended with the doctor that I get Food and Friends. A light bulb went on. It's like, yeah, my kids volunteered there 30 years ago, and why didn't I think of that? But I got the recommendation, I got the food, I was prepared to just buckle up and eat this wet cardboard. And then it came and it tasted good. I was like, this is all right. So it helped my whole family because, they wanted me to eat a lot and eat more and eat. I'm like, y'all, I can't eat anything. So Becca helped me understand that just getting something in would be good. The meals came. I ate the meals. They were manageable, as you could see on the video, in size. So it didn't look so overwhelming, like I can't eat all this. And even if I ate a little bit, the look of it being gone made me feel successful. And as I was getting my taste back, I was like, a little more persnickety. And Becca said, I can send you spice packs. So I thought I was going to get, a few granules of this and that. And she actually sent me full-size bottles of spices I wouldn't usually buy. And I used them, tried them. We talked on what they call the social hour calls among survivors. And I'm here now, as good as I am. I'm still on chemo, but I can probably eat more than any of y'all. And it really did help because, my husband, caregiver, good. I wouldn't trade him for anybody, but the hot dogs and beans, they, got kind of boring. So, sorry.
Thank you for that. Becca, I want to turn to you as the dietitian on the team who works with a lot of clients with cancer. What are some of the most common nutrition challenges that you're seeing with people you work with, especially people in cancer treatment?
Sure. Thanks, Khadijah, for that, all those kind words. The common challenges that I see as a dietitian, probably the taste changes that Khadijah was talking about, the loss of appetite, and those, are to be expected. And then there are a lot of conversations that people have where they're like, oh, I lost weight, but, I needed to lose weight, so it's okay. So me and my team, we have a lot of conversations with folks about, well, all weight loss isn't equal, and here's what it could mean for your treatment. We want your treatment to go well. And maybe that's a goal for the future, maybe that's a goal for next year or something, but we don't want to focus on muscle loss also. So we talk to people about, how all weight loss isn't equal. And then as Khadijah was saying with the poor appetite, our meals are kind of manageable in size. And if you can only eat a little bit, maybe you can have a bite of 3 components, and you're getting a balanced snack right there. Yeah.
Great, thank you. Debbie, I would want to ask you as a volunteer. So the video shows how the volunteer drivers are really often the front lines, the ones interacting with the clients on a weekly basis. From your perspective, what do you see the clients, especially clients who may have cancer, struggling with?
Well, as a volunteer, I don't necessarily know their diagnosis unless they've shared it with me. Sometimes I can tell by how long they've been on service. And the funding, HIV clients tend to be on longer. They have Ryan-wide funding. But the ones that have shared that with me, a lot of times it's just getting to the store. So it's getting, I live in Baltimore City. It's not a food desert, but it's a good food desert. So people don't have cars. They can't get to an actual giant, that has a pharmacy or decent food. They can get to the bodega on the corner that sells chips and things behind glass that you are pointing to. So that's a lot. A lot of it is what he was saying, to see somebody every week so they don't feel like they have to go to the ER, they have to call their doctor. Sometimes it's just enough to see somebody and say, this doesn't feel right, or I'm worried about this. And it's just that connection with somebody that's caring about them. They know you, they've seen you every week, and they love it. And I've heard that the small meal sizes is really helpful, that they don't feel so overwhelmed with these big piles of things on a plate. But one guy did say, I've heard of portion control. Is that what this is? I'm like, yeah, because eating a bag of popcorn is not portion control. Yeah.
That's great. Thank you. Phyllis, I want to turn to you now. Can you tell us a little bit about your experience and your diagnosis, and particularly how you got connected with Movable Feast for your meals?
You want to just switch? Sure. Thank you.
Hi. First of all, I want to really tell you all how much I appreciate all of you being here and doing what you do. I'm older than a lot of you. I look younger than I am. And getting services for myself, I feel like I've been a dog with a bone in order to find, not through the medical system, in terms of my doctors, my oncologist, but through the American Cancer Society. I have CLL, chronic lymphocytic leukemia, which is probably most of you know, is at this point an incurable leukemia. I hope one day there is a cure. I hope we're at that point soon. My dad, I will share, had chronic lymphocytic leukemia along with renal cell carcinoma in the last 4 years of his life before he died at 90. 18 years ago. He was in a clinical trial for CLL. Probably was, I don't know the history, but it was probably an early clinical trial. I like to think that possibly the treatment that I'm taking, which is a lifelong treatment, is in some way connected to what he chose to do. I had called American Cancer Society because I had switched oncologists after things seemed to be progressing to the point where I needed to start treatment. So I changed oncologists who quite a bit farther away for me. So transportation was an issue. I live alone. I live alone in Baltimore. My cat doesn't drive. She doesn't fix meals either. And so I called ACS and I said, anything, what can you all do? What do you know about in Baltimore? So I got hooked up with their transportation system. And kind of at the end of the conversation, the person I was talking to said, is there anything else you need help with? And typical for me, I was like, oh, no, I'm fine. It's like, it's okay. And then I went, wait a minute. There is one thing. I said, I'm having a really difficult time with meal preparation. The exhaustion, just planning meals, going to the grocery store, everything, all of it. So a few suggestions were made in my area, one of which I knew would not work. I won't name it, but I know of their food situation, and I don't know how people who without cancer can live a healthy life, let alone somebody who's dealing with a chronic disease. So they mentioned Movable Feast. And I said, oh, because I had heard of Movable Feast from many years ago. I said, I thought they just worked with HIV and AIDS patients. And they looked it up on the computer and they said, no, they work with other things. And I'm like, oh, that's great. So thanks to the ACS, I got hooked up with Movable Feast. Started second week in January of this year. It's been such a godsend. It sounds so, maybe not to you all, but to most people, it sounds like a very simple thing to, chop vegetables and make a grain or, whatever, make a protein. And I just couldn't do it. And I love to cook. I had been cooking for myself a lot and just couldn't do it anymore. And it has, to not have to think about anything dealing with food has just been amazing. I'm looking forward to my next primary doctor appointment to see when, she does my A1C and all the other stuff, to see the changes.
That's awesome. I'm so glad that ACS was able to help. I actually didn't know until we had our prep call that that's how you got connected to movable fees. So I was super happy to hear that. So go ACS. So Becca, related to that, I did want to ask you about kind of referral pathways and how you get patients referred to you at Food and Friends and what those pathways are and what really kind of works to get people into your service at the time that they need it.
For many, many years, we've gotten referrals directly through the healthcare system, and we continue to do that. I think most are still through the healthcare system. So directly from a doctor's office, that could be the dietitian, it could be a social worker, it could be anybody who has access to that client or patient's chart to document the diagnosis, the medication they're on. And that still works. And then in more recent years, we've worked directly with some of the managed care organizations in the area, and those providers can refer directly to us as well. And it takes a lot of work, actually, to build those relationships and to build that trust, to teach the folks who are going to be making the referral that we are a good resource for their patients, and here's how you make the referral, here's what will happen. So that's an ongoing process to teach new providers coming in how to work with us and how to make referrals.
Thank you. This next question is for Khadijah. So you worked with Becca as your dietitian. We'd like to hear just a little bit about how, is one of them not working? Sorry. Just talk to us a little bit about how you worked with Becca, what support she was able to provide, and how that support kind of made a difference in your ability to eat a nourishing diet.
No shade to the others in others' professions, but Becca's the one who will call me and see how I'm doing. That was a big help. I've noticed that everybody understands that cancer doesn't travel alone. So I have other stuff going on. I was able to get Glucerna from her because we talked, and she knew I was missing meals and not eating very well. And I get Glucerna because I have diabetes. And she knew that I had a son who was my cancer colleague. And she helped me talk through him and my care of him, even though he wasn't on her list. His doctor was in another state, was in Virginia, and said, well, maybe we can get him something from there. I'm like, that's too far. He needs Food and Friends. And they said, okay, we'll get somebody to get him Food and Friends. But in order to get him Food and Friends, we got to get him some DC referral source. And all of that was outside of my direct treatment. So she was a caregiver, creme de la creme. First interested in my nutrition to help me get better, but understanding that it takes, man does not live by bread alone, making sure I got my stuff. But then she'd say, how is your son doing? And I would fill her in, and then we'd end the call, but she'd call and see how I'm doing regularly, how the meals were. I would get regular information about what they call the happy hour, where people would get together. And I too thought it was mostly AIDS when I knew of Food and Friends decades ago. And we learned from each other. So I really encourage anybody out here that's dealing directly with what you all call patients, that you listen to the people over the paper. I mean, the paper is really powerful and it helps you get funding and all that, but you got to listen to the people, and not all people that you will experience have malnourishment or have a negative thing, you can learn from the patients that don't. For instance, I didn't have a transportation issue, but you can learn from me how I come about that, or if I'm retired or still healthy, how I might be able to help somebody else and really be a connector. And Becca was really a connector for me. And I was for her as well, because I used to do community work. So to really address what you said, my connection was personal. And I know you can't sit around and just shoot the breeze with every client, but for those who you can get something from, get it, acknowledge it, and give something back and create that relationship that's going to help you with the next person that may not be as engaging. So, yeah, it's personal between the two of us. Like, I don't want her watching what's on my plate. But yeah, there's got to be some personal engagement, and hopefully for you as professionals, that will also keep you motivated and keep you confident. You got to know, whether you see it or not, that you're saving lives. You got to know that. You can't be guessing if it's any good, or Mary Sue didn't make the call, or this one didn't make the appointment. You got to know. Just keep going, because it's doing good. If you save one life, if it's mine, it's 100%. Does that make sense?
You.
Just, yeah, not to be selfish, but everyone is 100%. I know your papers don't say that, but believe me, everyone is 100%.
Absolutely. Debbie, I want to ask you, because you are seeing clients on a regular basis, what's your impression of the impact that this program or these meals are making for the people that you deliver to?
As I was saying, the socialization part is enormous, besides the food, which when you deliver consistently to the same people, I've been doing it for 6 years. So some people I've had for 6 years, and some people I've had since January. They have a goal. They know you're coming. They know they need to clear out their freezer. They know Debbie's going to see that I haven't been eating my meals, so there's a little feedback from me, even though I don't say that stuff to them, but they know that there's somebody that cares about them that's going to be seeing how they're doing. I think they can feel like they can ask advice. They can ask about the food. They can comment about the food to me, where maybe they wouldn't to somebody else at Movable Feast, but they'll say why am I getting so much chicken? The last 2 weeks has been all chicken, chicken and rice and chicken and applesauce. But the nutrition at Movable Feast will listen. And then all of a sudden there were crates of salmon coming in from Alaska. It was great. And that got really good feedback. So they feel like they're buying into their own care to do that. And also, I get so many referrals so I deliver to some apartment buildings, and I must get asked at least 10 times a day, how do I get that? Are you from Meals on Wheels? Because everybody knows Meals on Wheels, and they often deliver to the same building as I am. And how do I get on that? And what's that phone number? They always want to know how to sign up. And unfortunately, most people of color that live in Baltimore City that I deliver to, live in an area, they probably do have a diagnosis that would qualify for Movable Feast. So I just tell them, I said, your social worker, your case manager will know about Movable Feast. Just tell them that you want that you can't get to food, it's tough to prepare. Fortunately, the places I deliver to are secure housing, and Baltimore's making great strides in improving that lately in the last few years, but not everybody knows how to cook. I don't know how to cook. I would need Movable Feast. So I think the consistency of a person that cares about them and seeing what actual proper nutrition is, that you don't have to fry that. And this is a fresh vegetable as opposed to a fried vegetable. And Movable Feast makes up their own spices, like you were saying Becca gave you, but they make up their own little fancy spice things. So when I get a new client, I always say, all the meals are low salt. No matter what meal you're getting, if it's carb controlled or heart healthy, it's always low salt. So use this spice jar. And they're like, what? No salt? But everybody tries it and they like it. So they, I think that you're educating people and creating better long-term intake.
Great. Speaking of educating people, Becca, I'm sure you probably get clients who come in with a lot of information, misinformation, myths about nutrition, and especially cancer. What do you hear from clients, and how do you kind of guide them on the right track?
Thanks. Always happy to bust some myths. I talked a little bit already about the weight loss and how people are like, oh, I needed to lose weight already. But people still bring up, or they ask questions about whether they can eat soy during cancer treatment or after they finish treatment. And we often point people to ACS's really digestible webpage about debunking those myths. And we also get a lot of people confused about sugar in general. I can't eat sugar, but I'm supposed to eat fruit. What do I do? And, we say you can eat sugar and everything's, in moderation. It's not just feeding your tumor. So those are a lot of the myths that we hear. And actually, we just realized we were hearing the same things over and over again, that we just put out a webinar busting some nutrition myths, and we're going to make it a series.
Okay, I think we're getting to the time to take some questions. But before I do that, Debbie, I just want to ask you, what would you say to anyone considering volunteering for an organization like this? Like, what keeps you coming back?
So I had just retired from inpatient nursing right before COVID. And so Hopkins was just a mess when COVID hit, and I couldn't go back in there to volunteer. So one of my friends on the fundraising bike team for Movable Feast was the interim director starting in January, and then COVID hit in February. So she was there, and I just talked her into going, and it was such a lovely streamline from being in service your whole life and then not for a year and then doing this. So I have as I said, my same peeps that I used to have and take care of. Some of them were actually my patients.
Wow.
In the hospital. They'd say, I get yelled, "You were my patient, Miss Debbie. You were my nurse, Miss Debbie." So it was wonderful. You get just those connections, the socialization yourself. You're making a difference. I can be there as a friend and just an ear without having to be a nurse unless I want to be. But that's not my job there, so I don't. But I maybe have a little more information than some others do. But actually, several nurses are volunteers. I think of the 7 or 8 volunteers that we have that drive, 3 of them are nurses.
Oh, wow.
And it's just a great way to serve and be useful and know your community.
Awesome. Thanks. Mm-hmm. And
Excuse me, can I
good.
throw something in here?
Yeah, I was.
Thank you. Is it on? Is it on? Yes.
Yeah.
I just wanted to throw in about the driving piece and volunteering. My driver, shortly after I started in January, like 3 weeks later, I got a window of when he would deliver. It was like almost 5 o'clock and he hadn't come. So I ended up calling Movable Feast because I wasn't concerned so much about me getting the food, but I was concerned something had happened to him. Mm-hmm. So I ended up calling Movable Feast, and I ended up leaving a message for transportation. And I said, I'm just checking. I just want to make sure Steve's okay. So it's like we really appreciate.
Yeah. The volunteers are on a more regular basis because I only have 10 people to deliver to.
Right.
Steve has got 35 or 40.
Yeah.
Yeah. But I see him all the time. Yeah.
Right.
He's a honey.
Yep.
Yeah, that's a nice relationship that you're able to forge. So I just want to wrap up this portion by, I'm going to ask the same question to both Phyllis and Khadijah. Just what advice would you give to anyone who is newly diagnosed, maybe struggling with food or nutrition, and kind of asking for help and finding resources to get through treatment?
Thank you. Yep. Okay.
Yep.
As I said before, I was like a dog with a bone. I wasn't getting much help from my primary, from the social workers at my oncologist's office. My oncologist didn't even know about movable feast. And I think one of you said something, somebody said something a little while ago about social workers and, knowing about movable feast and your program. Not necessarily.
Oh, really?
The primaries don't necessarily know about those things. So I think everybody, I've learned in this journey, in my medical journey here, one has, in the way our health systems are, one has to advocate for oneself totally, 100%, and one has to follow up over and over and over again. And if you get a no or an I don't know from one person and they don't know where to go, hit Google. I mean, just put in a question, or now it's my family, we joke about Dr. Chat GPT. Find out in my area, where can I get blah, 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 whatever it is you need. And just keep at it. It's hard when you're sick. It's hard to get the energy. It's hard to follow through. It's hard. It's just plain hard. But eventually, I'm of the belief that it's like the Rolling Stones. You don't always get what you want, but if you try sometimes, you might find you get what you need. If you keep at it, you do get what you need. And for me, my faith is that I'm always taken care of. I get what I need. May not be what I want.
I fully agree with the self-advocacy piece. Like I said, this is my second journey, and I didn't give the details, but my weight loss, it's numeric, it's on the machine, anybody could see it. But my nurse is the one that brought attention to it. Then she told my surgeon, and my surgeon told the dietitian. By the time I went to the dietitian, I was weak. I wasn't feeling great, but by the time she came in the office, I'm sitting there. And like you might look at me now, I take showers and stuff. I didn't look bad. I'm not homeless to the point where I had no access to a way to look good. You don't go out that much except doctor's appointments. So for me to go to the dietitian was an outing. It was a treat. I told my husband once I was going to wear a ball gown to the Costco because it was an outing. I had been in the house and only going to doctor's appointments. But when I got to the dietitian, again, no shade, she said, I don't think you qualify for Food and Friends. I guess because I looked like average weight. I'm like, honey, this is skinny for me. This is not healthy weight. And she thought it was healthy weight. Well, it just wasn't me. I had lost 26 pounds. She looked at the record and she said, oh, I guess you do with your diagnosis and your weight loss. I guess you do qualify. But if I hadn't pushed, she would have just thought I was just average weight and I was fine. And I'm like, no, this ain't fine. I can hardly walk. I was holding on to the wall getting into her office, but she didn't see that. So observation is the first part of, investigation, but you got to push. You got to don't go by what you see, or don't assume I'm healthy because I look healthy, or unhealthy because I look unhealthy. Let's look at what's going on. Look at the whole story, and you'll come to a good end. So self-advocacy would be the first thing I'd tell anybody, because I wouldn't have gotten this spice pack if I hadn't told Becca, this is good, but now that my taste buds are coming back, it ain't that good. So we worked on it, And I told her what I was doing with the food, because I try to be honest as I can without getting in trouble. So I'm telling her I'm putting this in it and that. She said, oh, I could send you a spice pack. But advocacy, pushing for yourself, if you can't get it, at least you tried, you know where it's off. And if you could just tell your folks, speak up and say how you feel. Fine is not a feeling. Okay is not a feeling. Work with your, I always tell people, advocate for yourself and work with your people. If that one is not good to you, good for you, get another one. Ask to speak to another one and be nice. People don't like to be nice to you when you're not nice to them. So I always tell you, don't make those people mad. But work with them and advocate for yourself. That's the number one thing. Thank you for that reminder.
Also, in terms of that, patients don't realize that we are consumers. We are customers. We can fire somebody. I fired my first oncologist.
I tell people,
which was 3.5 miles from where I live. I now see an oncologist who is 20 miles from where.
Oh, I have doctors
and I don't
everywhere.
drive anymore.
Yeah, good.
So it's worth it to me to pay Uber or Lyft or whatever to get there, or the ACS volunteer driver.
Yeah. I tell people that doctors and professionals are experts at what they're experts in. So oncologists are experts at patients in cancer and care, but I'm an expert on me.
Exactly.
They always agree. I'm an expert on me. Because if you give me something that I'm not going to take, why waste the little pad?
All right. Well, thank you to this panel. I think we'll wrap it up. Yeah. Okay. Thank you so much for sharing your experiences. I think we will take a 5-minute break. Quick break. There's some snacks outside, and we'll come back for our final panel. Thank you.
Okay, so welcome back, everyone. We have the last panel of the day, which is a lot of stress on us, but I know the panelists are going to do a great job. So we've started the day talking about building the evidence for food as medicine. We talked about some current initiatives that have been going on. We had a great panel talking about patients and providers and sharing their perspectives. And so now we're going to talk about what's next, what's coming up in research and implementation. So I am Anna Schwamlein-Howard. I am the interim managing director of ACS CAN's policy team, and I am pleased to introduce our panel. So I will start with Christopher Long. Chris is the director of research at Heartland Whole Health Institute in Arkansas. Much of his career has focused on collaborating with community-based organizations to improve access to healthcare and healthy food among people experiencing food insecurity and chronic disease. Next, we have Tanya Aggers-Collins. She is the very long title, program director in the Health Behaviors Research Branch of the Behavioral Research Program, Division of Cancer Control and Population Sciences at the National Cancer Institute. That's okay. That's okay. You earned it, She manages a portfolio of research grants focused on diet, food as medicine, physical activity, and weight loss behavioral interventions for cancer prevention and control. Her research examines diet and obesity-related health disparities and cancer outcomes, and she is a registered dietitian with the Academy of Nutrition and Dietetics. Next, we have Funke Ajenikoko, which is, I have to say, exactly as it is spelled. She is the manager of food as medicine at the Rockefeller Foundation, where she supports efforts to integrate food as medicine programs into the healthcare delivery system. With decades of experience, she has worked across the U.S. in global context to help shape food policies. We have Sarah Downer. She is a health insurance specialist, state and population health group with the Center for Medicare and Medicaid Services. She joined CMMI as a health insurance specialist in the State and Population Health Group, where she focuses on developing and implementing components of the Innovation Center's strategy related to prevention, and especially nutrition. So prior to her work at CMMI, she served as the Associate Director of the Harvard Law School Center for Health Law and Policy, leading their Whole Person Care initiative. And finally, we have Katie Garfield, who is the Director of Whole Person Care at the Center for the Health Law and Policy Innovation at Harvard Law School. In her role, she works for community-based organizations, state agencies, healthcare providers, and coalitions to develop strategies to increase access to innovative services such as food is medicine. And I think we've heard a lot about her today before she's even joined this panel. So we'll start with research funding. We've heard a lot about some exciting research that's been happening in the food as medicine and nutrition interventions in cancer care, but we know that there's more to be done to kind of build the strong evidence, particularly in cancer care. So Tanya, can you talk about kind of the food as medicine research landscape? What does it look like from the NCI perspective and from other federal agencies as well?
Hello? Yes. Okay, so I thought what I would do is just give an overview of cancer in the United States for 2026. We know that the incident rates are rising. A lot of it's related to early onset cancers, a rise in that particular type of cancer where individuals are younger than 50 years of age, as well as the rates are also rising among women. In addition to that, we know that cancer is the second leading cause of death in the United States. And good news is that it's predicted that there will be at least 20 million cancer survivors by the end of the year for 2026, which is outstanding. But also that brings some challenges as it relates to long-term care management, as well as changes that occur in the system, financial strains on the system, financial toxicity with cancer survivors, as well as, adverse cancer treatment. So we feel that at NCI that food as medicine is very important as far as reducing cancer risk in persons who are at risk for cancer, but also among cancer survivors as well, reducing the adverse side effects related to cancer survivorship and as it relates to treatment toxicities. So NCI is very much interested in funding research in this space. We have not funded a lot of projects. As you heard from Nick earlier, he mentioned that NCI funded 2 grants in 2025. When I went back and looked at at the portfolio like 10 years back, there were some other grants that we funded. They were pantry related among cancer survivors or those individuals that were at risk for cancer. And we're proud to say that we funded Dr. Gainey's research, and you heard about her project earlier this morning. So NCI is interested in doing more in this space. We feel that food as medicine is more patient-centered, focused on tailoring to the individual needs, and we feel that the research needs to be generated as it relates to reducing cancer-related negative outcomes, as well as looking at some of the other outcomes such as improving diet quality, as well as food and nutrition security. So the landscape, to address your question, the landscape is great at NIH, particularly NCI, because we're interested in research in this area. And we're working with the Office of Nutrition Research to elevate food as medicine across NIH, along with some of the other ICs.
That's great. Thank you for that. Funke, the Rockefeller Foundation is committed to supporting food as medicine in a variety of different ways. Can you talk about some of the priorities of your organization, particularly as it determines, what projects it's supporting?
Happy to. So since 2019, the foundation has been investing in the food as medicine space, both through direct implementation and the research needed to realize the full potential for these programs. In 2023, we announced an additional commitment of $100 million to food as medicine over the next 5 years. Our goal, depending on who you're talking to, is simple. Is to make food as medicine a reimbursable medical benefit that is covered through public and private insurers. To that end, we've developed a 4-pronged strategy on how we fund food as medicine internally. So the first pillar of our work centers around research. We have committed a little over half of our investment, our $100 million investment into the research space. We are funding Healthcare by Food, which is an initiative of the American Heart Association to build the clinical and economic case for food as medicine. Healthcare by Food is generating rigorous evidence through clinical trials that answers questions like, can food as medicine deliver measurable results? What is the impact it has on health outcomes and the economic savings? To date, Healthcare by Food has given out millions of dollars to fund clinical trials that are serving the basis for larger subsequent trials, as well as planning grants to researchers aiming to get larger funding around research. We are also piloting 5 studies with the VA in partnership with the Veteran Health Administration. So these 5 pilots are in Houston, Texas, Salt Lake City, Utah, Syracuse, New York, Durham, North Carolina, and the state of Maryland. Currently, most of these trials focus on produce prescriptions, but we hope as we continue to grow our relationship with the VA that we are able to expand this into medically tailored meals. Second, we're engaging in the policy space. So policy change is critical to making food as medicine a covered benefit. As a nonpartisan organization, the foundation works with a diverse set of partners to educate policymakers across all levels on the power of potential of food as medicine. Third, we are working to create a national narrative shift. So we want to create a narrative that persuades Americans that food is health and that nutrition should be core to healthcare. So in 2024, the foundation hired Hadaway Communications to conduct message testing on food as medicine, including conducting a nationally representative survey of 2,000 participants across all 50 states to understand their thinking around food as medicine. The findings were clear. Americans want to eat better and live longer lives. They're eager for programs that support their health through food, but public awareness for food as medicine remains low. Importantly, once people learned about food as medicine, nearly 4 in 5 Americans thought these programs should be covered through the healthcare system, which is an incredibly strong signal of public support. Finally, we are working to strengthen a diverse ecosystem of food as medicine operators across the local, regional, and national level, and helping them overcome some of the infrastructure challenges that we know exist when trying to scale these types of programs. In 2024, we awarded $3.5 million in funding to different grantees that partner food as medicine programs with small to mid-sized farmers, and actually see some of our grantees in the room right now. Through this work, we are building a fuller picture of food as medicine, looking at not just the value of improving health outcomes and lowering healthcare costs, but also thinking about the impact on economics and environmental benefits for communities. And yesterday, we released a report that highlights the economic benefits of local sourcing and implementation in food as medicine programs. So targeted guidelines that localize food as medicine can achieve measurable economic gains. And I have some stats. It can increase over $45 billion in annual GDP growth nationwide, support 316,000 new jobs through the food as medicine supply chain, and $5.6 billion in annual revenue for small and mid-sized farmers. So food as medicine is a people-centered approach with growing momentum and real promise. And as the foundation, our hope is to continue to put our dollars into this movement to help the broader community move food as medicine forward.
That's great. Very, very impressive. And an excellent segue to talk about kind of moving forward to how do we implement, going beyond the research. So Sarah, can you talk a little bit about what CMS is doing to expand access to food as medicine initiatives? Specifically, like what's the role of the MAHA Elevate model and funding opportunities that may be available?
Yeah, so thank you so much for having me here. As many of you, I'm sure, know, the CMS administrator, Dr. Oz, really believes that nutrition is core to health, foundational to health, and has been very open about that. So it's really exciting for me to be here. But today I'm going to be speaking to you mostly from the perspective of someone who works at our CMS Innovation Center. And so I know many of you in this room are very familiar with the Innovation Center, but for anybody who's not, that is the component of CMS, broader CMS. So we have Medicare and Medicaid and our Center for Information and Oversight, our Center for Clinical Standards and Quality, and then we have our Innovation Center. And so we are empowered to test service delivery and payment models that are innovative within Medicare and Medicaid to see if we can do one of two things. So can we improve quality while maintaining federal expenditures, or can we, maintain quality while reducing federal expenditures? So we were created by the Affordable Care Act, and that's our statutory mission. So anything that we do at the Innovation Center has to be able to meet those criteria. And so I'll get to MAHA Elevate in just a moment, but just wanted to talk a little bit about when we are assessing the kinds of things that we would go ahead and test at the Innovation Center. We really need, because of our statutory mandate, to be able to paint a picture at the outset of any test that we do of what's going to happen to achieve those two objectives. So we have to know a lot about how it's going to improve quality for the folks that we're going to be testing these innovation or payment models with, and what it's going to do to the cost under either Medicaid or Medicare, depending on which program we're talking about. So when we're thinking about prevention, so at CMMI, we have a new strategic direction starting in 2025. We have 3 pillars that will be guiding all of our work. And one of those pillars is promoting evidence-based prevention. And that's really important to our center leadership. And it can also be a little tricky for CMMI when we think about the things that we need to do for our models. We need to be able to look ahead, and we need to be able to show to all of our constituents, especially our Office of the Actuary, that when we do these things, when we do these tests, we're going to be looking at, we're going to be able to show our results. And we also are very interested in things that we can, if they're successful, scale up, right? And that we would be able to be confident that we'd see the same results if we scaled this program for these individuals. And so when we're looking at the evidence base, and that's why what Funke said is so exciting, is we're really looking for, can we test in particular groups of folks a standardized intervention that will see sort of reliable results? Have these results been repeated? Do they have reliable control groups? So for example, if we tested over here, are there others that we can look at and say, okay, they did not get this intervention, so what happened as a result of that? So those kinds of things are really compelling for us. And so in the prevention space, that can be really tricky because some things you'll test them and then they prevent things way far down the road, right? So I think the longest model we've ever done is 10-year time frame. And we have had many models that have only a 5-year time frame. So we're really looking at results within a relatively short time window. So for us, as we're looking at this in the prevention space, especially for some things that are newer and exciting and where the evidence base has just really been building, we are thinking about how we can then make these big investments. All of our models are sort of upwards multi-million-dollar investments, and we really want to protect, the integrity of our programmatic funds. So we really need to know that we're going to sort of get good results, or really have a solid expectation that we will. And so for newer things, this can be challenging. So with that in mind, our center director recently announced the MAHA Elevate model. And so I'm going to just refer to my thing about what that stands for. Sorry, one second. Okay, so it stands for Make America Healthy Again, Enhancing Lifestyle and Evaluating Value-Based Approaches Through Evidence. And so this is going to be an up to $100 million investment by the Innovation Center in trying to put a spotlight on really promising things that may be very, very good for folks who, especially who are the program is focused on Medicare. So for our Medicare beneficiaries, we're looking for innovative things that aren't already covered in Medicare that, have some experience. There's some literature that's supporting them, that's evidence-based, right, practices that we're looking at, but things that aren't covered in Medicare yet. And we're really looking to build out that evidence base, put a spotlight on things that are effective and working, and bring that data into the center through these sort of funding awards that we'll make, which will be up to 30 funding awards within that $100 million investment, so that we can have that data and then we can decide to do a lot of things. It can inform coverage determinations in Medicare. It can be used to broaden out and do a larger scale model test, right? So these are all possibilities that are at the end of this journey. And this is a relatively short time frame of investment, so we really expect to build that evidence base pretty rapidly in this model and then be able to sort of move to step 2.
That's very impressive. Thank you. So, Katie, can we just hear from you in terms of there's been a lot happening at the state level, both in terms of state Medicaid 1115 waivers. Can you talk about kind of some of what's been going on at the states and talk about some of the projects, any highlights that you've seen from state activity?
Sure, happy to cover that. So first, to just start off, I think we heard this earlier from Alyssa and others. As a baseline, it's important to remember that while there is so much promise in food as medicine right now, it is not yet sort of a baseline covered benefit in any of our really major federal public health insurance programs. So not a standard covered benefit in Medicaid, not a standard covered benefit in Medicare. So that's why we're talking about these other pathways like 1115 waivers. And I want to acknowledge before I jump into 1115 waivers that it's not the only pathway, right? There are a number of pathways. I would point you to that toolkit also highlighted by Alyssa that walks through all of the pathways in Medicaid. We hear a lot now about in lieu of services. Home and community-based services have been around for a long time. Value-added services. But the one that's really been sort of in the headlines, right, over the last couple of years has been these Medicaid Section 1115 demonstration waivers. And many of you in the room are probably very familiar with that pathway, either from work in your own state or sort of the broader policy discussion. 1115 waiver demonstrations are pilot or demonstration programs that are proposed by states, approved by CMS, and their goal is really to advance the objectives of the Medicaid program. And they're essentially highly, highly flexible waivers that typically run for 5 years that states use for a whole variety of goals, one of which can be food as medicine, but there are many others, including expanding to reach additional populations in your Medicaid program, additional services, and trying out new delivery and payment models. So I just want to acknowledge that this is a very big pathway that does a lot of things, and the food as medicine incorporation into it is a really important recent trend. And so what did that trend look like? Well, it's really started, I'd say, over the last decade. My colleague, Erica Hansen, led a really nice analysis of this in Health Affairs Scholar that really looked back to 2010 and sort of watched the 1115 waiver landscape and how it evolved since that time. And we really saw back at the start of that timeline some investment in things like nutrition education and then screening and referral to community-based organizations. And then really over the last decade, this real investment into food as medicine, right? The actual provision of food benefits, and in those sort of categories we've talked about a lot today. And so where does that leave us now? Currently, there are 13 states with approved 1115 waivers across the country. There are an additional 3 that are pending before CMS. So Maine, Nevada, DC, we're watching very closely. So we've seen a lot of uptake of these 1115 waivers. And I think there's a couple of reasons for that. One of them is just the highly flexible nature of an 1115 waiver, right? There's an ability to be really expansive or really focused depending on your state goals. There's also an ability to reach across your Medicaid program. Some of the other opportunities in Medicaid are limited to certain portions of Medicaid, like Medicaid managed care. 1115 can really reach broadly. It can also include infrastructure funds, which has been really, really important. As I think any of the community-based organizations in the room can attest that are in states that have these demonstrations, it's been a really valuable part of the 1115 waivers is states have been allowed to include dollars in those waivers to really think about what is the kind of sort of technology and staffing and training that it takes to bring community-based organizations that have been historically operating outside of the healthcare system into the Medicaid program in a really effective way, so they can participate and reach those Medicaid patients. And so that's really where we are right now. We've got 13 waivers, 3 more pending. We'll probably talk in a little bit about some of the policy movement in that space and some of the confusion and uncertainty, but I think I'll hold that off for now.
Okay, hold that thought. Yeah, thank you. So finally, we've talked about we've started with research, we've moved to the federal government, we've moved to discussing about states. Chris, can you talk about food as medicine and how it's growing in communities, and how can we make sure that we continue to include, local and community organizations in this policy?
Will do in just a second. I'm a weird person up here, so I should just explain why I'm here. Like, what is the Heartland Whole Health Institute? And don't worry about that for right now. That's just who pays my salary right now. But the reason I'm here today is that I have been paid by many of you to work on food as medicine. I have been paid alongside many of you to work on food as medicine. I've written papers with a lot of you folks. I've worked for big community-based organizations that are across the country just to figure out, like, how can we do food as medicine in a way that makes sense for the patient, but also for the healthcare world as well. So that's who I am. And so first, I'm not going to answer your question for a second. I'm going to say it's a weird question because we've had this little competition. You've heard people say all day long, like, oh, somebody else said the thing that I was going to say. And I was trying to think of something that no one had said. And this is the one thing I was thinking of, and it's knee injections. And it's because a long time ago, I worked on a project that had to do with knee injections. And people were trying to figure out what was the best way to do knee injections that led to the best outcomes for patients. And nobody ever asked me, how do you keep community-based organizations involved in knee injections? Never came up. Nobody ever said, what about churches? Do you need churches to do knee injections? Nobody ever said that. What about grocery retailers? Nobody ever said that. What about policymakers? Nope. What about CMS? A little bit. But that was about the only one of these organizations that was involved in that conversation. So it makes me stop for just a second and think about the premise of this question. And going back to the very first speaker this morning, the head of the ACS, who talked about the incidence curve. And he was like, we need to bend the incidence curve. Almost nothing that we've talked about today bends the incidence curve. Like almost nothing. A few things here and there. And so what does that mean? It means that we're spending a lot of time trying to help people who are already sick. And that's really important. Phyllis, Khadijah, y'all are awesome. And your time here was like, I learned so much just from listening to you that it was worth the trip all the way from Arkansas just to hear you guys say what you needed to say. And I think that's true for everybody else. But the perfect world would be we reached Phyllis, we reached Khadijah before they needed to be up here on this panel talking about dealing with cancer. So let's rewind all the way back. So that's the premise. So what are we doing? When we look at medically tailored meals, we look at groceries, we look at nutrition education, we're trying to solve problems that are bigger than healthcare. And I think if we're only looking at the lens of like, doctors need to solve this, my insurance company needs to solve this, my health system needs to solve this, we're ignoring the fact that we can't out-educate like all the marketing and all of the school meals like Stephen showed, all of the things that we've experienced our whole lives, that healthcare can't do that. And so I'll say another thing that's not controversial. I told my wife that I was giving up swearing for Lent, and she said that's not how that works, but like it's so I'll just say the way we fund healthcare in the United States is suboptimal because we can't use swear words, right? We spend a lot of money on the things, sometimes we spend more money on the things that need less money and less money on the things that need more money. And so what are we going to do here with this food as medicine problem? I think there's a couple of things that we need to keep doing. I've heard in these spaces, and I'm going to talk about community-based organizations, and I'll try to be quick. One thing we need to keep doing is, like, I hear people say sometimes, like, oh, we're doing all these little pilots and it's not permanent and these waivers are not permanent. And I agree with that. Like, this is not an either or situation, but there's a both and to that, which is a lot of the people in the Khadijah and Phyllis roles all over the country got helped by those pilots and by those waivers and those things that are temporary. And it may be a while till we get all the policy wins that we need. So let's keep those temporary things in place and keep doing that as long as we can. Let's also think a lot about how to share those temporary funds, and hopefully they become big funds, permanent funds, with the community-based organizations that have already been out there trying to deal with some of these big questions. About somebody was talking about food deserts, I think, in the last panel as well in Baltimore. And I think there have been people working on those problems for a long time. Let's make sure we involve them in food as medicine. Let's make sure that we also involve them in this bigger fight and that we all stay in the bigger fight, which is, even if we get all the things covered, like, there's still going to be the Khadijahs and the Phyllises until we start to change these bigger things. And we need those CBO partners, whether it's faith-based organizations, community-based organizations, American Cancer Society groups all over the country, to be engaged in that bigger fight too. So let's not only focus on the money part, which is hugely important, but also those bigger things. So how do we keep those folks engaged? We share the money. There's a lot of ways to make contracting easier if and when money starts to happen. One of Katie's colleagues, Erica Hansen, is working on a paper with another of her colleagues, Rebecca Landauer. I'm like a tiny little piece of that paper. It's going to be brilliant when it comes out. Like, Erica's brilliant. So keep an eye out this summer for a paper that talks about how to do contracting and how to evaluate contracting in states to make sure it's working for everybody. And then so that's sharing the money a little bit, but also sharing the work can be cost effective and good. If we are talking about money, there was a paper that came out. I know Phyllis and Khadijah didn't like the papers. We talk about papers too much. I agree with you. But Seth Berkowitz in North Carolina did a really cool evaluation of their Healthy Opportunities pilot, their 1115 waivers, and showed that their engagement of community-based organizations can be done in a cost-effective way, so that it's not just, well, we're being nice to have these church people and these community-based organization people involved, but actually it's helping improve outcomes that saves money over the near term. It's not even super long term for those states. So that, to me, is the two things that I would try to keep in mind. Let's share the money and let's share the work. Sorry, my hand is sweaty because that was a lot.
That was a lot, but very, very interesting. Thank you. We promise you'll get the mic back. Maybe right. Just kind of wondering, because kind of building on what Chris was saying, just wondering if the rest of the panel wants to kind of respond about thinking outside of the box. And if you had a magic wand, what additional research would you want to see done in this space?
I'll just say one thing about the community-based organization point and MAHA Elevate, which is that one of the exciting things about MAHA Elevate is that community-based organizations can be an eligible applicant. And so this is an opportunity for the very important work that we know takes place at community-based organizations to be recognized as being a critical part of how our Medicare beneficiaries maintain health, become healthier, prevent things. So we do, so that is something that I would definitely highlight. And then I think we also very much agree with Chris's point that our healthcare system, the way that we pay for it at CMMI, we agree that there is a lot of suboptimal things that are happening. And so we are very excited to move forward in this space with non-traditional partners. And so I think that's something that we can definitely put a double click on that.
I think we will go to questions now. If there are any questions for anyone in the room, I know it's the end of the day, but this is not a shy group. So if anybody has any questions, and if not, we will go to questions from the audience. Oh, good. Anyone want to?
So NCI is interested in interventions. Other research as well, and for interventions that are where there's a control group as well as the intervention, and concern about the duration to make sure that there's the dose, to show that there's a difference, and that the studies are powered to see a difference. But it's important that registered dietitians are a part of that process because we're measuring diet quality. We're interested in food and nutrition security as it relates to these food as medicine approaches. So as a registered dietitian, I'm very much, advocating on behalf of including dietitians in the research. And, sometimes you can, we can advise as a funding agency as it relates to make sure that there's community. Sometimes we write in the guidelines that there's community-based organizations are a part of the study, and that you include certain entities. And so it's quite possible that we could do that for dietitians as well.
What I would add to that is, as we think about the way that policy is evolving, one of the big things that I think we've heard referenced is the importance of zeroing in on how do we define these interventions, how do we set up best practices and what they look like. And I did just want to flag that a number of these interventions that are getting supported through things like these Medicaid flexibilities have RDN sort of built into them as a critical component. So a great example of that is medically tailored meals. If you go, FIMIC has a wonderful detailed explanation of exactly what medically tailored meal programming looks like, and RDNs are at the heart of that, as they should be. And the other place that you're seeing this is sort of across some of the interventions. I think we also heard earlier some mentions of the efforts sort of nationally to think about how we reach some sort of consensus definitions. A great example of that is the Coding for Food project that is really focused in on this problem that right now we don't have billing codes to describe many of these interventions. And so that was a collective effort that really put forward proposed billing codes. And in places like medically tailored meals, medically tailored groceries, part of those definitions were building in the role of the RDN. So I think there's a role for RDNs both as an intrinsic part of these services, but also I would say in a number of these efforts too, they're also thinking about what is the work that surrounds these services too. So how does nutrition education and those pieces fit in as well? And are these opportunities also some places to fill in some of the gaps in coverage for those types of things in the RDN role? So I just wanted to flag that I think RDNs are front and center and crucial to this conversation.
this of you, Chris, but I'll kind of do that and kind of throw it out to everybody. Because you all work in different aspects of this. As a patient, as a citizen, as someone who is a Medicare person, what can I do as an individual to help with this effort?
Since you asked me, I'll answer first, and then I'll say a couple things but real quickly. Like what you did today for you personally is what you can do. Like that story about how you had to advocate for yourself, like tell that to everybody. Like tell that to your Congress people, tell that to the people at your clinic, tell that to anybody that wants to hear it, because it's powerful, and it's way more powerful than the papers that we get to write. So number one, I would say that.
Did you want to?
So as I mentioned, we did some message testing work at the beginning of 2025 where we were able to bring in patients to really understand how food is medicine resonated with them. And I think it's even helpful to be in these rooms where we're having conversations about how do we design programs? How do we create these? What are the things that patients want access to be in those rooms and share your story and say, this is what I experience when I visit my primary care doctor. These are the things that I experience when I'm getting a medically tailored meal or produce prescription. So we have the ability to keep maneuvering to make sure that these programs work for the people it actually serves.
Yeah, the only other thing I would add to that, absolutely share stories, but also complete surveys. And a lot of surveys also have like open-ended boxes of, share some additional thoughts. I will say that that's always incredibly helpful from an advocacy organization. We do, go through and review those, and that helps to inform other research that's going on. So continue to be a self-advocate and share your story. That would be great. Yep. Another question? No. Sure.
Yeah, I know we have people that'll be looking at the video later. So between me sitting down and getting up here, you all already kind of touched on a couple points that I wanted to discuss. To Chris's point about us being more proactive as opposed to reactive around messaging and health literacy. So it sounds like we need a lot of buy-in from our powers to be to look into funding. But what we saw during COVID, there was a challenge amongst folks who were representing the medical community and the people that we were trying to reach with just understanding what's accurate. So the misinformation, the disinformation. So part of the question is about what type of opportunities exist, and are we looking to best methods for communicating to people who have no idea about food as medicine, and understand this is, like I said, even for folks who have degrees, because a lot of doctors who are still clueless as it relates to food as medicine. My mom was diagnosed with cancer last year, and as a caregiver, I attended appointments with her, and she wanted to know, should she be eating different? What should she be doing different? And most of the responses were, well, it seems like you're doing good with what you're doing. Keep doing what you're doing. And this is from medical doctors. Well, I know from COVID, we learned that the same message is not going to resonate with everyone. So are we looking at ways to best communicate with the people that we're trying to reach as it relates to patients, but also stakeholders and legislators and powers to be who are going to make the decisions to say, hey, yes, we need to invest over here. And then are we looking at like any type of social media campaigns to step ahead and be proactive about messaging? Because even while I was sitting there today, there was some people making some posts about more disinformation as it relates to cancer and not getting a biopsy because of it spreading. So just being ahead as far as messaging what food as medicine really is, our opportunities exist, and what else can we do as physicians to be able to help?
I think that's a great question. And also just to build on that, I mean, we refer to it as food is medicine. And I think sometimes in the policy world, we get stuck on certain acronyms, CMMI, CMS, 1115 waivers. And how do we kind of get out of the acronym bias and actually talking about programs that are meaningful to people and meet them where they live?
I just wanted to say, like, I think part of what you're saying is like we need more money involved in this. And I think one of the things that we're working a lot on in Arkansas is thinking about employers as the sources for some of that money. I think Athena mentioned earlier, like, we haven't talked a lot about private insurance or employer-based healthcare. There's a lot of incentives for employers to start to care about this. And that translates also into the sort of public concern about when we're handing off our employees to Medicare, like, it makes Medicare a whole lot more fiscally healthy and exciting if those people are healthier at the point of handoff. So I think that's, as you're telling your stories and as you're thinking about like who are some other folks to get to the table, I think employers are a big one.
Yeah, absolutely. I think really what you're bringing out, Chris, right, is that we need to think about like who are our key messengers, right? And I think we're starting to get down that road. You heard earlier about the work being done in terms of medical school education. That's really encouraging to see medical schools buying in. As we heard in that description, of course, the idea here is not to replace those other really key messengers like RDNs, but let's make sure that the conduits who can get people there know to do that and when. And I think doctors are a great start, but I also think there are other really important trusted messengers that we can start to think about in this space. So for example, when I'm taking off my food as medicine hat, I do a lot of work around patient navigation in cancer with the ACS National Navigation Roundtable. And navigators, a navigator at the end of the day is a problem solver, and they are so, so important to the patient experience. And so I also want us to start thinking about like, how are we making sure those individuals who are touching patients when they're in an incredibly vulnerable moment of their lives and need help to understand what resources are available to them to get to them quickly so you don't have to be knocking down doors and things. And so I think we need to make sure those individuals as well, individuals like navigators, community health workers, and others also feel really well equipped on what's available in this space, what referrals they can be making, what resources exist in their institution, because again, they're a really trusted voice for people who could really benefit from these services.
That's such a great point. Thank you so much. And last question of the day. I'll even hand you the mic.
Thank you so much. Erin Hennessy from Tufts University Freeman School of Nutrition Science and Policy. First, just want to say thank you to everybody who's been a part of this day. It's been wonderful. This might exist, and so I might be ignorant in asking this question, but I'll ask it anyways. We've heard a lot that we need more research and have more research, we need more funding, and I'm really curious how coordinated the funders are in this space. And I think back to my prior life when I worked at NIH, and I was fortunate enough to be a part of the National Collaborative for Childhood Obesity Research, which brought together four of the largest funders in obesity research. And it really had an amplifying effect and still has a really important role in that space. And just kind of curious how much, we need ACS to fund what they want to fund and AHA to fund what they want to fund and NIH. But it seems like perhaps there is a moment. I know Nick earlier talked about agency-wide, but there's a lot of people who are part of this table and would love to hear more about how funders are connecting to really make sure the ecosystem is actually a system and not just an elephant that we're all just touching the parts of.
Such a great question, and such a great last question too, because I think it kind of ties together everything that's been said today in terms of, how do we make sure that we are efficient stewards of the research dollars, and how do we make sure that we are supporting the programs that need to be supported? So just wondering if any of the panelists have any thoughts?
I think that's a great question. And as a food as medicine funder, I'm happy to talk about how we're thinking about it from, the private sector. So the Rockefeller Foundation has a relationship with all of the major food as medicine funders in the space. We do a lot of work and meet quarterly to talk about the research that is underway in the food as medicine space. and we oftentimes put our money together to fund things. For everyone's awareness, I would just say on January 15th, we announced the Food is Medicine Impact Fund, which is a joint initiative between the Rockefeller Foundation and Builder Vision to come together and put our dollars into a pot to fund very specific food is medicine activities around awareness, around giving states capacity, and hopefully as the fund expands, as we continue to get other funders into this pool into other areas around food is medicine. We also do a lot of work to educate and share our knowledge around food is medicine with public funders. We build these relationships to say, hey, AHA is doing this, Tufts is doing this, you should buy into this. So I think we spend a lot of our time and our energy and our resources trying to create the system where we are talking to other funders and we're getting dollars invested into the spaces that they should be in.
What a great way to end the panel. Thank you so much. Please, everyone, thank our last panel. Thank you. Mic drop.
Literal mic drop. We're a little at the end of our day and a little over time, but I wanted to say a couple things in closing. Let me introduce myself first. I'm Laura Makaroff. I'm family medicine physician, lifestyle medicine certified also, and I have the pleasure of leading our prevention and survivorship team at the American Cancer Society, which includes Kristen, Christina, and Nicole in the planning group for this meeting. So thank you all for making the trip, whether you're here in person and braved like a very interesting weather day here in DC. If you saw me when I walked in this morning, you would have felt bad for me because I walked in the moment of like maybe the most rain of the whole day for some reason. So I was pretty wet, but it's been great to be here. It's clearing up. And thank you for everybody who's joined us online today. So a couple of things. I just want to say 3 quick things in closing. Again, I've had a mentor who said, like, any day you learn something new is a great day. And I have learned so many things today, and I've heard that from a lot of you, and I think we've all learned so much. So let me say thank you for contributing to a really great day. And let's just give one more round of applause and thank you to all of our panelists who've shared with us today. The second thing I wanted to say is just to really vocally say at the end of our day here that our commitment at the American Cancer Society in this space is real. I think you see the strength of our group that's here. So we've got people from our research side, our discovery shop like Marissa and Robin. You heard Anna and Katie McMahon is here, and Emily from our ACS CAN side, and then Kristen, me, Nicole, Christina, and others from our state teams, Lee, and I think I saw someone over here from our state teams at ACS in our patient support programming side. That, and then we had Shane and Arif and Lisa here this morning, who are our executive team members from the American Cancer Society. All of that to say that we've been working and wanting to work to end cancer as we know it for everyone, recognizing that food and food as medicine is such an important part of that. We are all exposed to so many different things in our daily lives, including food. Food is important for nutrition, of course, but food is also so important for community, for connection. We heard about all of that today. So thank you for being our partners in this work. We look forward to continuing to work with you to advance this field, to recognize that we're maybe on the very leading edge of food as medicine in cancer care, which includes both after a diagnosis and to help people survive and thrive with and after a diagnosis, as well as on the true prevention side and recognizing that, if you look at the data, more than 40%, maybe up to a half of cancers are connected to a modifiable risk factor, which includes food, the environment. Thank you, Dr. Chen, for all of that. And so many other modifiable risk factors that we can help people with. So my last thing I wanted to say, another thank you to our second to last panel and our volunteers and patients, Khadija and Phyllis. Thank you again. It really means a lot to hear from patients and people like yourselves, and we all took away so much from that.
Shane started the morning talking about our why, and I think there really is nothing more powerful than having the why in the room. And so we really, really appreciate you taking time to get out on this very unusual weather day and to make the trip. I think you've all made a trip in here, so we thank you for that, and thank you again for who you are, and we really appreciate you. So thanks again, everybody. Safe travels home, and we'll see you again soon, hopefully in a year or year and a half, and we can do this again.